We are live and you can start. Dr. Sandeep, please unmute and start.
Hello.
Dr. Sandeep, you can start.
Okay. Good morning. Good morning, all the faculty members and also the delegates. Today, we are going to start our session with an pandemic issue which is going on, that is COVID-19 and us. I would like to welcome the chairpersons, Dr. N. Ramesh sir and also Dr. K. Udayakaran sir to chair the session.
Thank you.
Dr. N. Ramesh sir is the chief surgeon now working in the railway hospital in South Central Railways, and he worked as an NBA examiner in 2019 and served as a state and central council member and vice president for the TSID event. And rightly, he is mainly interested in the work regarding contact dermatosis in railway locomotive workshops. I welcome the other chairperson, Dr. K. Udayakaran sir, to chair the session. He is a former WHO and NLEP district consultant in the 5 years span, and he is an author of chapter in the IVDL textbook of dermatology and published several papers in the international journal with 100 citations. Thanking you, sir. With this, with this proceed the chairperson to continue the session.
Thank you, Dr. Sandeep. Good morning to all the delegates. We'll start this morning's special session for about 45 minutes. We have 3 speakers, 15 minutes each. So the first topic would be dealt by renowned and celebrated dermatologist of Telangana state, Dr. Putta Srinivas. Dr. Putta Srinivas is a life member for over 3 decades of IIDVL, and he's got tremendous teaching experience of over 32 years. And he has been HOD of the Department of OMC for quite some time. And he has been on the committee, National IIDVL Committee on Therapeutic Guidelines for Treatment for Vitiligo. And he has edited Medical Ethics and CPA for IIDVL textbook. He also contributed 3 other chapters for IIDVL book, one on medical legal aspects of dermatology and plastic surgery, the other on leprosy in the IIDVL textbook of dermatology, and the third one was he has contributed 3 chapters in the book called Practice Management. He has been again a very reputed invited speaker in many national and international conferences, and he has been the former member of the Medical Council of India and Ethics Committee and PG Committee of Medical Council of India. As you know, he has been the former principal of Osmania Medical College, Hyderabad, and been a director of medical education in Telangana, and been director GMC and Government General Hospital, Mahabubnagar at present. So I welcome Dr. Putta Srinivas sir. He will be dealing with a very new topic of dermatology, being in the under the present pandemic circumstances. The coronavirus being basically primarily a respiratory infection. So very little is known about its dermatology manifestations. So Dr. Putta has a challenge cut out for him. He has to review the Jaundice is a manifestation based on so many, very few reports internationally and nationally. I now request Dr. Putta Srinivas to start his presentation. Thank you.
అన్మ్యూట్ డాక్టర్ పుట్టా శ్రీనివాస్ గారు
Sir.
అన్మ్యూట్ చేసుకోండి.
You have to unmute, sir. You're not audible. Someone has to inform him.
Dr. Srinivas, we can't hear you.
I'm just trying 1 minute.
Oh,
Yeah,
wait,
you're
it's
okay
clear
now.
now. It's clear now, sir.
ఓకే
Can you hear me?
Yes, sir.
Yeah. It's the screen share. Can the share the screen is shared?
Yes, sir.
Yes.
Full screen, please.
Yeah. Good morning to all of you. Thank you very much, Dr. Sandeep, for your kind introduction. And my sincere thanks to Dr. Uday Kiran, the senior most member of IIDVL Telangana State, and Dr. N. Ramesh, the president-elect for TSRU 2022. And I also sincerely thank the president, Dr. Pavitra Mani Patale, secretary, Dr. Aruna Samars, Dr. Kavita, the treasurer, and the most crucial scientific chairperson, Dr. Rajesh Mir, for giving me the opportunity. So I'll be briefly talking about skin manifestation of COVID-19. We all know that last 1 year has seen the world what was not seen last century. This COVID-19 is affecting every one of us in all marks of life and affecting all the countries, states, families, and societies in all aspects of life, including economy also. So under these circumstances, as rightly said by Dr. Sandeep, it was basically respiratory disease. But now, for last 1 year, there's so many case studies and analysis of scientific nature have evolved and produced. Coming to that, we have skin manifestations too. So skin manifestations are seen very commonly now among COVID-19 patients, but it varies. There is variation from 0.2% in China to 20 to 80% in Italy. But now it's well established that the skin manifestations are quite common, and we can also predict which type of skin manifestation will have good prognosis, which will have little bad prognosis. So these manifestations are common in all age groups, and identification of skin manifestations, it helps a lot, particularly in early diagnosis, early treatment, and better prognosis, and also to prevent the infection. If you diagnose early, you can prevent the infection spreading to others. So though we all know COVID-19 enters into cells through ACE2 inhibitors, and sorry, ACE2 receptors. ACE2 receptors are located in all parts of the body. Then highest concentration in small intestine, testes, kidneys, heart, thyroid, and adipose tissue. The concentration of receptors are medium in the lungs, colon, liver, bladder, adrenal glands, but they're lowest in blood, bone marrow, spleen, blood vessels, and muscles. So location of, the concentration of ACE2 receptors is very critical for the entry of COVID-19 virus. In the skin, these ACE2 receptors are located in the basal cell layer of epidermis and also in the hair follicles. And there are 6 types of dermatological patterns that are described. There are 6 varieties of patterns in which COVID-19 can manifest. I'll tell briefly about that. These 6 patterns are, the first is maculopapular and morbilliform lesions. The second is urticarial lesions. Then chilblain-like lesions like COVID toes, pseudochilblain, but probably known as COVID toes. Then vesicular lesions, then petechiae and purpuric lesions, then livedoid eruption. Other than these 6 patterns, there is one more entity called as multi-system inflammatory syndrome in children, In addition, under these COVID times, PPE kits are mandatory. So PPE-associated skin damage is also seen nowadays. If we carefully observe, the skin manifestations are usually observed in the first 10 days. This is very important. In the first 10 days, we see skin manifestation like skin rash, pruritus, and all these things. At the same time, what we have to notice that these eruptions are evolved before the onset of fever and diarrhea. You see, skin manifestations are here in the first 10 days, whereas first week itself, whereas the fever and cough other develop after 1 week. The skin manifestations also manifest before RT-PCR becomes positive. This is very important. So skin manifestation, if we can diagnose early, we can advise RT-PCR and then predict the course of the disease and also guide the patient. Maculopapular eruptions are common among all the other skin eruptions. They range variously from 5 to 70%. These eruptions are common in the middle age and elderly, associated with itching majority of the cases. And these eruptions are common, evolve along with the symptoms, but they may precede also. How long they last? They last usually 8 to 11 days. But in small group of patients, this maculopapular eruption may evolve at a later stage also. But what is most significant is maculopapular eruptions are associated with greater severity of the COVID infection. This is important. They have associated with greater severity of COVID infections, so much so that 2% mortality rate is observed in COVID-19 positive patients who present with maculopapular lesions. Histopathological, there will be early onset. In the early onset lesion, there will be epidermal spongiosis, perivascular lymphocyte infiltrate with eosinophils. In late stages, there will be perivascular lymphocyte infiltrate along with histiocytes and collagen fibers. This eruption is mainly supposed to be due to cytokine storm instigating hyperactive immune system and producing maculopapular rash. So here you can see clinical pictures. You can see the maculopapular lesions on the thighs. Some of them are perifollicular, diffuse erythema on the cheeks with papular lesions, and the upper part of the chest of the same girl. You can see in a woman on the upper part of the chest as well as the abdomen. In middle-aged man, you can see on the entire back, it's covered in the pressure areas, maculopapular lesions is in the forearm. So these are typical maculopapular lesions in case of COVID-19 positive patients. The second variant is urticarial pattern. Urticarial lesions are quite common in these patients, but commonly seen in middle-aged patients. These urticarial lesions are distributed mainly on the trunk or limbs. Sometimes face may be involved in generalized manner, and urticaria will be usually manifest itself in COVID along with the other systemic symptoms like fever, cough, and other symptoms. But sometimes this urticaria manifests even before the onset of systemic symptoms. This is important. 92% of the patients who have urticaria in COVID-19 indicates that they are likely to have more severe COVID symptoms. So urticaria is an indication of severe COVID symptoms, and the reason being that a cytokine storm involving the skin. You can see in this clinical picture the urticarial lesions on the buttocks and the upper part of the thigh and the lateral surface. You can see on the neck and upper part of the chest and the forearm here. You can see on the waist here, and here urticarial wheals we can see on the face and also on the face and the neck also. In the histopathologically, we can see here mild edema and perivascular lymphocyte infiltration, and dilated blood vessels is seen in histopathologically in the upper dermis. This is another picture showing the same patient having urticaria of the face with mild angioedema, again subsiding after 15 days. Third is chilblain-like lesions, very popularly known as COVID toes. Usually, we see chilblains with cold temperature and damp humid conditions. But in COVID-19 patients without exposure to cold, patients will manifest chilblain-like lesions. There will be swelling and discoloration of extremities, fingers and toes, manifested by erythematous biliaceous papules macules, and nodules. These chilblain-like lesions are seen in 14.3% to 72% of the COVID-19 patients. They are common in adolescents and young adults, and the onset is usually after the other symptoms of COVID. These chilblain-like lesions last for 1 to 2 weeks, and they are associated with mild COVID infection. Histopathologically, there will be focal vascular degeneration of the basal cell layer, perivascular lymphocyte dermis, perivascular neutrophilic infiltration with inflamed edema endothelium is also seen in these cases. These are clinical pictures showing various patients having COVID-19. You can see the toes here. Chilblain lesion with erythematous papules and nodules, and some of them are violation lesions on the fingers here. On the fingers here, you can see chilblain-like lesions on the toes here. You can see on the heel also, on the heel, and here on the heel, and the toes. These are the clinical features of the chilblain-like or COVID toes, what we commonly know. Histopathologically, dense superficial and deep perivascular infiltration of lymphocytes, very appendageal also, and extravasation of RBCs. You can see in this picture, extravasation of RBCs and our focal thrombosis of the blood vessels also seen. So COVID toes, you can see the distal part of the toes of the left foot and also both feet here presented with macules, nodules, erythematous papules. Next is vesicular lesions. They're not very common compared to urticarial or maculopapular lesions, but they are vary from 3.77% to 15%. They're common in middle age. Itching is seen in majority of these cases. The common site being the trunk, but the extremes also can be involved. These vesicular lesions, which are seen in most of the viral conditions, exanthemas, will be polymorphic in majority of these cases in diffuse pattern. They're polymorphic in majority of the cases. But in few 25% of the cases, they're monomorphic and maybe localized partially. Sometimes they appear along with other symptoms. And the studies in Spain have shown that they appear along with same time as COVID symptoms, whereas Italian studies have shown that vesicular lesions may appear at a later stage also. They last for 8 to 10 days. Vesicular lesions in COVID-19 patients indicate that there is a likely to be moderate severity of the COVID-19 infection. Histopathology will show intra-abdominal vesicles, mild acanthosis, burgeoning of keratinocytes, basket view hyperkeratosis, atrophic epidermis, degeneration of basal cell layer, multinucleate hyperchromatic keratinocytes, and sclerotic cells.
Sir, 2 more minutes, sir.
Oh, I'll just finish fast. And this is the picture showing all the vesicles and other pictures on the back, trunk, and other areas. Now this is the macular vesicles and the trunk. Then petechiae and purple lesions are also reported in 3% of the patients. They diffuse, commonly looking at external parts of the limbs, and they appear on onset of the COVID symptoms. They indicate greater severity of the infections, particularly in purple indicate greater severity. You can see purple lesions here on the abdomen, on the knees, and the legs here, and the hand. This is extravasation of blood vessels and RBCs in the blood vessels and the lymphocyte infiltration. The liver eruption is a transient and persistent eruption we see, rectal fashion, least common among 6% only, mainly in the trunk, flagella spreads to the dorsal of the hands and feet. And most important is these liver eruptions are have high mortality indication. So they indicate a high mortality, particularly up to 10%, and they get risk of abnormalities. So there will be prolongation of D-dimer, high level of D-dimers, and high prolonged proton time will be seen in these cases. Then these liver lesions on the buttocks and on the legs. Then 2 more minutes. Multisystem inflammatory syndrome in children, commonly seen, which was not supposed to be there in Chinese cases, but in the late report in UK, a lot of cases are coming. They have an overlap of Kawasaki disease-like picture as well as toxic shock syndrome. Common in elder children, unlike regular Kawasaki we see below 5 years. This is in older children and adolescents also. And with the fever and other symptoms, but most important is the GA symptoms dominate in this type of MIC syndrome. You can see clinical pictures showing on the abdomen, rash on the abdomen, and the palms, and the trunk, and the chest and upper back, abdomen, that part of chest also. The PP associated kits are common, we all see, very common in 42% of cases. Particularly bridge of the nose is involved and gloves can cause contact dermatitis. The main reasons are moisture-related damage to skin, skin tearing and heavy sweating. Wearing for more than 4 hours can cause this. So this you can see N95 mask and the clip here causing the pressure, here causing skin lesions. You can see rash on the forehead because of mask here also on the forehead. This is dermatitis because the latest, this is latest dermatitis because of the gloves. So take home message is, dermatologic manifestations are well described in COVID infections. They may precede before systemic symptoms appear, even before RT-PCR becomes positive. Maculopapular eruptions are the most common. Most maculopapular eruptions are most common. In addition, arterial, petechial, livedoid lesions are associated with severe infections of COVID-19. They indicate severe infection. Livedoid lesions are least common but are associated with high mortality of 10%. They have high D-dimer levels and prolonged reaction of prothalamic time. Chilblain and vascular lesions are associated with mild and moderate infections. Multi-system inflammatory syndrome have features of causative disease but can have overlap of toxic shock syndrome, but they have more of GAD symptoms. PP-associated damages are common in doctors, nurses, other medical personnel. The treatment of PTN lesions is mainly asymptomatic treatment, whereas the treatment of PP-induced rashes will be wearing proper fitting PPEs, application of moisturizing creams and gels. These are the references. Thank you very much for the patient listening.
Thank you. Thank you, Dr. Putta Srinivas garu, for your
Thank you.
For your comprehensive and lucid presentation on this new topic. So your take-home messages from your presentation are, as I said, urticaria. When we see cases with urticaria, the treating physicians should be alerted because it might lead to, if not properly intervened effectively in time, it might lead to cytokine storm, which has a very critical, strategically, it contributes to the high mortality that we are finding in present day COVID hospitals. So apart from that, other cutaneous manifestations, early onset, before the actually classical fever and cough or dryness, respiratory symptoms could arise, the early subtle changes in the skin can bring to the notice of a dermatologist, or then he can be isolated. The crux of the issue is the public health aspect can be controlled. The spread of the infection can be stalled once we identify these kind of early lesions. Before rapid antigen tests could be made widely available in some remote areas and all. Clinicians, when they are very alert, they can make out these skin changes and isolate such patients so that the community spread can be controlled. So very useful presentation, sir, you have made. Thank you very much.
Thank you very much.
The next speaker is Dr. K. Sagar, and he is a Gandhiite, and he is a senior resident right now in Government General Hospital, Islamabad, and he has already made some interesting publications called Concurrent Multiple STIs in HIV-infected patients in 2019. So, and he will be speaking on teledermatology, which is a new, recently widely being practiced widely, and particularly we are forced to resort to this mode of consultation because of the pandemic. Dr. Sagar, go ahead with your presentation.
Morning, sir. Hello. Dr. Sandeep, can you hear me?
Yes, Dr. Sagar, you are audible.
Sir, can I share my screen?
Yes, go ahead. You share your screen.
Okay, sir, it's saying somebody else is sharing the screen, so please.
The administrator has to remove the CV slide of Dr. K. Sagar.
Dr. Sandeep, allow Dr. K. Sagar to share his slides. Dr. Sagar, you can share your slides now.
Okay, sir. Is it visible, sir?
Go ahead.
Okay. Good morning, everyone. I am Dr. K. Sagar. Firstly, I'd like to thank all my teachers and seniors for giving me this opportunity. So today's topic is teledermatology. Coming to the definition, teledermatology is the use of electronic information and communications technologies to provide and support healthcare when the distance separates the participants. So it is used to diagnose, treat, monitor, prevent, to do research and educate over a distance. The term teledermatology was introduced by Douglas A. Perednia and Nancy A. Brown. There is WHO definition of teledermatology, which says the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of diseases and injuries, to do research and evaluation, and for continuing the education of healthcare providers, all in the interest of advancing the healthcare of individuals and their communities. So as dermatology is one of the most visually dependent specialties, this is particularly suited for telemedicine. The technological development has enabled clinicians to care for diverse patient populations who are in need of skin expertise without increasing their overhead costs. So the scope and purpose of teledermatology. This practice reduces multiple in-person follow-up visits and thereby benefits the elderly and those coming from far-off places. And hence it saves cost and time and also allows for faster delivery of care, and this reduces waiting time. So what are the systems and tools required for teledermatology? The hardware, software, connectivity, and centers. Coming to the hardware, it requires a basic telemedicine platform, servers, clinical devices, video conferencing units, communication hardware, and power support. The software required are operating systems, licensed telemedicine software, appropriate user interface, and backend database. Connectivity, the VSAT, PSTN, ISDN, or satellite communication modules, and also internet communication modules like wireless LAN or wide area networks. There are two types of centers for teledermatology. The first is telemedicine consultation center, and the second is telemedicine specialty center. In telemedicine consultation center, the patient is present and there is also equipment for scanning, converting, transformation, communication of medical information, and it usually has a general practitioner or a registered medical practitioner in remote areas who communicates with the telemedicine specialty center. In the specialty center, the specialist is present. The specialist interacts with the patient who is present in remote area and views his reports and monitors his progress. The specialty center is generally located in a specialty or a super specialty hospital. What are the types of teledermatology? First is primary. This refers to the direct communication between the patient or with the general practitioner or a nurse or a specialist. This provides a direct service for initial diagnosis or for a referral. The secondary teledermatology is indirect communication between the patient and the specialist. Example, if a patient with a skin lesion goes to a general practitioner, the practitioner in turn refers the patient to a dermatologist. There are other possible intermediaries like healthcare insurance companies and healthcare institutions. Coming to tertiary dermatology, this is a second opinion among the specialists. It is a specialist to specialist consultation. For example, a dermatologist to other dermatologists or a dermatologist to a pathologist. There are certain models for teledermatology. The first is store and forward technique, SAF. This is most widely used one. It involves taking pictures and making videos of the skin lesions of the patient, which are then assessed by a specialist dermatologist who is in a different time and place. There is no direct interaction between the patient and the physician, hence this is relatively inexpensive. This is particularly suited for patients with poor access to healthcare, as there is no need for coordinating visits. This might be used across different time zones and interferes less with the daily workflow of the physicians. This method does not depend on internet connection speed, but very high resolution of images is needed. Might, however, require a repeat consultation if the clinical data and history are incomplete. Coming to second mode, that is real-time dermatology. This involves video conferencing for interaction between the patient and the dermatologist. This enables verifying medical history of the patient and giving immediate advice. And this method is convenient for both the patient and the physician, as there is exchange of information from both sides and the physician can clarify the aspects of concern. This saves the time, as there is no need for repeating the same consultation. But on the downside, this might be expensive because of the technical issues involved, and this might interfere with the physician's daily schedules. There is a third mode called hybrid mode. This involves combination of the above two methods. In the current era of mobile messenger apps like WhatsApp, still images and videos are stored and forwarded. This has emerged as a widely used medium for teledermatology practice. So the practice guidelines for teledermatology as laid down by the Government of India. There are 7 aspects: the context, identification, mode of communication, consent, type of consultation, patient evaluation, and patient management. Coming to the context, the practitioner should decide whether the telemedicine consultation is appropriate in a given situation or an in-person consultation is needed. He should consider the mode and technologies available and their adequacy. The practitioner should be reasonably comfortable that the telemedicine is in the patient's best interest and shall uphold the same standard of care as an in-person consultation, but within the intrinsic limits of telemedicine. Identification, which is most important. Telemedicine consultation should not be anonymous. Both the patient and the practitioner should know each other's identity. The practitioner should identify and confirm the patient's identity by name, age, address, email ID, phone number, etc. If a patient is a minor, then consultation is done along with an adult whose identity should be verified. And the practitioner should display his MCI registration number on prescriptions, websites, electronic communication modes like WhatsApp, email, and receipts. The modes, like I said, there are 3 primary modes: video, audio, and text. So the physician should use his best judgment to decide which he has to go for. Patient consent, the most important thing. If the patient himself initiates a telemedicine consultation, then the consent is implied. An explicit patient consent is needed if a healthcare worker initiates a telemedicine consultation. In such cases, explicit consent should be recorded, like the patient can send an email or a text message or audio or video message. The patient can state the intentions on phone or video with simple language like, yes, I consent to avail consultation via telemedicine. And this has to be recorded in patient's records. The exchange of information. Clinical history, examination findings, investigation reports, and past records all should be gathered. If the physician feels that the information received is inadequate, request should be done for additional information. And if a physical examination is mandatory, never proceed until a physical examination can be arranged through an in-person consultation. The practitioner shall maintain all patient records, including case history, investigation reports, images, etc. The types of consultation. What is first consultation? If the patient is consulting the practitioner for the first time, or the patient has consulted the practitioner earlier, but more than 6 months have passed since the previous consultation, or the patient has consulted the practitioner earlier, but for a different health condition. And the next is follow-up consult. If the patient is consulting the same practitioner within 6 months of previous in-person consultation and for the continuation of same health care for the same health condition. So, however, it will not be considered a follow-up if there are new symptoms that are not in the spectrum of the previous health condition, or if the practitioner cannot recall the context of previous treatment and advice. This cannot be considered a follow-up consultation. So the patient management. If the condition of the patient can be appropriately managed via telemedicine, then the practitioner may proceed with a professional judgment, either to provide health education, to provide counseling, or to prescribe medicines. So health education. The practitioner may impart health promotion and disease prevention messages like those related to diet, physical activity, smoking cessation, food restrictions, home physiotherapy, etc. Advice can be given regarding investigations to be carried out before the next consultation. Prescribing medicines, most important thing. Prescribing medicines via telemedicine should be done only when the practitioner is satisfied with adequate clinical data and the prescribed medicines are in the best interest of the patient. So prescribing medicines without appropriate diagnosis will amount to professional misconduct. And there are certain limitations for prescribing medicines via telemedicine. And these categories are given by the central government from time to time. There are 4 lists. List O, this comprises of medicines which are safe to be prescribed through any mode of teleconsultation. List A comprises of medicines that can be prescribed during the first consultation, which should be a video consultation. And the list also contains other drugs which are follow-up medications used for chronic illnesses like diabetes and hypertension.
Sagar, 2 more minutes.
Okay. And there is list B. These drugs are prescribed in addition to those which have been given during in-person consultation. And there is prohibited list, for example, which has high potential of abuse and Schedule X drugs. This is the list given by the Government of India. And this is the matrix. Mobile teledermatology, which is more popular nowadays. This represents the transmission of images via mobile phones. The motion and still images can be transferred. Advanced network technologies and Android technology has revolutionized mobile teledermatology. Teledermatology and education. It plays a pivotal role in education, resident training, exchange of knowledge between dermatologists, and learning of different diseases from different parts of the world. WhatsApp groups has made it possible to discuss various diseases and their management. It is one of the easiest and safest media. Teledermatology and diagnostic agreement. Many systematic reviews have shown that there is a good diagnostic agreement between teledermatology diagnosis and face-to-face consultation. The diagnosis concordance is ranging between 92 to 98%. Indian perspective of telemedicine. The remote areas still have the scarcity of dermatologists and limited means of communication. So increasing population in India are treated for skin diseases without ever seeing a dermatologist. So teledermatology in India has huge potential. This can be included in national programs like leprosy and leishmaniasis. So increased collaboration between dermatologists and primary health providers is needed. But there are a lot of unresolved issues which need standardization, and there is Indian Society of Teledermatology, and this is their website. Limitations. Clinical. The accuracy of teledermatology might be disputed in certain diseases like psoriasis, atopic dermatitis, etc. It does not allow palpation, which is very critical in certain clinical disorders. Some conditions are not perfectly suited for store and forward model of teledermatology, like cases where full body examinations are needed, lesions located in hair-bearing areas, patients requiring in-person counseling. Economic. The most frequent challenging is obtaining reimbursement. So the teledermatologist might not be reimbursed properly or reimbursed at a lower rate in comparison with in-person visits. Technological. Poor image quality, expensive, inefficient software, and smartphone captured images which are of inferior quality, and lack of formal photography training for healthcare providers. Legal. The main concern is security of patient's information, so which is transmitted electronically. Patients should be properly informed who will have access and how the information is stored along with all its benefits. Ethical. Physicians express concerns that this would promote a technology center rather than a patient-centric model. They also report the fear that variety of advances will depersonalize the medical consultations. So there are certain situations where dermatologists might choose not to offer teledermatology, like atypical unusual presentations, non-specific presentations, varied morphology, skin tumors where palpation is needed, SGS, TEM, rare diseases like genodermatosis, and symptomatic presentations without any obvious lesions, and clinical entities due to varied etiologies like leg ulcers. In such case, initial face-to-face examination needs to be performed, then teledermatology practice can be employed. In COVID-19 pandemic, this can be very useful. There are certain guidelines for technology platforms laid by the Board of Governors of MCI along with NITI Aayog.
Dr. Sagar, can you make it fast?
Yeah, 1 minute, please. Teledermatology and artificial intelligence. This is going to the future. There is a mobile application which is linked to a diagnostic database which analyzes and delivers the probabilities of DDs or diagnosis of DDs. So this machine analysis can be supported by human dermatology experts later on. The current accuracy of an app is reasonably good, which is developed by AIMS. Sensitivity and specificity are around 80 to 50%. but it is not entirely accurate to rely on artificial intelligence-driven images. So, teledermatology and law, there is no definite legislation. So all the laws which apply to medicine and IT will automatically apply to telemedicine. All the prescriptions should be duly signed by the medical practitioner, and the physician is responsible for the issues related to security, privacy, and confidentiality of patient data. Always use a disclaimer. The medical opinion is only based on records available without direct contact with the patient, and hence this advice is only to guide the referring doctor and cannot equate face-to-face consultation. This is the sample prescription format given by the Government of India for telemedicine practice. As Dr. Annie Burdick aptly said, the teledermatology train is coming. Get on board, get out of the way, or get run over. These are my references. Thank you.
Thank you, Dr. K. Sagar, for your comprehensive presentation on telemedicine, teledermatology. As we know that it is still taking wings in medical, Indian scenario. A lot of issues are there to be clarified, ethical, moral, legal issues, particularly as you said, the reimbursement fees aspect also. So let's hope due course of time, the Indian population gets used to taking advantage of this new modality of medical treatment, which is actually popular in developed countries. Thank you once again, Dr. K. Sagar.
Thank you, sir.
I request Dr. Uday Kiran to introduce the next speaker, next topic, please.
Okay, sir. Now, it's my pleasure to invite for the next topic Dr. Vaggu Anand Kumar, eminent dermatologist, and has done a lot of good work. He will be speaking on dermatology practice present scenario. I invite him for this presentation.
Yeah. Oh, thank you, sir. Good morning. Good morning, everyone. Good morning to chairpersons. Are you able to hear me, sir?
Sharing your screen.
Hello.
We can hear,
yeah.
sir.
We can hear you.
Yeah. Sandeep is sharing my screen.
Right.
Sandeep. Sandeep, what happened? Hello.
Yes, sir. I'm sharing.
Sandeep, what happened? It's not sharing.
Okay, 1 minute. My sharing is actually paused, sir. You have to ask the technique.
Oh. Okay.
Sandeep, did you download the PPT and then?
I have downloaded, and right now it's on my tab only, sir. I haven't shared them.
It's not coming.
No, you have to share with laptop.
Yeah,
Sandeep,
laptop.
I also sharing from iPad only, but it's not able to share. So that is the reason I sent to you to share through laptop.
1 minute. I'm resuming, but it's not showing.
Anand, have you already sent it to the administrator before? Your PPT?
No, I
Have you
sent to
sent?
Sandeep only, sir.
Okay.
Can you
Sandeep,
Shall I present, sir?
I'm there, sir. I have already created all the my desktop, sir.
we'll ask Mintu to look into it. Meantime, you can start saying.
Sir, I will. No problem, sir. Don't waste the time. I will present it. No issue.
Yes, you can start.
Yeah. Though there is no screen sharing, but I can present it. See, on 11th March, WHO declared. Hello. So, sir, can I go ahead?
Yes, you can start, Anand.
Though there is no screen sharing, but I can effectively, I hope I will present it. On 11th March 2020, WHO declared coronavirus
Sorry,
as a
sir.
pandemic.
Dr. Sandeep, can you share your screen?
I'm sharing, sir,
Yes,
but there is a technical issue.
Okay, can you send it to me?
Okay, sure. Mail ID?
I'll send you in the system.
Meantime, Anand, you can continue.
Yeah, I will continue it. And recently, IMA on September, IMA's Indian Medical Association says that at least 515 doctors in India has died of COVID-19. So the practice of dermatology was not exempt from this global issue. So the roots, as we know, the roots of transmissions are basically the respiratory droplets and also contact with the contaminated fomites. As we all know, the air and environmental contamination caused by COVID-19 is very, very established, and it was in Korean literature also. They isolated from the hospital environment like beds, air-conditioned vents, bed rails, bedside lockers, and toilets also. As we all know that there are basically respiratory aerosols. It's a two one. One is the droplets and is the aerosols. Aerosols are less than 5 micrometer in size, and droplets are more than 5 micrometer size. 5 micrometer in size, and those who are more than 5 micrometers in size, these called droplets because of the gravity. They are settled down to the ground very quickly. So droplet transmission requires close physical proximity between the infected individual and a susceptible individual. On the contrary, aerosol droplets, because they are very small particles, they evaporated very easily and low settling velocity, so they may remain in the air for longer time and travel further before they can enter the respiratory tract or contaminate surfaces. The median off-life of the SARS-CoV-2 is 2.7 hours in the aerosols, 5.6 hours in the stainless steel, 6.8 hours in the plastic, with viable virus still being detectable on steel and plastic for up to 72 hours. At room temperature, the virus can remain viable from 2 hours to 9 days. So that means the virus can survive on medical instruments and also equipment of other significant and also other equipment for significant period of time. And comes to the transmission from the symptomatic, asymptomatic. So virus not only from the symptomatic individual, it can also transmit from the asymptomatic individuals and also from pre-symptomatic period. It is very, very established in the literature that in one study, Hugh et al. Reported 24 asymptomatic infected persons in whom chest scanning revealed ground glass opacities or patchy shadowing in 50% of the cases. In another study, 55 patients with asymptomatic infection, 2/3 of whom had evidence of pneumonia as revealed by CT scanning. That means the asymptomatic patients are very, very significant for the transmission of the disease, because we are the dermatologists, and not only we dermatologists, most of the healthcare workers are exposed to this asymptomatic or in pre-symptomatic period of the disease. If you see as we know, the incubation period is up to 14 days, but average is a 5.2 days. And this graph clearly demarcated that the period of the infectiousness. Usually the maximum period of infectiousness is the time of the symptoms develop, that is the incubation period, 2.3 days before the incubation period, before the start of the symptoms, and also up to the 7 days is the start of the symptom. So that is the actual average is a maximum 10 days. So before 2 to 3 days before the start of the symptoms, and 7 days is after the start of the symptoms. This is the maximum incubation period. So we are the more vulnerable on that period. Is there any studies on impact of dermatology practice? Yes, there is a one web-based global survey is there that is reported in International Journals of Women Dermatology. This is a web-based global survey. They included 733 dermatologists, and they aim to assess the immediate and long-term effects of the pandemic on dermatology practices on larger scale, including the clinical activity, frequency and types of procedures, and teledermatology use. In this study, they did all over the world, in Asian countries, North America, South America, European countries also. They included all urban, suburban, rural practices, and also private hospital-based practices also they included. And comes to the practice activity before the pandemic. Before the pandemic, face-to-face consultations is around 73.9%, and during the pandemic, it comes down to 9.3%. Before the pandemic, teledermatology consultation was zero. Nobody used exclusive teledermatology consultation was zero before the pandemic, but after the pandemic, it rises to 38%. And before the pandemic, both teledermatology and face-to-face was 26.1, but after the pandemic, it comes to 37.3. And patients also comes down drastically all over the world. Patients per usually less than 50 patients per week before the pandemic was 15%. Now it comes to 62.9%. And procedures per week, all the dermatologists used to do all the procedures before the pandemic. Now there are only 25% of the patient, 25% of the dermatologists are doing procedures. And teledermatology use before practice and after the pandemic, it increases to almost 75%. And impact on the clinical activity, 53% reduction in the number of the dermatologists practicing face-to-face consultation, 49% increase in the teledermatology consultation, 15% of the dermatologists all over the world, they stopped practicing face-to-face or person-to-person consultations, especially the senior dermatologists. And impact on the procedures, 1/4 of the dermatologists, they are not doing any procedures, especially the cosmetic procedures. The most common procedures they are doing in the pandemic is skin biopsy only. Impact on the hospital services, considerable impact is there on hospital services. Oh, it's good, thanks. Can you move to the slide, impact on the hospital services? Yeah. Next slide, please. Next slide, please. Next slide. Next slide, please. Next. 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 Right. What? Right. Thanks. Next slide, please. See, the hospital services is 60.8% in the local hospital discontinued dermatology clinics. Next slide, please. Next slide, please. And there is a 49.1% increase in number of participants in teledermatology, and for both new and follow-up patients. So now dermatology practices shifted from bedside to phone side. Next slide, please. So there is a lot of impact on the postgraduate teaching also. It is a profound, and examination is also postponed, but academic hours in the form of continuous medical education is like a digital podcast, virtual meetings, and webinars. Next slide, please. Next slide. There is also financial affected, and IID will also release the IID Academy, IID will Executive Committee published the position statement and recommendation for post-lockdown dermatology practice amidst in the COVID-19. It is available freely in Indian Dermatology Online Journal. Next slide, please. The preventive measures in dermatology practice for COVID-19 are the administrative guidelines and corrective usage of PPE and engineering measures. Next slide. Checklist for the administrative measures, like the moment you enter the patient, you have to screen them like triage area, rule out for the low-grade fever, flu-like symptoms, cough, cold, shortness of breath, risk of exposure. And when patient arrives in the clinic, putting up posters like education posters, temperature checks, donning of universal face masks, hand cleaning with the soap and water, sometimes sanitizers, limiting on non-patient visitors. Inside the clinic, placing the chairs 3 to 6 feet apart, removing the toys and reading materials, and after patient have the clinic, cleaning the frequently touched surfaces. Next slide. Recommendation for the administrative for the staff, like general management, traveling outside the country is prohibited. Staff who have recently traveled history must undergo 14 days. This was the previously. And intraoperative measures like machine surfaces of the dermatology should be cleared frequently, and proper PP use is must for the staff also. And smoke evacuator should be used to capture the flumes of the aerosols, and also the covering of the mouth and nose of the patient while doing the lasers. All contaminated PPD must be properly removed and cleaned and disposed. Hand hygiene must be performed after the removal of the gloves. Next slide, please. Triage area at the patient entry. In our hospital setting, also in KIMS Hospital, we are doing very good triage area, because those who have a fever and respiratory symptom, they are sending to the fever clinic. This is a separate fever clinic is there, not to combine with other services. But in the clinic setup, it's very difficult to set up like a private separate triage area. But what you can do the single entry point, and you can dedicate a small demarcated area. There we can screen for the temperature and respiratory symptoms. Next slide, please. So environment care of the clinic is important, because adequate ventilation is also required, because as the virus thrives well within the temperature between 22 to 25 degrees centigrade and humidity of 40 to 45 percentage. So this is like a typical air conditioned room. So room temperature should be maintained between 25 degrees centigrade to 30 degrees centigrade. Next slide, please. Stationary use, it should be minimal. E-prescription is recommended. Prescription for 1 to 2 months at least for you have to give, because and banknotes it will stay for 2 days. It is an experimental setting, and digital mode of payment is recommended. And you can charge surcharges for the maintenance of PPE kit and disinfectants also. Next slide. The consultation should be bare and uncluttered, and patient seating
2 more minutes,
at least,
Anand.
yeah, 1 meter away. And if oral examination is required, you have to follow it like ENT procedures. Phototherapy is recommended. It's no issue. And next, machine surfaces should be covered with the plastic wrap, and the procedure room must be kept minimally clean and air conditioned. Sanitized hand frequently after each patient visiting, and pre-procedure mouth rinse. This is especially dental practices. In the dental practice, whenever we consult the dental patients, they are recommending the chlorhexidine mouthwash before consulting the patient. And this will prevent the aerosol generation from the mouth at least for 2 to 3 hours. And personal precautions before entering to the living, you have adequate food, wearing belts, and all these things is avoided. And before leaving your clinic, and you should dispose PPE properly, wash your hand thoroughly, and decontaminate mobile and spectacles and everything. While going back to home, and you have to call to the home, and because you should be remember that in the home the children are there, family members, all senior citizens also will be there, and so that is the reason, don't touch anything, just go and take the bath. And personal protective equipment is very ideal, and everyone is recommended, like N95 mask. If the triage area is not there, is N95 mask is there. And while doing aerosol procedure, is N95 mask and face shield is compulsory. And also if required, you can wear the gown cap and foot cover also. And wearing the PPE kit alone is not enough, but you should not touch hand hygiene, eye protection, goggles, gown. This is also very important. And biomedical waste management is also important, because you have to spray 1% sodium hypochlorite interior and exterior of the biomedical waste bag. So advice to the senior dermatologist, like above 60 years, is IID will already in his statement mentioned that if you are 60 years and above age, or have underlying medical conditions, or pregnant, please stay home. You may consider referring your patients to the colleague who is working. And how to disinfect the different surfaces in the clinic. As we know, is 0.5 to 1% of the sodium hypochlorite. You can prepare it and you can use it daily. And the metallic door handles, like metallic areas, security locks, and equipments, for that you can use sodium hypochlorite, especially the lasers one. So engineering measures is surgical smoke and laser flume is very dangerous. Theoretically, it may contain RNA virus also. That is the reason you have to use a smoke evacuator. And very interesting article in the Journal of Cutiousness of Aesthetic Surgery. There were surgical policies there. You can go through it. That is the article says there's something better than nothing. That is nothing but household electrical chimney you can use in the procedural room. But how effective for coronavirus is, we don't know. but at least for the surgical flume, yes, it can decrease it. And regarding the immunosuppressive, and American Academy of Dermatology, it already recommended to discontinue, postpone the biologicals in COVID-19 positive patients, and you have to use immunosuppressive on case-to-case basis. And but recently, one article came in the journals. They says that biological therapy protect against severe COVID-19 infection also. So I came across one patient recently who I started secukinumab recently. After 2 injections, the patient developed COVID positivity, and he called me. Then I told him to stop the secukinumab for 2 weeks. Then he stopped it. Then he recovered very well. After recovery, then 2 weeks also I didn't start the medication. After 2 weeks, then I started again secukinumab. So those who are on the biological, they are doing very well regarding the COVID-19 infection, but the severity of the symptoms compared to the normal people is very, very less. And as we are
Sir, can you
International
make it
Psoriasis
faster?
Council,
Actually, we are late by 15 minutes.
yeah. And also is a SAG and IIDL Academy and SAG of
Try
different
to wrap
SAGs
up
like,
quickly.
yeah, 1 minute. SAGs of lasers, SAGs of aesthetic dermatology, and SAG of dermatosurgery. They are all recommended. All the safe practices in the Indian online dermatology journal, so you can go through it. And also, I recommend to all the dermatologists to have a health insurance and also the term insurance, not only for you and your family members, and also for your staff, because there is the phone pay and phone pay is launched for 149 rupees for the 50,000 health insurance for the COVID also. You can take it for them, for your staff. So at last, just remember, for the world, you are the only one person, but for your family, you are the whole world. So take care of yourself. You need to be your first priority. Patients can always replace doctor, but there is no replacement for your family. So take care of yourself before you take care of others. No need to heroics. All you will get is a garland either way. Thank you so much.
Wonderful, Dr. Anand. I must congratulate you and also thank you for being very confident and brave in starting your presentation without the visual aids. And fortunately, we could get back the slides. So, once again, I thank you for an excellent presentation. You shared some very new important findings which we should use in our day-to-day practice. Thank you. Now I leave it to Dr. Ramesh.
Thank you, Dr. Uday Kiran. Now, on behalf of Dr. Uday Kiran and myself, we thank the organizing committee and the CUTICON 2020 for enabling us to chair this session, very effective session. And I thank the speakers also, Dr. Putta Srinivas, Dr. K. Sagar, Dr. Anand Kumar, for their excellent presentation, very much pertinent to the present ongoing pandemic, and how do we adjust ourselves and adapt to the given situation and continue with our practice, safeguarding our own interests as well as the public's. So very nice program we have overseen. I thank personally President Madam Vani and Dr. Aruna Samarth, General Secretary, Dr. Kavita, Treasurer, and Dr. Rajalakshmi, the Scientific Chairperson. Thank you.
Okay. Thank you, Dr. Ramesh sir and Dr. Uday Kiran sir, for giving your valuable time and chairing the session. And there is a valuable information about the COVID and the precautions to be taken by the medical fraternity and the normal complications that are faced due to the PPE kits and everything is explained very well. Okay, thanking you, sir. We will move on to the next session. That is topic on the auto sensitization. I would like to call the chairpersons, Dr. Vinay Kumar Sharma, sir.
Yeah, available.
And Dr. Chandravati, ma'am.
Yes, I am there.
To chair the sessions, ma'am.
Yes.
Can you share the screen? Dr. Sir Mintu.
I think, sir, Dr. Sandeep is not able to share his screen.
Okay, something is.
Once.
Mintu.
Yes.
Can you Actually, I have shared the PPT.
It is not coming. I think you have to sign out and sign in again.
No, I will share from my side, not an issue.
Okay, sir. Go ahead.
Can you see, sir?
Yeah.
No, sir.
Okay, I will introduce Dr. Vinay Kumar, sir. He has completed the MD in the 1988 from Usmania Medical College. Has worked in the Saudi Arabia for 5 years, and he has worked as associate professor in the Deccan Medical College for 10 years, and now practicing as a dermatologist at Chaitanya Puri, Hyderabad. He has done many publications in the Journal of IADVL, Indian Pediatric Dermatology, and Indian Journal of Imaging and Radiology. I would like to introduce one more chairperson, Dr. Chandravati ma'am, the professor and HOD of the Department of DVL in Care Institute of Medical Sciences, Care Hospital, and she is the member of several national and international societies of dermatology, trichology, cosmetology, and dermatosurgery. I would like to please chair the session.
Hello.
Hello.
Hello. Am I audible?
Audible, ma'am.
Yeah. Good morning. Good morning, Vinay Kumar Sharma.
Good morning, madam.
Good morning to the audience. So, without further delay, I would like to introduce. Will you share your slide, please?
Madhusudan Reddy.
Madhusudan Reddy garu.
Yes, madam. Directly, can I go for presentation, sir?
Okay. You wanted to go off because no, I wanted to tell you what biodata and all CV because that is what.
But I could not get it.
Okay. So it's actually the topic is auto-sensitization. It's a very interesting topic, and it's going to be moderated by Dr. Madhusudan Reddy. It is to you to moderate the session and also introduce the panelists.
Thank you, madam. Thank you, Vinay Kumar Sharma, sir. Thank you, madam.
Yeah, please go ahead. Yeah, Madhusudan Reddy, please go ahead.
Yes, sir. Sir, can I see the panelists, sir? I'm not able to see them. I would welcome the panelists, sir. First one is Dr. B.N. Reddy, sir.
As well as with medication and severe active infections.
I am here.
Yes. Second, Dr. Tina Priscilla.
Yes. Good morning, everybody.
Good morning. Good morning. Third is Dr. Purna Chandra.
It's not like that. We have to prepare the patient before.
Dr. Purna Chandra, are you here?
I am there.
Yeah. Thank you. Fourth is Dr. Radha Shah.
Good morning, everybody.
Good morning. And fifth one is Dr. Aradhya.
Good morning, everyone.
Good morning. Nice to be on this. Nice to be all you in the panel discussion. Just I will start a presentation regarding auto-sensitization for a minute, and then we'll directly go into the panel discussion. Okay. So first we are discussing what is auto-sensitization. Auto-sensitization is nothing but auto-sensitization dermatitis is nothing but it refers to a phenomena where acute dermatitis develops in a cutaneous site distance from inflammatory focus.
That's over. No? Ajilakshmi, mute yourself.
Finish this.
Secondary acute dermatitis is not explained by primary inflammation. This is the term first coined by Whitfield in 1921. Classically, the autosensitization dermatitis presents secondary to the stasis dermatitis. It may have varied presentations starting from papular, vesicular, eczematous, morbilliform, urticarial, and erythematous. Usually, you'll see a bilateral eruption. The mechanism can be by spread of allergic contact dermatitis or ingestion of an allergen. Third one is a hyperirritability of the skin. Fourth one is hypersensitivity of an infection. So, with this brief introduction regarding auto-sensitization, I am directly going into the pathogenesis. Yes, B.N. Reddy sir, coming to you first. what do you think the pathogenesis is involved in autosensitization? In what way and why it is common in upper limbs compared to the other sides?
Resistance or non-responders. It can be due to persistent.
Good morning, everybody.
Good morning, sir.
So this autosensitization, suppose it's in contact dermatitis, you can expect to develop immediate type 1 hypersensitivity reaction. Otherwise, most of the time, it's allergic contact dermatitis instead of this irritant contact. So you can expect type 4 hypersensitivity reactions.
Rise of pro-inflammatory cytokines.
Yes, sir. So, what is the main thing is, anything to add, Dr. Radhasha?
Bring the patient under
Hello?
control, stabilize and
Hello, anything to add from your side?
interestingly, there is no
Some presentation is going on.
Yeah, basically it's more of
యాక్చువల్లీ చేయకపోతే మేలు, కాకపోతే దాంట్లో అంత స్ట్రిక్ట్ గా ఉండొద్దు అని చెప్పాను. బికాస్ అవార్డ్ పేపర్స్ మనకు తెలిసిందే కదా, స్ట్రిక్ట్ గా ఉండాలి, తప్పదు.
Rajalakshmi, your voice is heard.
కాబట్టి వాళ్ళందరూ మెన్షన్ చేయొద్దు అని చెప్పు, బట్ డోంట్ ఎక్స్పెక్ట్ ఎనీథింగ్ మోర్ దాన్ దాట్. అంటే నేను వీళ్ళకి జడ్జెస్ ఏం చెప్పాను, ఇప్పుడే చెప్పాను 5 minutes బ్యాక్, దట్ పర్వాలేదు, ఎందుకంటే ఇది వాళ్ళకి తెలియదు కాబట్టి, కొత్తది కాబట్టి వీ కెన్ ఎక్స్క్యూజ్ అట్లా. ఓకేనా, కానీ వేయొద్దు అని చెప్పి, ఎందుకని మంచిది, కొంతమంది వేసుకుని ఎందుకు, ఇంకా మిగతా వాళ్ళకి ఏమైనా తెలిసి వేయకపోతే వీళ్ళు మళ్ళీ అంటే వాళ్ళందరి పేర్లు కూడా ఏం అవసరం లేదు, లైక్ ఫ్యాకల్టీ అండ్ ఆల్ దాట్ అట్లా పెట్టేసుకోమను. మిగతా వాళ్ళకి తెలిసినట్టు చేస్తారు.
Mute Dr. Rajalakshmi.
Rajalakshmi, mute, no?
Sorry. Extremely sorry, bro.
Yeah. Yes, Dr. Radhasha.
basically delayed type hypersensitivity is it's a delayed type hypersensitivity reaction, type 4 kind of reaction, and sometimes it may be type 1 reaction and related to presence of antibodies, which is type 2. So it can be different pathogenesis depending on how it presents itself.
Yes, mainly it is a autoreactive to the keratinocytes antigens, which is a delayed hypersensitivity commonly seen and correlates with the histopathology findings and increased T lymphocytes counts and release of interleukins. Why it is more common in upper limbs, it has explained by more number of receptors are seen in upper limbs compared to the other areas. So coming to directly, I'm going to a case scenarios. So the first case is a 55-year-old male presented with itchy scaly plaques on left lower limb since 2 months. And the swelling of left lower limb is slowly increasing with prolonged standing and prolonged journeys. And he presented with multi-itchy papules with crusting on trunk since 1 month. You can see the photos here. Background lipodermatosclerotic change, dilated reticular veins with eczematous change on top of it, with crusted lesions on abdomen. So coming to this thing, sir, we'll start with Dr. Tina. What is your opinion regarding the presentation? What do you think? What is the root cause for it, and what is the pathogenesis involved in it?
Yeah, basically, because looking into the age of the patient and the history of prolonged standing and the clinical features that is resembling stasis dermatitis in this patient. So probably this is a case of stasis dermatitis, and there could be a chance of dissemination of this stasis dermatitis attributed to the allergic contact dermatitis of application of the local things. So that could be one of the reason wherein there is dissemination or auto-eczematization in this case.
So what do you think the pathogenesis involved in auto-eczematization of stasis dermatitis? Same like other things or anything more? Anything new to be added? What we discussed earlier?
Yeah, usually there is an increased leukocytic activation, that causes this cutaneous hypersensitivity, that causes this T cell proliferation, causing this eczematous the dissemination of this in this case. And even the topical medications, the allergens could act as a systemic, it can cause a systematization and cause these eruptions. So that could be one reason.
Dr. Purnachandra? Are you there?
Yeah.
How you are going to evaluate, and how are you going to differentiate from other conditions, and how do you manage these cases?
Sir, first is stasis dermatitis. If it is because of medicaments, we can always do patch testing if it is because of medications. And first treat the root cause. What is stasis dermatitis? We have to treat. And if at all needed, if it is very much disseminated, we can go for systemic corticosteroids for the treatment of the condition.
Underlying root cause color Doppler should be done, and we need to treat how much is the venous insufficiency. Based on that, we need to take a call whether it is a grade 1, grade 2, grade 3, grade 4, and avoid prolonged standing usage after healing of the lesions, usage of stockings. These things we should take care. And what is the main pathogenesis of stasis dermatitis, do you think, Dr. Aradhya? I'm not audible.
Yeah,
Yes.
sorry, sir.
Yes,
Because the stasis dermatitis is a cutaneous manifestation of chronic venous insufficiency. Chronic venous insufficiency is caused because of altered venous microcirculation. Fibrin clots are present around the capillaries, which occur due to the endothelial transportation of the fibrin because of the damaged venules, and also activation of leukocytes and adherence of leukocyte because of increased expression of ICAM and VCAM on the blood vessels. All these things will lead to proteolytic enzymes and other cytokines and inflammatory pre-mediators, leading to the pathogenesis of the stasis dermatitis.
Yes, good. Ultimately, the release of fibrinogen, depositing of fibrin deposits and proteolytic enzymes and ICAM1. This is a root cause of pathogenesis and treatment. Next case we'll go. This is a similar case. The patient has chronic lipodermatosclerosis with venous ulcers. You can see on middle 1/3 of the leg, the wound is eczematized around the ulcer. Around the venous ulcer, the eczematization is seen. So what is the reason do you suspect for eczematization? So how do you explain? Dr. B. N. Reddy, sir?
So this is going into slowly infection.
Yes, sir.
There is evidence of cellulitis.
Yes, sir.
So it's a secondary infected.
Secondary infection is okay, sir. Developing of contact dermatitis around venous ulcer, sir?
Contact dermatitis may be due to the topical applications or any wound care that's the patient undergone.
So, what is the common suspect you think, sir, in contact dermatitis of a venous ulcer? Which is a common causative agent which you suspect, sir, routinely?
There are two steps in the pathogenesis, as earlier panelists they told. So first of all, there is a venous valvular insufficiency. So there is a venous hypertension that causes actually increase in the osmotic pressure. So there is a diapedesis of RBCs into the cells. So there is a hemosiderin deposition, which is responsible for pigmentation. And due to the fibrin, there is it invites like a necrotic changes because it doesn't allow the oxygenation and other nutrition to be supplied to surrounding areas. Then it invites the infections, mainly the staph and strepto. So when these bacterial infections are there, they may actually produce the super antigen. They may be directly responsible for autosensitization.
So, anything, Dr. Tina?
As Sir has said, the bacterial toxins, they act as super antigens, which would result in this excessive activation of this immune system and the cytokine release and cause these eruptions. That could be.
Contact dermatitis to topical antibiotics and steroids. How commonly you see, how do you go, and how do you manage application of topical steroids and antibiotics?
Can I?
Yes,
Hello.
Dr. Radhasha?
Okay, so you want me to talk on how do you...
No. Commonly, venous ulcers, we develop contact allergies with oozing around venous ulcer due to topical application of antibiotics or steroids. So, which of the group drugs you commonly encounter, and how do you manage these cases? You should unmute, madam.
Oh, sorry, I didn't get, sorry.
Yeah.
So apart from the topical steroids and the, what you said, this antibiotics being used for treatment, even the cleaning agents which are used, a lot of them use Dettol and Savlon. So they are also another cause for contact, or it could be even irritant dermatitis. It need not be an allergic thing. So that has to be taken, history has to be taken into what all products are being used in the local area. And then we go on to the milder cleaning agents like betadine lotions, povidone iodine solutions have to be used. Topical moisturizers, emollients, which are non-fragrance products, simple oils, they have to be used more frequently. The use of stockinets, because we have to reduce the edema there. Otherwise, the wound will not heal. So the edema, they have to be encouraged to put a wrap on it, put a gauze piece on it and wear the stockinets, because most of them are hesitant to wear stockinets in this stage. So there are, I mean, we course them that you have to wear for few hours, which helps with healing. Topical antibiotics, I would like to avoid because it gives rise to a lot of sensitivity. I would rather give a oral antibiotic and then maintain with povidone iodine as local cleaning. That's a safer thing and very less chances of contact sensitization. Topical steroids, usually we don't advise if it's a wound area because it will give rise to a steroid also. It will not allow healing of the wounds. So I usually won't give topical steroids. If the patient is on it, then we ask them to get weaned off it and be only on topical moisturizers and emollients. More frequent usage of that. And antihistaminics. If you use antihistaminics, the need for the topical steroid will go down because itching is a major complaint there.
Yes, that is very important. Avoid all topical antibiotics, use oral antibiotics and just use bland moisturizers. Avoid all topicals. Suppose if the patient is desperate, requires topical steroid. If you suspect topical steroid contact dermatitis, then how you are going to switch on? Yes, Dr. Purnachanda?
Yeah. So topical steroids, if at all needed, we can avoid the ulcer area and then apply, or we can go for systemic corticosteroids.
Yes, systemic corticosteroids is ideal. But if you suspect contact dermatitis to corticosteroids, there is a corticosteroids allergic contact dermatitis as described into 4 groups. One is a hydrocortisone group, which hydrocortisone, prednisolone are there. Triamcinolone group, which fluocinolone and triamcinolone are there. Betamethasone and dexamethasone, 3rd group. Hydrocortisone and clobitazone is the 4th group. You can switch the class of steroids and see that, but this is not in an active stage. First, give the oral steroids. If you still suspect contact dermatitis to the topical steroids, just switch the class of topical steroids and you can use. Anything from your side, Dr. B. N. Reddy, sir?
So in the topicals, I don't go with the sulfa containing ointments or even neomycin containing products. And topically, my choice of dressings are saline compresses, followed by potassium permanganate. Then, of course, any steroids, suppose steroid dermatitis is there, orally, I can give actually for short course, for 5 days, you can give even 1 milligram per kg body weight. For 5 days.
Yes, sir. Thank you, sir. Ideally, first you should start with the oral steroids with only topical moisturizers. Once it is resolved, if the patient requires long-term topical steroid, you can switch the class of steroid and see to avoid cross-sensitization, because same group of steroids, contact dermatitis, cross-sensitization will be there. So switch the class of the steroid, then you will, chances of getting contact dermatitis is very less. So
sometimes they may be sensitive to even the vehicle also.
Yes, sir. Vehicle. That is very good point, sir. Correct. A vehicle is also known to cause it. And third case, sir. 12-year-old girl presented with sudden onset of itchy vesicles and bullae on both palms since 2 weeks. There is no history of contact. Developed pain after 1 week. No history of any systemic illness. So, how do we go with these cases? So, based on seeing clinical photograph of this case, what is your probable differential diagnosis and how you are going to differentiate and how you are going to manage these cases? We'll start with the Dr. Tina. Yes.
Yeah, looking into these deep-seated vesicular lesions, this is looking like a formifolix eruption. So most common cause of, the differentials that tinea pedis should be excluded in these cases because there could be an auto-sensitization because of tinea pedis occurring in this group. Especially the inflammatory variant of tinea pedis, that is a vesicular form of tinea pedis, can lead to auto-sensitization occurring in the palms. The second thing would be the other differentials could be an allergic contact dermatitis, and these are the differentials. Maybe you can think of EMF, scabies, or any pustular psoriasis, palmopustular psoriasis in these cases.
So yes, correct. One is a formifolix, id eruptions, allergic contact dermatitis, and palmoplantar pustulosis. These are the common things which you should rule out. This is to Dr. Aradhya. How you are going to differentiate palmoplantar pustulosis with formifolix with secondary infection? How you are going to differentiate, and what are the key features in it?
Usually in formifolix, it is vesicular eruption, and they have a sago grain-like appearance, sir. In palmopustular psoriasis, we can see more like a fissuring, deep cuts, and the other areas of psoriasis involvement can also be seen.
No, if it is isolated palmoplantar pustulosis?
Fissuring, crusting, hyperkeratotic in nature.
Dr. Purnachandra?
In formifolix, usually sides of the fingers will also be involved. And in palmoplantar pustulosis, even the instep will also be involved. Mainly here in convex areas, I think so. I'm not very sure.
First thing is here in formifolix, the vesicles, secondary infection, large vesicles to bullae can be there. But coming to palmoplantar pustulosis, ideally you will see 2 to 3 mm small pustules and a background of erythema, and you don't see much itching. The 2 small pustules, never you will see the large bullae and large pustule in palmoplantar pustulosis. So severe itching associated occurrence of both vesicles as well as bullae with secondary pustular infection more points towards a formifolix with secondary infection. If a small pustules occurring on a erythematous background, more points it's towards a palmoplantar pustulosis. This we should need to rule out from other causes, but grossly I'm telling clinically. So coming to B.N. Reddy sir, how we are going to manage these cases, sir?
Actually, this I put it as a vesicular hand eczema rather than palmoplantar. Palmoplantar is just symptom, and this actually looks like in differentiating already or differentiated from palmoplantar pustulosis because of the erythematous changes. So here I will give wet compresses, saline wet compresses, then topical steroids.
Yes,
I go with super potent steroids.
Yes, sir.
Which contain even a topical antibiotic also, fusidic acid.
Yes, sir.
Then oral antibiotics also definitely I will give.
Yes, sir.
And antihistamines are also mandatory.
Yes, what B.N. Reddy sir told is one very important point. Every palmoplantar vesicular eruption is not a formifolix. That we should keep in mind. So this is a algorithmic approach which is given in a Fitzpatrick. If it is acute explosive self-limited, we'll call it as a formifolix. If it is a chronic, if it is occurring on lateral aspect of the fingers, either you should see for a tinea pedis or a tinea capitis for a id eruption, or we should label it as a chronic vesiculobullous eruption. This is a algorithmic approach which is mentioned in the Fitzpatrick textbook of dermatology. So that is a very good point. Every palmoplantar vesicular eruption, we should not label it as a formifolix. Okay. For id eruption, definitely we need to see the underlying root cause and treat accordingly. So this is one more interesting thing. Infective eczema versus eczema with secondary infection. The first picture you can see a 8-year-old boy having mild impetigo on the cheeks. Slowly he developed erythema with progressive border and minute vesicles over the cheeks. Second one, you can see the hyperkeratotic eczema of a feet which developed the pustules. So how we are going to differentiate infective eczema versus eczema with secondary infection? We'll start with Dr. Radhasha. Yes.
basically the history will be important, that how the lesions evolved, what came in first, presence of itching first. Impetigo means it would have been a painful lesion, and then they have applied something and then it progressed. And I mean, basically, I think it is the history, because at times it is very difficult to differentiate it clinically. I can't think of anything else.
Dr. Tina?
Yeah, as ma'am said, the clinical, I mean, the history is very important. Maybe investigations, like if in case of secondary infection, infected eczema, there could be rise of CRP and all that can collaborate with these findings.
Yeah, see, mainly by infective eczema, or what you call infective eczematous dermatitis, where you will see the primary lesion with the discharge, the erythema will be progressing and minute vesicles will be seen. This is mainly because of superantigens, which is already Sir has spoken regarding it. And eczema with secondary infection, here the background eczema will be there, background allergic. On top of it, because if it is open in nature, the secondary bacterial infection will enter from outside, and you can see the pustular infection. So in the management, is there any difference, sir? B. Reddy, sir?
So there are now two photographs. One is infected eczema. That
Yes,
is which we know already eczematous lesion is there, like nummular eczema that got infection with staph or strepto. But infected eczema, infective eczema, that is what we are actually bothered today.
Yeah.
So due to autosensitization, so there will be two lesions. The primary lesion will be there and secondary lesion somewhere. If it is very near, the symptoms are very aggressive. As the distance increases, the symptoms are less. So this can, otherwise we say it's a disseminated eczema.
Mainly
So
the
that's all.
superantigens, what we call
Yes.
enterotoxin and
Yeah, which are responsible for dissemination.
yes, sir. And do you have any other infective eczema, sir, which we commonly encounter? The first described infective eczema actually for a HTLV1 infection, which was, there is a criteria for it where they have told, which we think many times it is a atopic dermatitis with secondary infection. Whenever there is a recurrent occurrence of eczema on face, scalp, axilla or anterior nose, with chronic relapsing dermatitis, which responds to antibiotic, and seropositivity for HTLV1. This is a major criteria which says infective dermatitis positive for HTLV1. This is the condition where infective dermatosis was the terminology first used. And the minor criteria comes.
In our country, I think HTLV diagnosis and this appreciation of this condition is very difficult. But commonly what we see is following ear stud piercing and they getting autosensitization and molluscum contagiosum and herpes simplex virus.
Yes, sir. Even we'll see after otitis media also, sir, CSOM discharge, which leads to yes. That is the commonest thing, sir. But to refresh one of the first described entity, I'm showing this slide, sir, which is there is a criteria for HTLV1. And this is about infective dermatitis. And whenever there is you suspect infective eczematous dermatitis, don't give topical steroid, just to treat with antibiotic and topical moisturizer. Wait for the lesions to resolve, because sometimes even topical steroids may cause irritation to those lesions. So better give oral antibiotic, don't start topical steroids immediately. Okay. And this is the fourth case, sir. A 40-year-old female complaining of scaly erythematous plaques on left upper limb since 3 months. The plaques are slowly increasing and it is forming coalescing plaques. And there is history of usage of unknown medicines. She has used some Ayurvedic medicines and topicals. Now, since last 15 days, she is not using anything. And she developed erythematous plaques on left upper limb, which is associated with pain. And erythematous plaques will see in a linear fashion, and the trailing scaling is seen in all lesions. The swelling of left upper limb also present. If you see the picture, the erythematous plaques with coalescing scales, both rings are forming like an annular to polycyclic with trailing scales. So here you can see background erythema with fine scaling on top of it. Third one, here you can see the diffuse induration erythema, which is more like a erysipelas and cellulitis picture. On top of it, mild scaling is there. So based on the clinical findings, what we can suspect, sir? The patient started with presenting with a annular plaques, slowly increasing in number and size, and slowly they are coalescing to form a polycyclic plaques with a trial scaling, and background erythema away from distant side, background erythema and fine scaling is seen, and erythematous cellulitis and erysipelas like picture is there. So can we suspect a single entity or a mixed entity in this, sir? We'll start with Dr. Tina. Yes. She's not there. Okay. Dr. Purnachandra.
So erythema annular centrifugum.
Yes, good. One possibility is yes, because hypersensitivity response secondary to the tinea infection. One is erythema annular centrifugum, could be the one possibility. So tinea infection with ESC, the first possibility. Second, the infiltrated plaque, erythematous plaque with the background of scaling. Is there anything to suspect?
Erysipelas.
Yes, good. Yeah, very good. So very rarely, tinea hypersensitivity response can be present as erysipeloid eruption, which commonly seen on lower limb, but we can see rarely on the upper limb also. So this has a hypersensitivity response of two types. One is erythema annular centrifugum. Second one is erysipeloid type. Purposefully, this is a case from periphery. When I went, I gave only oral antifungals. I didn't give any topicals. I gave only oral antifungals. After 4 weeks after therapy, you can see complete remission with all cellulitis. I didn't give any topical antibiotic, nothing. Only oral antifungals with antihistaminics and liquid paraffin. That's it. After 4 weeks, complete subsidence of all lesions with clearance, no cellulitis, everything. So coming to interruption and tinea. So how you are going to differentiate interruption and tinea, and how commonly you see different manifestations of a interruption? Dr. Aradhya?
Sorry, interruptions or non-infective hypersensitivity reactions to the microbial antigens, sir. Usually, they don't have any, the interruptions will not have any ringworm manifestations at their site. They're usually distant from the primary site of infection. They are not, I mean, like culture-wise or stain-wise, they are negative for the antigens, and then usually they respond well with the treatment of the primary infections, sir. So that's how we can differentiate interruptions. The different types of interruptions include the most common is lichen scrofulosaurum. The second one would be Formifolix like associated with Tinea pedis. The other like EAC, erythema nodosum, erythema multiforme, erysipeloid, pityriasis rosea like etc. can also be seen, sir, most common.
Yes, that you covered everything comprehensively. Very fine. Very good. Yes. Next, coming to Bernardi, sir, anything to add from your side, sir?
That previous picture that was looking like lymphangitis. So what we actually describe as St. Anthony's fire spreading everywhere. That's my opinion. And this case, as already told, it looks like secondary to Tinea pedis. Usually, you can expect Tinea pedis producing ETH reaction unilateral, usually unilateral. That one point, and there will be. You can appreciate if you do proper studies, there may be association with tinea mentagrophytes or a zoophilic infection. These are two important factors responsible for ETH reaction.
So this is one of the rare variant where commonly we'll see papular variant as Formifolix, as Dr. Aradhya already told, but rarely we'll see erythema annular centrifugum type also, that everybody should keep in mind. Commonest one is a dermatophyte infection, and one more rarest form, erysipeloid eczematous and pityriasis rosea also. So always keep in mind these things before directly treating as a tinea. So this is the case number 6. So a 12-year-old boy who is the son of a circle inspector has presented with a circumscribed boggy swelling on the scalp and a vesicular eruption on the hand. So it is a straightforward case. So straight away, I will ask the cause and I will go for management. This will go with Dr. Tina. Are you there? No, I think some problem is there. Dr. Radhasha, madam.
Yeah, so it's a case basically of Kirion and giving rise to an id eruption, which is of the Pomfolix type. So he'll have to be, we can do the microscopy and all that thing, but we put him on antifungals. How old did you say he is, sir?
12 years.
12-year-old. So you can begin with grisofulvin because I'm hesitant to give terbinafine and itraconazole in young children, and grisofulvin works out well based on his body weight. We start that dosage and we have to give him for at least 6 to 8 weeks till there's complete clearance of the lesion. Regular shampooing with say selenium sulfide or zinc parathion based shampoos or even ketoconazole based shampoos. That would be for the scalp. For the hands, he will need topical steroids and emollients. And if it is itchy, then we add the systemic antihistaminics.
Mainly, as madam told, whatever medicines have come till tinea capitis, grisofulvin is the drug of choice. Always we should use grisofulvin as the first line of drug. Itraconazole is still it is a good drug, but for tinea capitis still proven according to AAD, it is only grisofulvin is the first drug of choice which you should use. So grisofulvin for 6 to 8 weeks is an ideal treatment with clearance of both primary as well as id eruptions with the antihistaminics and shampooing. Yeah, that's so this already we discussed. Proven infection side of id eruption should be negative for fungus. It will be resolution of lesions once primary lesions is treated and positive response for trichophyton. This is case number 7. A 55-year-old male presented with recurrent crops of crusted papular erosions on extensor aspect of upper limb and back since 1 month. No history of fever and systemic symptoms. On examination, multiple papules with central crusting is seen. You can see the trunk as well as the upper limb, multiple papules with central crusting is there. So, onset of papules with central crusting, how do you approach? BN Reddy, sir? Start with you, sir.
So they are looking like papillonecrotic tuberculosis.
Yes. Any differentials to be considered, sir? When does the patient present acute onset with the papules with central?
Lichen scrofulosum or any other acral lesions you can consider. And apart from papillonecrotic tuberculosis, even Guerin-Costi syndrome, of course, is not a child. GCS.
Dr. Aradhya?
And what about lichen planus also you can consider because they are looking violaceous. And pleva also you can consider.
Correct. Close differential is one is pleva, where acute with the systemic symptoms, if it is there, papular with central crusting, pleva should be considered after papillonecrotic tuberculosis. Anything to add, Dr. Aradhya? Unmute yourself.
Sorry, sir. No, sir. The second DD I could think of was only pleva. That's it.
Dr. Radhasha, madam?
You can keep in mind dermatitis herpetiformis. Sometimes it may not look vesicular, but the biopsy shows it.
AH also, yes.
Yes. Dr. Purnachandra?
Nothing more.
See, ideally, we should remember one entity which I want to highlight is lymphomatoid papillosis, which will present as an acute eruption of the papules with central crusting, CD30 positivity, which epidermotrophism and Reed-Steinberg cells will be seen, and methotrexate and PUVA is the therapy. Whenever the patient present with acute sudden onset of papules with central crusting, these 3 possibilities first to be considered. One is papillonecrotic tuberculosis, second one is pleva, third one is lymphomatoid papillosis. Because this is little we'll forget entity, so which we need to think in the aspect and we need to go for CD marker if required. BND, sir?
Secondary syphilis, then sarcoidosis.
Yes. Secondary syphilis, sarcoidosis is there everywhere, sir. It is like so. Coming to histopathology, you can see central necrosis with lymphohistiocytic, caseous necrosis with lymphohistiocytic infiltrate. So it is pointing towards papillonecrotic tuberculosis. So how do you manage this case? Dr. Tina, are you there?
Yeah.
Yeah, how do you manage this case?
So papillonecrotic tuberculate is a interruption. I mean, it's a tuberculate. So basically, we have to put him on ATT.
Okay. ATT for 6 to 9 months is ideal. So that will have resolution of all the lesions. Montu test should be done along with the biopsy.
Yeah, they'll have. Yeah.
That is one more important thing. And if possible, do routine screening, chest X-ray. Ideally, we don't find the primary cause, but we need to search for it. If any possible primary cause we can see. And next coming, sir, B. Reddy, sir, with you, sir.
Yes.
What are the other tubercle interruptions which we'll see commonly in our practice, sir? And how it is? Yes, sir.
Lichen scrophulosum.
Yes, sir. That is commonest one. Yes.
This papillonecrotic tuberculates.
Yes, sir.
And
Erythema
erythema induratum. Erythema induratum. That's tuberculosis.
So Dr. Reddy, we are now.
Sir, sir, we are delayed, sir. Within 5 minutes, I will finish, sir.
Okay.
Just mainly lichen scrophulosum, erythema nodosum, erythema induratum we should consider. Erythema nodosum and induratum, the pathology is different. Erythema nodosum never ulcerates, whereas induratum, posterior aspect of the scalp, it will ulcerates. Here, erythema nodosum, you will see a septal paniculitis with Meissner granuloma. Erythema induratum, commonly you will see discharging sinus with ulceration. So, for all, ATT is the primary line of treatment which we should give for 6 to 9 months. This is case number 8. So 35-year-old female presenting with recurrent episodes of painful ecchymotic patches on lower extremities since 6 months. Lesions resolving in 7 days, leaving hyperpigmentation. Coagulation profile and autoimmune profile were negative. So this is a ecchymotic painful patch which patients presents repeatedly, and it is healing with hyperpigmentation. So what do you suspect? When coagulation profile is normal and autoimmune profile is negative, what do you suspect? We'll start with Dr. Radhasha, madam. Yes. Hello.
Yeah. No, I'm thinking what you suspect because your profiles are normal. Your coagulation profiles are normal.
Yes, sir. Yes, madam. Coagulation and autoimmune profile were normal. Can we think anything else?
Immediately, I'm not able to think. You can ask someone.
Okay. Not an issue. Dr. Purnachandra?
Sir, any vasculitic disorder?
Could be arterial vasculitis. Yes, you can think one aspect.
Autoerythrocyte.
Yes, good. This is a case of autoerythrocyte sensitization syndrome, which is nothing but a garden diamond syndrome, where you have coagulation profile negative and autoimmune profile is negative. Here, how to diagnose the test? Mainly, you need to separate RBCs. You need to re-inject on the forearm. Then you can see ecchymotic patches around. You can see here. Once you re-inject on the forearm, you can see ecchymotic patches developing. So mainly autosensitization secondary to the phosphatidylcholine is convert pathogenesis. It is mainly seen in middle-aged psychiatric females. So anxiety and depression is most commonly seen. So we need to treat psychological condition along with this, and counseling is very important. So this is one more entity because we'll see commonly, but sometimes we'll forget. So to refresh the entity, just I have given this autoerythrocyte sensitization syndrome. And the last one, this is not related to autosensitization, just to highlight the usage of dermoscopy. I am telling a 30-year-old female presenting with multiple papules on trunk since 3 days, associated with mild itching, and he had no fever and systemic symptoms. If you see on a gross look, it is presented as a disseminated like eczema, but once you get a closer look, you can see the umbilicated lesions and few necrotic lesions. So why I am telling this is not related to autosensitization, to highlight use of dermoscopy. If you use the dermoscopy, you can see perilesional erythema, central necrosis, which points more towards the viral pathology. So these things which help to avoid the biopsy and for essential diagnosis, this to highlight usage of dermoscopy in the routine practice, I have added it. So with this, I finish my presentation. Any final comment, sir, from you, sir? Any final comment, B. Reddy, sir?
Nothing. Well done. Well done, everybody.
Radhesha madam.
No, thank you. I learned a lot.
Dr. Tina madam.
Yeah, now we'll wrap up the session.
Yes, sir.
Okay,
Yes, I hand over to Vinay Kumar Sharma, sir.
Yeah, thank you, Madhusudan Reddy, for bringing out lucidly so many different facets of this autosensitization phenomena. Yeah, everybody learned a lot from your presentation. And I also thank all the panelists who actively participated and gave their valuable contribution to this understanding autosensitization syndrome. Thank you. Thank you, everybody. I thank all the organizers also for giving us opportunity to be the chairperson.
I thank the organizers for giving me this opportunity, and Madhusudan Reddy, you have done a good job by showing so many cases. Very nice.
Yeah, thank you, madam. Thank you, madam. Thank you, sir. Thank you, Vinay Kumar Sharma, sir. Thank you, PN Reddy, sir. Thank you, madam. Everybody,
Hello.
panelists. Yes, sir.
Good morning. I'm Dr. Vani here.
Yes, madam. Yeah.
Go ahead.
I just wanted to add something. You did a very good job, Dr. Madhusudan. This topic I think is very less discussed. I just wanted to add a very significant point for the stasis dermatitis, especially the creams. The preservatives in creams are a very common, more common than the actual drug. So that we have to keep in mind. And one can use ointments in place of creams because ointments mostly don't contain preservatives. So just wanted to make this point. Thank you.
Thank you, madam. Thank
Dr.
you,
Madam, Dr. Vani Madam, the ointments maybe sometimes give the opposite effect because they have the occlusive effect.
Yeah, they have the
No, that's okay. But
there,
when we're talking about contact dermatitis, this is one point we can consider.
Can you stop the screen sharing?
Has pros and cons, but this is what we have to keep in mind about sensitizers. Just wanted to make that point.
Finally, thank you, Vinay Kumar Sharma, sir. Thank you, Chandravati madam. Thank you for
You're welcome.
Thank you. Thank you.
Dr. Manogan, can you display the Dr. Vinay Kumar Sharma? Thank you. Thank you. And thank you, Dr. Chandravati madam. And there is a small disturbance because of the technical issues. Be sorry and apologize from the faculty and also the team. And I will just reintroduction the moderator and other persons. Aradhya Purnachandra, Madhusudan Reddy sir. He has an experience of 7 years and an international journal publication for the 4. And right now he is an assistant professor in the Common Medical College, LB Nagar, and awarded gold medal for an ongoing student in 2013 year. Coming to the panel members, Dr. B. Punachandra, Associate Professor in the ESI Medical College. She has done MD in the Osmania Medical College, had the publications of 8 and experience of 15 years. She had the interest in the pediatric dermatology. Thank you, ma'am. Next slide, please. Dr. Aradhya Bhimahati. She is right now consultant at Global Hospital and also consultant at Med9 Clinics and have done the observationship and fellowship in the cosmetic dermatology from the Tamil Institute of Medical Sciences. And she has presented many papers and posters in the national level. Next slide, please. Dr. Radha Shah. She has completed her MD from the Lokmanya Tilak Hospital and working in the Savant. He has contributed the chapters in the Dr. Savant's textbook of cosmetology and dermatosurgery. And she has in the program of clinical trials since last 12 years. Dr. Tina Priscilla, she has an experience of 12 years and worked as a trichology from the Rajiv Gandhi Institute of Medical Sciences. Published papers in the both national and international journals. She is the member of research committee, MSR, and editorial board is the member of various journals. Dr. B.N. Reddy, sir. Right now, he is a professor DVL in the Medicity Institute of Medical Sciences. He has organized multiple conferences both in the state levels and the national level, and member of IADVL, Red Cross, ASA, STD, AIDS, and CSA, CSC, and AMS, and delivered Honorable B.G. Ranade Memorial Oration. Thank you, sir. Thank you, Dr. Vinay Kumar Sharma, sir, and also Dr. Chandravati, madam, for chairing this session. And we will go up onto the next session. This is a session about the immunoserology in dermatology. I would like to invite them, Dr. Nipadevi, madam, to chair the session, and also Dr. Naeem Sadaf Hanif, sir, to chair the session.
Good morning. Good morning, everyone.
Managna ma'am, can you display?
Just a second. There's a small technical glitch. Please bear with me for a minute.
Okay. I will welcome the Dr. Naeem Sadaf Hanif, sir. He has done his MBBS from the Davangere and MD from Kolar, and he is the author and co-author in chapters in the 2 textbooks, and has done 27 publications in the various journals. He is the scientific committee chairman for the CUTICON Telangana in 2017 and organized various CMEs, workshops, and conferences. And he is a IADVL member as a chairperson 2016, 17, 19, and 2020. Thank you, sir. Next slide. I will welcome the Dr. Nipa Devi, madam. She is an assistant professor in the Department of DVL, Usmania Medical College, and consultant dermatology in the cosmetology Shreya Skin Clinic, Malkajgiri, Hyderabad. Thank you, ma'am. We can proceed on to the sessions.
It's 12 o'clock.
Nipa Devi, madam, can you unmute your?
Yes. Good morning, everyone. Shall we start the session?
Can you welcome the next speaker, ma'am?
Yeah. Dr. Kranti Kumar Verma.
Hello, good morning all.
Hello, good morning.
Good morning, chairpersons, Dr. Nipa madam and Dr. Naeem sir. So this is Dr. Kranti. I am here to talk a few words about this immunoserology in infections. I'm just sharing my screen.
I'm sorry to interrupt. I request Dr. Nipa ma'am to kindly introduce Dr. Kranti Kumar Verma, sir.
Can I have Phoebe, please? Yeah. Dr. Kranti Kumar Verma, he has graduated from Asarams, Ellur, and working experience is a consultant at KIMS Hospital, Kondapur, consultant at Himagiri Hospitals, Gachibowli, and consultant and medical head at Call Health Services Private Limited. Yes, you can start.
Yeah. Thank you for the intro, madam. I'm Dr. Kranti. So I'm just sharing my screen with you. Hope you can see my screen.
Yeah, it's visible.
Yeah. So for the next couple of 15 minutes, I'll be taking you through immunoserology of infectious diseases. Though this is a huge topic to discuss, I've cut shorted and I will be discussing about few of the important infections. So immunoserology of infectious diseases. So infectious diseases, I will be serology and the infectious diseases play a great role in diagnosing the infections. So we'll be going through different bacterial, viral, fungal, and other infectious diseases in the next couple of slides. So we have multiple ways of investigating an infection. So which among will be microscopy, and which among will culture techniques, biochemical reactions, serological identifications, molecular biology techniques like PCR. So today the main interest would be of serological identification. So what is a serological diagnosis basically? Serological diagnosis is nothing but an antigen antibody reaction, which is the union of an antigen with a specific antibody at an optimal concentration, which gives us the laboratory detection of either antigen or an antibody in the direct and the indirect basis. So different type of reactions which are actually in practice today are agglutination reactions, precipitation reactions, complement fixation reactions, neutralization reactions. So immunofluorescence tests, ELISA, the enzyme immunoassay, the radio immunoassay, and immunoblotting techniques. So these are all different reactions with which in practice we are able to diagnose different infections. So what is the application? Where is the serology actually applied? So there are multiple ways which is helping serology is helping us with the clinical practice, which is like in the diagnosis to see the severity of the disease, a staging of the disease, to response to the treatment when there is a reduce in the titers actually. Epidemiological studies, it is helping us out. It is helping us a screening as a donation before before blood and tissue donation. So let's move on to the infection part. I'll be discussing something about a couple of major infections. So immune response to the bacteria. So what sort of immunity is developed against bacteria? So as we see, there are antigens on the bacteria are both intracellular and extracellular. So extracellular antigens, the capsular antigens, the enzymes produced by a particular bacterium and exotoxins. So antibody response is developed to each of these specific extracellular proteins. Okay, and also to the and the way the intracellular immunity is mostly of cell mediated type. So let's discuss something about Streptococcus pyogenes. Streptococcus pyogenes, we all know that it's a dangerously pathogenic pathogenic organism for human beings. So from streptococcal infections to the necrotizing fasciitis, it has a great clinical significance. So from suppurative to non-suppurative complications to like rheumatic fever, post-streptococcal throat infection and skin infection to acute glomerular nephritis and scarlet fever. So we all know it causes superficial pyodermas, invasive infections, non-suppurative complications, and toxic syndromes. So this is a basic structure when we go into the antigenic properties of a group A beta hematolytic streptococcus. M protein is the most major virulent factor that we actually study upon. So there are multiple, like say 60 to 100 serotypes present in M protein, and each type is significant for its own antibody production. And the other exotoxins or antigens produced which are significant with streptococcus would be a streptolysin O. So recent days we go through this ASO titers were various infections caused by streptococcus. So it has its own significance. It's helpful in pathogen. Sorry.
No. That is individual. You have put the slides separately. No, we need one PPT with everything. Otherwise, we'll have to close one, open another. It will take.
Mute yourself, please.
Okay. So it's helping in pathogens then to know the pathogenesis of disease and serological diagnosis. Antibodies usually are substances which we see for whether to diagnose it's a recent infection or a past infection. So here in Streptococcus, significant would be streptolysin O, deoxyribonuclease DNases. So we all know M serotypes of throat infection would be responsible for non-suppurative complication of rheumatic fever. And rheumatic fever, we have direct proportional to the levels of the antibody response to streptolysin O. And skin and respiratory infections with nephrogenic M types you have seen to cause acute glomerular nephritis. So diagnostic evaluation. As I told you, each M type has its own significance. ASO and ADNB are the two serological standard tests. Here we see some of the interpretation levels. Adults with 200 to international units per ml are less than are considered to be negative serologically, and accordingly for DNA deoxyribonucleases B, it's less than 200 units per ml. So usually these antibody titers are seen 7 days after the onset of infection, which peaks up after around 4 to 6 weeks. So categorically, anti-DNase B antibody is seen to be most reliable measure of a streptococcal pathogen in skin infection. So with any serological testing, we have this setback of false positive and false negative reactions. So in ASO titer also, we have this false positives with multiple other proteins, other bacterial proteins like beta lipoprotein and other bacterial overgrowths during the contamination of a serum. So ADNB procedure is serologically proven test for a rheumatic fever and glomerular nephritis. Coming to streptococcal toxic shock syndrome, a four-fold rise in this in this streptolysin O and DNase B is considered to be significant serologically. Though the sensitivity and specificity of single antibody titer is not satisfactory, we are coming to a diagnostic profile. The combination of ASO titer and ADNase B was the most sensitive and significant, which has a sensitivity of 95.2 to a specificity of 88. So that's about streptococcus. We'll move on to syphilis. Syphilis, causative organism Treponema pallidum. So the most characteristic diagnostic feature would be of a clinical examination, direct demonstration by dark field microscopy, and direct or indirect fluorescent antibody testing done. So serological significance of syphilis, we have non-treponemal tests, which are screening tests, and the treponemal tests, which are confirmatory tests. So non-treponemal tests are of VDRL, RPR, USR, and TRUST. So VDRL, RPR is a rapid plasma reagent test, and TRUST is a Toledian red like test. So coming to the non-serological tests, VDRL and RPR are the most common screening test done, while VDRL is a microscopic evaluation of the flocculation that happens with an antigen-antibody reaction. Macroscopic evaluation will be from RPR. So RPR is more sensitive than compared to the VDRL. So all these treponemal antibody tests measure the both IgM and IgG antibodies, and they're helpful for screening and during the follow-up with the titers for after treatment. So non-treponemal tests are positive within 1 to 4 weeks after the appearance of the primary canker. So significance, primary disease, IgM antibodies are not significantly there. So 13 to 41%, it will be non-reactive. In secondary stage of the disease, almost 100% of the serums will be positive for the reagent antibodies. Reagent is the antibody which is produced in the serum. So these titers tend to decline in the later stages of the disease, which means in the latent stages, VDRL can be non-reactive at times. So after several years, like with 25% of untreated cases are known to show the non-reactiveness. So this trend declines fourfold with the treatment by 3rd month, and eightfold to decrease is there with 6 to 8 months time. So even without treatment after 1 to 2 years, even with treatment after 1 to 2 years, VDRL tends to be negative. So setbacks with the VDRL testing would be a sensitivity and the specificity in the primary and the late latent syphilis, where it is actually seen to be non-reactive or weakly reactive. False positive and the false negative results are one limitations. False positive is seen with multiple viral infections, with multiple other autoimmune conditions. Some of them will be like viral infections, malarial infections, so immunizations in the IV drug abuses, connective tissue disorders, leprosy, malignancy. All these conditions have shown to produce a false positive reactions. So coming to the false negative reactions, this is one thing that has to be looked into is a prozone phenomenon. This usually happens when there are high concentrations of antibodies in the testing specimen. So how is this overcome will be a double diluting the query, the sample will help in ignoring, will relieving this issue, a process that begins antigen antibody reaction. So prozone phenomenon have to be is actually seen in 1 to 2% of the secondary syphilis. So VDRL, as I told you, it's a microscopic evaluation and a slight flocculation test. So blood and CSF are two things that can be actually used. So antigen, which I told you, the reagent would be is a combination of a cardiolipin, lecithin, and cholesterol. So results interpreted are weak when there is medium to large clump, weakly reactive when it is medium to large clump, weakly reactive when there are smaller clumps, and non-reactive when there are actually no clumps. So 1:8 is considered to be the reactive with clinical symptoms. So when this is all a qualitative testing. Every positive qualitative testing have to be quantified with the serial dilutions from 1:2 to 1:32. Even if 1:32 seems to be positive, then the higher titrations have to be done coming to the VDRL. So as I told you, rapid plasma reagent is modified via the VDRL test. What happens is so this is a macroscopic testing where this cardiolipin antigen is bound to the charcoal particles. When the agglutination actually happens, there are clumps which are formed, the charcoal black colored clumps which are actually formed to indicate the positivity of the reaction. So all the reactions can be confirmed by retesting with double dilutions as we do it in the VDRL. Quantitative testing is also should be done in the RPR test. So this is a kit which is used for RPR, where you can see that the second circle and third circle are showing the flocculation, the antigen antibody reaction, and that designs to be the positive reaction. So coming to the treponemal tests, there are multiple treponemal tests, which is most significant and specific. This will be FDA-ABS fluorescent treponemal antibody absorption test. The second one would be a TPHA, and the new one of treponemal enzyme immunoassay. So though compared to the non-treponemal tests, these treponemal tests are though confirmatory, are difficult to perform and are most time consuming. So FDA-ABS, a few words on that. Indirect fluorescent antibody test is highly sensitive and specific. So what is actually done is testing sera have to be put to the antigen strain, and antigen anti-human immunoglobulin is added to that, and to see the fluorescence. So when there is a green fluorescence, it is tend to be positive. A result of 2 or above is considered reactive. So this is a specificity and sensitivity of a VDRL and all this syphilitic testing. So non-treponemal tests like VDRL, RPRL have least sensitivity in the primary stage of the disease. The almost 100%, as I told you, almost 100% of the clinical specimens turn out to be positive if the serum is reactive. Specificity for both non-treponemal and treponemal are about 95%. So they are specifically to say specific it's good. So coming to interpretation, RPR and TPHA, this is just to interpretation on a summarization. So when all are negative, when the RPR, TPHA, and enzyme immunoassay are negative, it tends to be no disease. So only when enzyme immunoassay is positive for IgM antibodies, it's said to be an early primary syphilis. So when all of them are positive, it could be a primary or a secondary infection. So when RPR and TPHA tend to be positive and IgM is not detected, it is said to be a late latent infection. So biological false reactions we only tend to see the screening test to be positive and non-screening will be negative. So so in the neurosyphilis, VDRL would be the best solution for neurosyphilis. So along with the reactive VDRL, the increase in the proteins and cell counts are diagnostic of neurosyphilis. So that's about a syphilitic lesion. Coming to the Lyme's, a causative organism is we know Borrelia burgdorferi. So this is known to cause erythema chronicum migrans. So the methods of identification will be isolation, histology, serology, and molecular. Coming to the serology aspect, FDA has approved immunofluorescent assays and enzyme immunoassays for testing like Lyme's disease. So usually it's not the antibodies are not present in the initial first 2 weeks of the infection. It is only seen after 2 to 4 weeks of infection. The sensitivity is little low when coming to this immunogenic response of this. So CDC has given a 2-step approach for for perfect diagnosis of Lyme's borreliosis serologically. That will be first step. First step would be involving enzyme immunoassay and indirect immunofluorescence, and the second step would be a Western blotting test. So if the first test is negative, there is no recommendation for second test. So CDC doesn't approve that. If the first test is positive or weakly positive, then the Western blotting is done. So Western blotting, Western blotting may, if the screening test, that is EIA, enzyme immunoassay, is positive, then if IgM is present, then there should be 2 bands positive in the Western blot. That should be either 23, 39, or 41. So if it is IgG positivity, the Western blot has to be positive for 5 out of the 10 bands. So that will conclude the diagnosis of borreliosis. So that's about a bacterial thing. Now moving on to the viral thing. So viral, once it enters, the innate immunity is one thing that is actually of initial response. So when the innate immunity is insufficient, then we go for humoral and cell-mediated immunity, the cell-mediated immunity. So let's discuss about a couple of viral infections. Herpes growth capable of latent infection with lifelong and persistent in the host. So herpes simplex viruses HSV1 and 2, HSV3 and 4 would be varicella zoster virus and Epstein-Barr virus. Cytomegalovirus and SHV8 will be Kaposi sarcoma associated. So coming to the serological diagnosis of HSV and HSV2. So it's good to interpret a genital herpes with a serological testing than with a herpes simplex labialis. So incubation period with some range somewhere around 2 to 12 days. And there are 2 specific serological antibody testing that are being in practice, which are Western blot technique, and the second one will be a glycoprotein G assay, which is held with the help of enzyme immunoassay. So antibody testing based on HSV1, if it will be a glycoprotein G, for HSV2 it will be a GG2. So this will be the testing in practice basically. So acute HSV infection, for all the viral infection, one thing have to be considered would be a pathogenic detection will be the first source of identification of an organism and infection. So antibody detection is of secondary importance, and diagnostic would be of nuclear amplification tests. Serological diagnosis in HSV is usually the antibodies are usually present between 4 and 7 days of time. So the titers peak between 2 and 4 weeks. So HSV type specific antibodies are helpful in the diagnosis of the infection. So while coming to the interpretation, anything above 1.1 is tend to be reactive with the help of the tests which are done with the help of enzyme immunoassay. Usually the testing is negative during the initial testing, then the retesting is done with around 14 days time. So seroconversion or rising titers indicate the presence of an active infection. So when you see the slide, there will be interpretation. I will tell you a little bit on the interpretation part. So based on the pathogenic testing and the non-pathogenic testing. So I think everyone can see my arrow. So when there is a positive HSV1 and all the serological testing are negative, then we have this primary infection of HSV. So we cannot go by the serological testing alone. We'll have to go for the pathogenic testing to whether to come to a conclusion of presence of infection or not. So with the positive HSV1 and with the positive HSV2, the HSV2 in the serology indicates a primary infection with HSV1 could be a latency of HSV2, and vice versa with the pathogenic infection of HSV2. So so these are all the indications where actual serological testing would be of help. So where you can see HSV genital is primary, it will be of serological significance, along with which determination of immune status at the time of pregnancy, one thing serological significance is there, and the determination of immune status before, so it will helpful in like before organ transplantation. So coming to the varicella zoster virus, incubation period of varicella is around 14 to 16 days. So varicella zoster virus, IgA, IgG antibodies, and actually IgA avidity is the one which is actually giving us a serological like significance. Antibodies, once they're formed, they are lifelong seen. So this immunity can be identified with fluorescent antibody membrane antigen test. This is one test which is approved by FDA, and it's the gold standard for determining the immunity against varicella zoster virus. Anything above 4 is highly significant of chickenpox, the varicella. So serological significance, where do we have to test in case of suspected cases? So in all varicella zoster, herpes zoster, varicella infections, herpes zoster infections, congenital varicella syndrome, and to know the immunity, the serological markers of IgA and IgM are helpful, which will give us the picture of the infectivity. So this is what it is explained. So coming to cytomegalovirus infection, so diagnosing a cytomegalo infection with the serological testing is little difficult. So cytomegalovirus IgG conversion is one step which is seen in serial blood samples. So for incubation period of 10 to 14 days or a gap of 10 to 14 days, and detection of CMV IgG antibodies with low avidity in combination depicts the earlier infection, the primary CMV infection. With high IgG avidity will give us a past infection. So there is it has to be diagnosed as a primary CMV infection. There should not be any detection in the immunoblot, and there should be a high CMV IgM antibodies which are seen. So specifically, DNA, CMV DNA and antigens have no role in the identification of infection. So interpretation part, when both IgM and IgG are negative, there is no infection. When only IgG is positive, there could be a source, and avidity is high. Avidity is high only during a later infections. So there is low chance of primary infection. Positivity with IgM and IgG antibodies and low IgG avidity would give you a primary infection. So all the three, if they are positive, then it could be a late infection. So this is the slide which has been explained earlier. So coming to EBV diagnosis has based on 3 indications: primary infection, differentiation between a severe primary infection and a reactivation in immunosuppressed individuals, determination of a EBV status before a transplant, it can be done, and monitoring a tumor, so tumor of a nasopharynx. IgG, IgM, and IgA are usually IgA avidity similar like CMV are the tests which are done in practice. So ELISA method, IFT, Western blotting are the most common things which are seen. Though IFP, immunofluorescent assay test are said to be a specific and gold standard for EBV serology methods. So these are all the antigens which are there. So early acute antigens are EA restricted and EA diffuse. Viral capsid antigen is a late phase, and in the latent phase, you tend to see Epstein-Barr nuclear antigens. So there are 3 steps of diagnosing EBV serologically. Step 1 actually includes antigen-centric approach. Step 2 is a Western blot technique, and step 3 is a mixed antigen. So step 1 if EBV, IgM, and IgG are negative, then the interpretation will be a negative infection. So if IgG is positive, then EBV, EB, and IgG avidity is positive, then it is considered to be a past infection. A fresh infection, it has to be both IgG and IgM. So second would be a Western blotting technique, and third would be an antigen mixed approach. In the antigen mixed approach, both early antigens and late antigens are mixed to see the response. So when both of them are negative, then it tends to be a negative infection. When IgG is positive, then it is tend to be a past infection. When IgG is positive, when both IgG and IgM are positive for the mixed antigen response, then it is said to be a primary EBV infection, acute infection per se. So that is all about the EBA and CMV. So serology, we all do a common test called ELISA initially for screening that will be confirmed by Western blot. So apart from this current standard testing that is done, other methodologies are particulate cell agglutination and immunofluorescence in RA. So particulate again is a screening test here, and immunofluorescence and radioimmunoassay is a confirmatory test. This is second line of testing for serology. So these HIV P24 antigen assay and HIV antibody ELISA and Western blot are 4th generation antibody serological testing which are actually done. So where is it significant? Significant before a transfusion, significant for diagnosing an infection with symptomatic or asymptomatic stages as a post-exposure prophylaxis and research purpose. So these are all the antigens that have been generated over years: first generation, second generation, third generation, fourth generation. So what is the setback with the first generation would be the antigens used of HIV isolates are not sensitive and specific. So coming to the fourth generation, the HIV P24 and the IgG and IgM antibodies directed again by the diagnosed by ELISA and the ELISA test, and as I told you, Western blot will be of helpful in during the window period also. So commonly used are ELISA and rapid test. Rapid tests are dot blot test, agglutination assay, immunochromatography, and the dipstick test, which is based on the enzyme immunoassay. So rapid tests, which are in current use, can detect more than 99.5% of all HIV infections, and false positives are less than 2%. So as I said, positive, false positive, and false negative is expected with the HIV testing. Autoimmune diseases and alcoholic hepatitis, leprosy, and multiple pregnancies there are false positive reactions which are actually seen. Negative reactions are there with technical error and during the window periods. So dengue serology, one which is not commonly used, but of significant with serology are NS1 antigen by ELISA and IgM and IgG by ELISA. So these are basic serological testing done in terms of dengue fever. See, coming to the fungal infections, superficial fungal infection doesn't have a significant role to play with the serological diagnosis. So fungal, so it has more significance with the systemic fungal infections. So serology often play a role in the important role in the diagnosis of systemic fungal infections. So these are the most common infections where we actually serological diagnosis is helpful. One will be aspergillosis, so blastomycosis, coccidiomycosis, cryptococcosis, and histoplasmosis. These are all and the tests which are helpful are enzyme immunoassays, complement fixation tests, latex agglutination tests, and particle agglutination. So for diagnosing, serologically diagnosing a case of the suprasystemic fungal infections. So parasites, not to be covered much. Toxoplasma gondii is one thing which has to be in mind when we are actually thinking about the torch infections. So titers, indirect immunofluorescence, IgG, and enzyme immunoassay IgM are the two diagnostic methods that are actually in place. Negative testing, if it is the titers are 1:16. So the titers, if they are high when through indirect immunofluorescence of 1:1024, the infection is probably acquired within the last 18 months. So recent infection, which gives more than titers, in both of them are positive, and the more titers, fourfold increase, provides acquired immunity, the infection. So that's all about the immunoserology that I thought I would like to tell you basic and important infections.
Thank you, Dr. Kranti Kumar. That was a really very informative session on immunoserology in different infections. Thank you very much.
Thank you.
Name, sir, can you please introduce the next speaker?
I was thinking other chairperson anyway. Dr. K. Swarupa is a founder and consultant dermatologist at Ritu Skin Care since 2008, and she's working as consultant at Rainbow Hospital, Hyderabad for the last 7 years. She also worked as assistant professor at Maheshwara Medical College, and she is a like MD from Osmania and MBBS from Andhra Medical College, Visakhapatnam, and she has conducted several patient education programs. I welcome Dr. K. Swarupa to deliver her talk on vesicular diseases serology.
Good morning, everyone. Thank you, committee, for giving me this opportunity. And today, my topic of presentation is immunoserology.
Sorry to interrupt, madam. Your voice is not clear. There is some problem with the audio. Can you please fix it?
Yeah. Is it okay, sir? Is it okay?
Even now there is an echo, madam. I think you can, if you have logged in through 2 different devices, you can log in through only one.
No.
Only one? I think you can go ahead, madam, please.
Is it audible?
It is audible. There is some echo, madam. Yeah, please go ahead. Please go ahead.
Yeah. I would like to share my screen. Am I audible now?
You are audible. Please carry on.
Yeah. Good morning, everyone. Thank you, Sci Committee, for giving me this opportunity of presenting immunoserology in these visual disorders.
There's a suggestion to try without earphones, Dr. Naeem. Yes.
Dr. Swarupa, can you please try without earphones, please?
Yeah. Is it okay now?
Not okay. Yeah, I think we need to go ahead like that.
Okay. Yeah, okay, sir.
And now it is better. It is better now. Please go ahead. Yeah.
Okay. My topic of presentation is immunoserology in vesiculobullous disorders. Before going to because it is about all the antigens, I would like to briefly describe about the antigens, the anatomy of these desmosomes and hemidesmosomes. So bullous skin disorders represent a group of organ-specific autoimmune disorders which are characterized by the binding of circulating autoantibodies to the adhesion molecules of the epidermis and the dermoepidermal basement membrane zone. So binding of these autoantibodies to their antigenic targets will result in the loss of adhesion between the keratinocytes as well as at the level of the basement membrane zone. So the common clinical features are chronic blisters and painful erosions, and sometimes secondary eruptions like encrustation, impetusination, and secondary scarred erosions can also dominate the clinical picture. So this is the anatomy of desmosomes. We usually have 3 types of cell junctions, which are called tight junctions, anchoring junctions, and communicating junctions. So tight junctions are the protein particles which present between 2 adjacent cells and do not allow the transfer of any molecules between 2 cells. And the second type is the anchoring junctions, which will allow a few micromolecules but not the macromolecules between the cells. And these desmosomes and hemidesmosomes, they belong to this group of communicating junctions, wherein the tissue permeability is responsible for the communication, like changes in the intracytoplasmic calcium or pH values might change the permeability. So coming to this desmosomes and hemidesmosomes, and here if it is in the case of intermediate filaments which differ, like in case of desmosomes, it is the keratin filaments, whereas in adherence junctions, it is the actin filaments which are present, and these are present in muscle cells actually. So coming to these desmosomes, these are tight button-like structures. Desmosomes are tight button-like structures which are responsible for riveting the 2 cells together. So these are, the structure is very complex actually, and the desmosomes are organized in such a way that they join the intermediate filaments or the keratin filaments within the cell to the plasma membrane to the adjacent cell. So thereby acting a button-like structure. And this is the structure of the hemidesmosome. Here it contains an inner dense plaque, outer dense plaque, and this inner dense plaque contains desmoplakins and intermediate filaments or keratin filaments, and the outer dense plaque contains desmoglins, desmocolins, plakophilin, plakoglobin, and these are like through the intermediate filaments, these desmoplakins with their attachments with the desmocolins, they communicate with the adjacent cells. So, but here the main cadarins, which are the desmocolins and desmoglins, are the main structures or the main antigens which are responsible for the integrity of the desmosomes. So any antibodies which are directed against these desmocolins and desmoglins are responsible for the symptoms or the bullous lesions. And this is the structure of the desmosome which is present in the spinous layer, and this is the basal lamina where the hemidesmosomes are present. And the main antigens in the desmosomes are desmoglins, desmocolins, and the plakophilin, desmoplakins, and plakophilins, which are present in different types of pemphigus disorders. So, classification of the blister forming diseases is usually based on the localization of the blister. So, so there are several types of autoimmune intraepidermal blistering disorders. Like we can see that in the intraepidermal blisters, as in case of pemphigus, are very flaccid because they are present in the upper layers of the epidermis. They easily rupture. Whereas in case of a subepidermal blister, the upper epidermal layers, they cover the blister which is present in the lower layer of the epidermis. Thereby it becomes very difficult. That means it does not easily rupture. So we have several variants of pemphigus group, like pemphigus vulgaris. Vegetans is a variant of vulgaris. Pemphigus foliaceus and Fovus alvagum, pemphigus erythematosus, and herpetiformis are again the variants of pemphigus foliaceus. Paraneoplastic pemphigus, drug-induced pemphigus, IgA pemphigus, and the other pemphigoid disorders are the bullous lesions where there is subepidermal loss of adhesion is bullous pemphigoid, pemphigoid gestationis, mucous membrane pemphigoid, linear IgA bullous dermatosis or CBDC, and the adult forms, which is the adult form is linear IgA, and epidermolysis bullosa acquisita. And we also have another subepidermal condition, which is dermatitis herpetiformis. So there is a theory called DSG1-G3 compensation theory. So in this, we have desmoglin 1 and 3, which are variably expressed in the skin and mucosa. Desmoglin 1 is present throughout the epidermis in the skin, and it is it is situated in the upper layers, whereas desmoglin 3 is situated in the basal and parabasal layers of the epidermis. Whereas in case of mucosa, the desmoglin 3 is present, the expression is more when compared to that of the desmoglin 1. So when the desmoglin 1 is inhibited, the DSG3 compensates, that is compensates for the loss of DSG1. So we don't find any oral lesions, whereas for the upper layers, the DSG3 doesn't compensate. So the lesions appear in the upper layers, which is subcorneal pustules appear. Whereas in case of where DSG3 is inhibited, so the lower layers are affected much, as well the mucosa is largely affected because DSG1 doesn't compensate for DSG3. So the blisters are present mostly in the mucosa, and sometimes skin may also be affected. If both desmoglin 1 and 3 are inhibited, then we have both the skin and mucosal lesions. So this is a condition wherein loss of DSG1 causes the blisters in the upper epidermal layers, whereas in pemphigus vulgaris, it is in the lower epidermis because of the loss of DSG3. So pemphigus comprises of a number of diseases wherein the IgG antibodies are directed, and in all the conditions like desmoglin 3 and 1, in pemphigus vulgaris, desmoglin 3 and 1 are the common antigens, whereas in pemphigus foliaceus, it is the anti-desmoglin 1. In case of paraneoplastic pemphigus, in addition to desmoglin 3 and 1, there are antibodies which are directed against desmocollins 1 and 3, as well as an alpha-2 macroglobulin-like factor, and another placophilins are also involved. Whereas in case of IgA pemphigus, it is not IgG but IgA is produced against the epidermal antigens. But the antigens are again desmoglin 3 and 1. So this is the pemphigus vulgaris group. We have 4 variants: vulgaris, vegetans, foliaceus, and erythematosus. So we'll go mostly into the immunology part. We know as the targeted antigens are desmoglin 3 in case of vulgaris, 3 and 1 in some cases, and in foliaceus it is only desmoglin 1. So when we are going for immunofluorescence, IgG plus of which are directed against desmoglin 1 and 3 is present in the epidermal surface along with the complement. Whereas in case of indirect immunofluorescence, will tell you, will also confirm the IgG antibodies which are directed against these antigens. Coming to the hemidesmosome structure, hemidesmosome, these are like, it contains an inner intracellular and the transmembrane plaques. With these inner plaques is attached to the keratin filaments, and plectin and BP230 are the major antigens or in the inner plaque, whereas the transmembrane plaque contains collagen 17, which is also called BP180, and alpha-6 beta-4 integrin. So these components are involved in several diseases like epidermolysis bullosa simplex, wherein this part, the BP230, plectin and keratin filaments are involved. Whereas in case of bullous pemphigoid and pemphigoid gestationis, mucous membrane pemphigoid, here the collagen 17, which is also called BP180 and alpha-6 beta-4 integrins are involved. And this anchoring filaments, anchoring fibrils, which is made up of collagen 7, are involved in the dystrophic epidermolysis bullosa and EBA, epidermolysis bullosa acquisita. So depending on which antigen is involved, we have the corresponding diseases are shown. So coming to the next slide. So this is immunofluorescence findings in case of all the subepidermal blisters. Here we find the linear deposition of IgG and C3 in the basement membrane zone in all the cases, except in the case of epidermolysis bullosa acquisita, it is also seen, but in to differentiate this deposition, we need an indirect immunofluorescence test, wherein the tests like monkey esophagus and salt split skin are used to differentiate the deposits which are present on the epidermal or the dermal side of the basement membrane zone. And here in dermatitis herpetiformis, it is the IgA which is deposited in the papilla of the upper dermal layer. Whereas in case of linear IgA bullous dermatosis, it is again the basement membrane zone, but here the IgA deposits are found. So coming to the differential diagnosis, usually we have some hereditary conditions to be diagnosed, infectious, immunological, and other diseases. Whereas in hereditary, usually the immunofluorescence is negative, and we have specific tests for infectious diseases to rule out. Whereas in case of bullous SLE, here also we have immunofluorescence which is positive against the type 7 collagen. So immunofluorescence is can also be used in bullous SLE. In order to refine the diagnosis, we need the serological tests, which will be discussed later. So to establish a diagnosis of pemphigus vulgaris, it is a Zank smear which is taken from the base of the cells, histopathology from the edge of the blister, direct immunofluorescence on normal appearing skin, and indirect immunofluorescence using the patient's serum. Here, the preferred substrate is the monkey esophagus or the salt split human skin. Here,
Dr.
this
Sarupa, sorry to interrupt. I think you have 2 minutes time left.
2 minutes.
Yeah, we can give you 3 more minutes maybe. Hello? Hello? Dr. Sarupa, please. Dr. Sarupa? Technical team, can you please check?
I don't have doctor here.
Yeah. What happened?
I think doctor logged out. Can we move on to the next one by the time we can get her back?
Yeah, I think so. So Dr. Rakesh, are you prepared with the talk? Like, can we go on? Yeah. So sorry for the technical glitch. I think there was a sudden glitch faced by Dr. Sarupa. So she was suddenly logged out. Anyway, we have next speaker, Dr. Rakesh, Dr. B. Rakesh, who is who has done IADVL observership in dermatopathology from CMC Vellore in 2015 and ICMR certificate course in health research fundamentals in 2016. And he has presented various e-posters, and he is IADVL gold medal winner for topper in dermatology at JIPMER 2015. And he is a first prize winner for award paper in CUTICON 2014 at Srinagar. And he has won several such awards. And he has published 2 papers in IJDVL and 3 case reports published in a book, Puzzling Cases in Pediatric Dermatology by Dr. D.M. Thapa. And presently he is working as consultant dermatologist at Mahavir Hospital. And he is a very young and dynamic person, and he has put a lot of effort in facilitating this conference also. He has been the man behind all this hard work that has gone on, especially the PG's part of the conference. So I welcome Dr. Rakesh Kumar to deliver his talk.
Thank you, sir. But I should not take the whole credit. It has been a collective effort under the guidance of Naeem sir, Rajalakshmi madam, Pavitravani madam. Good afternoon, everyone. Is my screen visible? My sharing screen visible?
Yes, Dr. Rakesh.
So my topic is immunoserology of connective tissue disorders. So what comes to my mind when I first think about ordering an ANA profile or an ANA test? What is the method I would choose? Would it be an immunofluorescence or an ELISA test? How would I interpret the results? Is it the pattern of presentation that matters or the values that matter more to me? What if it is a healthy patient who has a false positive report or is a false negative report? What am I looking for in the reports? Is there anything which will predict a disease organ affection in future? Is there something which can predict progression of the disease, like from DLE to SLE or undifferentiated to a differentiated connective tissue disorders? When I order a myositis profile, can I predict the malignancy risk in such cases? And how do I come to an establishment of antiphospholipid antibody syndrome? So these are the broad doubts which come to my mind each time I order a test. And my talk will be more or less focused on such topics. So it all started with the detection of an LE cell, which was actually a neutrophil, which had engulfed the denatured DNA of a cell which was attacked by autoantibodies or anti-nuclear antibodies. And from there on, a lot of cells, a lot of methods have been developed to detect these anti-nuclear antibodies, which are the major immunoserological tests for connective tissue disorders. There are a lot of methods like indirect immunofluorescence, ELISA, immunoprecipitation, immunoblot. But despite all these years, indirect immunofluorescence remains to be the gold standard for initial testing. It's a highly sensitive test. The result is in interpretation either as a pattern, like a homogeneous or a speckled pattern, or in titers. Previously, rodent cells, liver and kidney cells were used as substrates in the indirect immunofluorescence. However, majority of the labs have now shifted to the human HEP2 cell lines. Why is this important? So you need to check the cell line that they have used, because the rodent liver or kidney cells, they lack the classical anti-Rho and anti-La antibodies. So that was why there was a high incidence of ANA negative SLE cases in the previous days, almost reported to be 15% when rodent cell lines were used. But with current HEP2 cell lines, the incidence has come down to 1 to 2%, thus leaving it more of a historic finding. ELISA, it's a rapidly available test, which is less expensive, more convenient. However, there are few drawbacks for this method of testing too. The pre-coated wells that we use in ELISA, they can only display a limited number of autoantigens. And during the procedure, there's a high chance of denaturation of the autoantigens, giving a false positive result. Hence, ELISA as an initial screening test would not be recommended because of these limiting factors. Immunoprecipitation and the immunoblot, which almost gives the entire spectrum of the autoantigens that we are looking for, helpful for research purposes, helpful to identify specific disease, organ affection, and the risk for progression. So how much of a titer do I take it as positive? So when you look in normal people or in healthy adults, titer of 1:40 has shown to be in a prevalence of 32%, 1:80 around 13%, 1:60 around 5%, 1:320 around 3%. So as the titers increase, the chance of a healthy person being positive for ANA decreases. Although greater than 1:40 is reported as a positive test, high titers, especially greater than 1:160, could be considered almost diagnostic of CPD. When you're looking for an ANA positivity in a population of SLE, the test has a high sensitivity and high specificity. However, for an unselected population of individuals that we are screening, if we start screening for SLE, the test holds more in case of negative predictive value. That is, it almost rules out a possibility of SLE in the patient. However, the positive predictive value being low, around 30 to 40%. So what are the conditions wherein we can have a positive ANA, but the patient could be a healthy person? So usually we see it in elderly people, relatives of patients with connective tissue disorders, pregnant women, patients with neoplasms and post-solid organ transplants, chronic infections like Epstein-Barr virus, and even in certain healthy adults. So what helps us in differentiating is again the titers. High titers, more chance of it being a true positive. So what is the prevalence of ANA with respect to the diseases, the routine connective tissue diseases that we usually come across? So it's almost around 100% in cases of SLE. That suggests a high specificity and high sensitivity. As in systemic sclerosis, 97%, dermatomyositis, 40 to 80%. So you can still have a negative ANA patient with a positive, with features of dermatomyositis and Sjogren syndrome too. Where and all the criteria require ANA as a must for the diagnosis. That is in case of drug-induced lupus, where you require antihistone antibodies as a must. Mixed connective tissue disorders, wherein the ANA titers greater than 1:2000 to 1600 is a must for the diagnosis. When interpreting the result, we always get to see these patterns: homogeneous, peripheral rim, anticentromere, speckled particulate, nucleolar. But are they all specific? Do they all accurately predict what the affected autoantigen is? No. The only pattern which is considered to be highly specific is the anticentromere, which is presenting as a discrete speckled pattern, classical for the limited cutaneous form of systemic sclerosis. Most of the labs report a homogeneous and a peripheral rim pattern, which corresponds to the double-stranded DNA. So, nucleolar pattern responding to more or less the topoisomerases. Rim pattern, which is now an obsolete, it was seen more with the rodent cell lines. Speckled pattern corresponding to the ribonucleoproteins and the homogeneous pattern corresponding to the anti-double stranded DNA. So this is how the immunofluorescence study looks. Homogeneous peripheral rim is a classical discrete speckled pattern corresponding to the anticentromere, and the speckled pattern which corresponds to ribonucleoproteins and your extractable nuclear antigens like Rho, La, Smith, U1RNP, and then the nucleolar, which corresponds to your SCL70, RNA polymerase 3. We always see 3 plus, 1 plus, 2 plus. What does it signify? The more the fluorescence, the greater is the positivity they report. Coming to specific diseases and how we interpret the immunoblot or the ANA reports in such cases. In SLE, there are autoantibodies against the chromatins, against the histones, against ribonucleoproteins, extractable nuclear antigens. There's an endless list. But which of them am I looking at when I see the report? What am I searching for? Which of them are highly specific, which can predict an organ affection in future? So one important single most factor is the double-stranded DNA. Why? It has direct association with lupus nephritis, and the levels also correlate with the activity of nephritis and the worsening of glomerulonephritis in future. RRNP corresponds with the neuropsychiatric LE symptoms. You have a lot of other antigens that you see, but what are more specifically important? Single-stranded DNA. Remember, we were looking for predictors which would guess whether a DLE patient can progress to SLE. Yes, single-stranded DNA is one such pointer which tells us that there's a possible risk for early SLE development in DLE patients. The Rho and La antigens, they are a linked group of antigens. Invariably, when one is positive, the other tends to be positive. And they are classically related with your photosensitivity, with your subacute cutaneous lupus form, with your neonatal LE and the chance of congenital heart blocks. Beta-2 glycoprotein 1 positivity in SLE patients puts them at a higher risk of thrombosis. Yes, presence of antibodies against histones is a 100% required criteria for diagnosis of a drug-induced SLE. But this is only for drug-induced SLE. The other form of LE which drug-induced high risk is SCLE, wherein the drugs usually again induce anti-Rho and anti-La antibodies in that case. Coming to the other second disease that we commonly see, that is dermatomyositis. What am I looking for when I order a myositis profile? There are two sets of antibodies that we check for, myositis specific and myositis associated. The specific are the amino acid tRNA synthetase antigens. So they all correspond to the anti-synthetase syndrome that we get to see in dermatomyositis. The myositis associated antibodies are the U1, U3, PMSCL. They are more associated with the overlap forms. So what is the specificity of these autoantibodies in case of inflammatory myositis? MI2 presence is correlating with classical cutaneous symptoms of dermatomyositis. P155, it's more or less seen with amyopathic forms of dermatomyositis and an increased risk of malignancy. The JO1, PL7, PL2, well, all these correspond to your anti-synthetase syndrome. When I find an anti-SRP positivity, I'm more worried because it has a fulminant prognosis, bad prognosis, high risk of mortality. There's chance of cardiac involvement with myocarditis. And I wanted to mention this MDA5. It's associated with a rapidly progressive form of interstitial lung disease. And unfortunately, the highest incidence of positivity is found in us, that is the adult Asians, with around 45% positivity. The low specificity forms are the overlap forms, PMSCL, U1RNPs. And even ANA, we had seen that only 40 to 80% of dermatomyositis patients are positive for ANA, but it's more positive in case of amyopathic forms. Yes, we were looking what could give us a prediction from underlying malignancy risk in idiopathic inflammatory myositis. Almost 30% risk is present in such patients. More in case of elderly age, atypical symptoms, cutaneous vasculitis, not responsive to medications, and raised ESR. In this slide, if you would have noticed, there's a specific demarcation of non-CAM and CAM. CAM corresponds to cancer-associated myositis. What do you see here? In case of cancer-associated myositis, the autoantibodies are all zero. The frequency of being positivity is very low or zero. Only one is there, that is P155-2, which is found with almost 50% frequency. What does this give me a clue for? If I'm looking for an underlying malignancy in a patient with dermatomyositis, when I check the routine myositis profile, if the antibodies are absent, I search extensively for malignancy. If they're present, I check which one is present, whether it's anti-P155 and 140. If it is present, again I search intensively for malignancy. With the other antibodies, I still maintain an awareness for 3 to 5 years period, especially in elderly people and in the male sex. Coming to the autoantibodies which we see in systemic sclerosis, kinetochore or the anticentromere form is the most specific pattern that we see on an ANA corresponding to the limited cutaneous. The topoisomerase 1 corresponds to the diffuse cutaneous. Amongst these, the presence of RNA polymerase 3 is a bad prognostic factor, especially increases the risk of renal crisis in patients with systemic sclerosis. 40% of all patients with systemic sclerosis will lack all antibodies. So always a clinical and a serologic correlation is important. Presence of anti-RNA polymerase 3 in case of systemic sclerosis is a marker for an internal malignancy, again pointing us to search intensively. Usually these patients have a high skin score and a bad profuse cutaneous involvement. Antifibrillin increases the risk of pulmonary artery hypertension. In Sjogren's, we all know this anti-Ro and anti-La, but actually speaking, the Fodrins are the more specific antibodies in these cases. Anti-Ro and anti-La are also associated with risk of, apart from the Zika symptoms, neonatal LE and congenital heart block. What about other connective tissue disorders wherein my ANA plays a role? One is MCPD. The specific criteria is that high titer anti-RNA antibodies should be present to diagnose an MCPD. So once again, immunoserology plays a role in establishing the diagnosis. In undifferentiated connective tissue disorders, nearly 30% evolve into definite connective tissue disorders. So what am I looking for to predict that there can be a chance of a specific connective tissue disease? One is a high ANA titer in such cases. Greater than or equal to 1:640 has shown to have a high odds ratio and a high p-value or probability. Presence of an anti-centromere antibody at baseline will predict the risk of development of a definite connective tissue disease in such patients. The other...
Rakesh, you have 2 more minutes.
Yes, sir, 2 slides. So the other disease which I am confused when I order for the immunoserology is the APLAS. Yes, the laboratory criteria are very important. Presence of lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies are a must for diagnosis. But what matters, can you see here is 2 or more occasions at least 12 weeks apart. Why is this important? Is to rule out false positives during infections, during cases of acute thrombosis, and patients on anticoagulants. False positive test for syphilis, we commonly see as a risk factor for APLAS, but it is not sufficient. However, it points to us that we should search for an anticardiolipin antibodies. So what are the learning points from my talk that I would suggest to take home? One, the pattern of test. The indirect immunofluorescence should be considered as the initial screening test in contrast to the ELISA. The patterns are less specific, so don't establish a diagnosis just based on a pattern, except for the anticentromere one. Titers do matter, especially to rule out false positives, rule out healthy individuals, to establish MCTD, and to predict risk for UCTD. Yes, end organ affecting prediction is possible using the immunofluorescence test, which is in case of double-stranded DNA for renal involvement in SLE, RNP for neuropsychiatric involvement, anti-Ro for congenital heart blocks, progression risk from DLE to SLE, positive anti-double and single-stranded DNA, UCTD to CTD with high ANA titers, malignancy risk, yes, absent autoantibodies, or a positive anti-P155 140 in case of inflammatory myopathies, and RNA polymerase 3 in case of systemic sclerosis. And APLAS, repeat tests after 12 weeks and watch for moderate to high titers in order to establish the diagnosis. Thank you.
Thank you, Dr. Rakesh, for a wonderful, informative talk. As always, you have done a nice talk. Thank you.
Thanks.
I think we now have Dr. K. Swarupa back here. So I will request her to resume her talk. And one more thing is, since the parallel session in the other hall is running a little slow, so we are behind schedule in the hall A. So I think Dr. Swarupa can take about 7 minutes. So please resume, madam. I think you are facing a lot of glitches.
Sorry for the interruption.
Please go ahead. No problem. Please go ahead.
Actually, I think from this slide, I couldn't share, I think. You were able to view this last time in the presentation?
Yeah, I think so. Yeah, you can go ahead.
Yeah.
The previous slide. Yeah.
Yeah. Yeah. In case of indirect
Please put it in
immunofluorescence.
slideshow, madam.
Full screen, please.
There is one slide on. Yeah.
No, it will be in the down barrel, ma'am.
Now you see that plus minus sign in the bottom.
Madam, I think we'll be running short of time. Please go ahead. And I request you to please go to the serology part.
Yeah, I'm going to serology.
Yes.
Remote control of it. PDR.
Yes.
Yeah.
Yes, we are able to see the full screen, madam. Please go to the serology part.
Yeah, this previously it has been previously because the different substrates were used like monkey and monkey esophagus and bladder and liver. There we had many antigens which were giving the false positive results. So in order to avoid that, we have an antigen specific serological assays wherein this can be accomplished using monospecific antigens which are used in indirect immunofluorescence, ELISA, or immunoblot tests. Here, the antigenic substrates have been made available by means of recombinant expression systems, and by using the immunoreactive epitopes and deleting the domain that causes non-specific reactions, the sensitivity and specificity of the tests have been improved. So in this case, BP180 contains the NC16A domain, which is the most common antigen in all the bullous pemphigoid and other related disorders, wherein this has been made 4 times so that the antibodies could be easily identified. And so these antigens could be either used as a substrate. These are coated either in the along with the substrate on called biochips, which are arranged on the slides, and they are incubated, or these are antigens are directly put onto the biochips, so that it could be either substrate coated with antigen or only the antigen which is being used, and this would help in identifying the antigens separately for DSG1, DSG3, BP230 and type 7 collagen, because they were together, wherein many antigens could be isolated using single substrates, but here independently each antigen could be identified separately. In this picture, we have DSG1 ectodomain, wherein so here we could identify the desmoglin 1 antigens. And in the second picture, we have desmoglin 3 type of ectodomains could be identified. And C and D, we have 230 and type 7 collagen. And E and F is the more refined one, which is tetrameric form of NC16A. And this is the anti-gliadin antibodies which is present in dermatitis herpetiformis. Along with that, biochip mosaics also have been used, wherein at a time many substrates could be used, like many antigens could be used at a time. Here in this case, we have used 6 antigens together. Here they have used 11 antigens, and at a time they could identify many antigens, or and this would help in specificity of identifying the specificity of the underlying conditions. Like it could be only the specific condition of in many types of subepidermal bullous diseases. And we have the same antigens have also been used in ELISA, and this is used to confirm and differentiate autoantibody specificity, supporting the diagnostic attribution of ABD subtypes, because ELISA is more quantitative, helps in the quantitative measurement of the diseases, enables the disease and therapy monitoring. And the quantitative measurement of these anti-BP180 antibodies, the levels of which, if they are increased, we can identify that the condition is going to relapse. And if they are decreasing with our treatment, we can identify that the condition is getting under control, or and also we can reduce the dosage of our treatment or adjust the dosages regarding the results of these treatments. So further advantages of ELISA include standardization and easy handling, and commercial availability and easy availability. So these are the specificity index, sensitivity and specificity indices for specific antigens in pemphigus foliaceus. So this anti-desmoglin 1 antibodies, the sensitivity is higher and the specificity is more compared with other immunofluorescence tests. And immunoblotting is another condition, another test, wherein it helps in identifying the rare autoantibodies like laminin gamma 1, LAD1, laminin 32, anti-desmoplakins, and alpha 6 beta 4 integrins, which have not been isolated, where the antigens could not be isolated and used in ELISA or other tests. But these tests will help in identifying the rare autoantibodies. And immunoblotting is not recommended in cases of DSG1 and DSG3, where there is a compensation effect because of the compensation effect of DSG1 and DSG3. And this is not recommended in patients having, so it is not recommended in anti-desmoglin in pemphigus, but the results are more superior for rare autoantibodies. And the immunological monitoring, diseases correlate with the disease activities in case of the antigen levels correlate with disease activities. In case of these antigens, the DSG1, G3, BP180, and type 4 collagen, type 7. But in case of 230, that does not relate with the disease activity, so we can't monitor with the BP230 levels, whereas BP180 is helpful in monitoring the disease activity. It is subjective and it produces semi-quantitative data based on serial dilutions in indirect immunofluorescence, whereas ELISA will provide quantitative and objective assessment. Therefore, ELISA is routinely used in many laboratories. Accurate diagnosis and discrimination is crucial for therapeutic diagnosis and prognosis. So patient management will further benefit on the research of the on other researches which are being done, like from the other forthcoming treatment options, wherein the pathogenic role of IgE class in autoantibodies are yet to be found out, and probably this might help further.
Thank you, Dr. Keso, for a good informative talk. So nice of you that even after technical glitches, you have been back. Thank you.
Thank you so much, sir, for giving so much time. Sorry for the interruption.
That's okay. That's okay. We all face these technical problems nowadays. We don't have any other option. So thank you.
Thank you, sir.
come to an end of this session. So I thank the organizers and the scientific committee for giving us this opportunity to chair this session on behalf of Dr. Nipadevi Madam.
Thank you.
Dr. Nipadevi Madam, you can speak.
Yeah. Thank you, the organizing committee, to give me the opportunity. Thank you very much.
Thank you. Back to the hall coordinators.
I thank you. I thank you, Nipadevi, and also maintaining the time schedules and also maintaining these technical issues. Okay, thank you, sir. We will move on to the next session, which is most awaited, lasers. For this session, I will like to call the chairpersons, Dr. K.S. Ram and Dr. Radha Shah. Dr. K.S. Ram, sorry, the senior consultant dermatologist in the skin and hair elegance, and he is also working at the Abyss Hospital and Ambrosia Aesthetic Center in the Banjara Hills. He is the HOD at Leo Jaganta Aesthetic Medical Institute. Okay. So Dr. Radha Shah, next slide please. She has completed both MBBS and MD from the Lokmanya Tilak and experience in the hospital at Dr. Savant work, and has published both national and international publications. She has awarded for the best Aramba and paper presentation in several conferences. I would like to hand over this session to the chairperson. Thanking you, sir. Last one. One of them. Last slide. Not this one. No, the end slide.
Okay, so just a second. This one, sir?
Last, Aurangabad, sir.
Okay.
Dr. Kesram, sir, can you invite the Dr. Sanjay Aurangabadkar, sir, to give his lecture on the lasers?
Good afternoon, everybody. In spite of the time schedule being behind, I wish all the speakers of this session best of luck. And at the same time, now I would like to introduce one of the luminaries of our IADVL, none other than Dr. Sanjay Aurangabadkar. He's awarded the IADVL medal for the best outgoing student in MD dermatology exam from the NTR University, AP in the year 1998. He is an international fellow of Mount Sinai Medical Center, New York, USA, and is a recipient of the International Society of Dermatology and scholarship at the World Congress of Dermatology in Buenos Aires, Argentina in 2007. He is the managing editor of the Journal of Cutaneous and Aesthetic Surgery and a reviewer of the Indian Journal of Dermatology. He was national coordinator of IADVL, SSG Lasers and Aesthetics in the year 2013 to 2015. He published guidelines for laser treatment of pigmented lesions and tattoos in IJDVL. He has more than 20 publications in index journals and has written many chapters in textbooks on lasers and photography. Now I present Dr. Sanjeev Aurangabadkar to you.
Thank you so much, Dr. K.S. Ram, for this kind introduction. It's a pleasure to see you virtually, if not in the conference. But I first must compliment the organizers of TSIDVL. They've done a great job. The conference has been a remarkable success with very good coordination between everybody and a good teamwork. So I would like to start my presentation because we are already running short of time. I would like to start with my presentation, which will be on lasers for dermatologic indications. Now, when I was given this topic, I realized that it's a very vast subject. I mean, I need to cover a lot of things. So for that matter, what I have done is I'm going to talk less on theory and more on practical points. And I will be showing you many pictures before and after, so that you get an indication as to what a laser can do. But my only humble request is, please do not click, take screenshots, because they're my personal patients. Now, lasers are an integral part of dermatologic armamentarium, and today seldom a practice of dermatology is complete without lasers. My journey started almost 20 years ago with a fellowship in the US in Mount Sinai Medical Center. And after that, I got my first laser, which was a long pulse Alexandrite laser for hair removal. And now you can see that the Alexandrite laser has gone a full circle and it has come back again for hair removal, though in a little different avatar. Then currently, I'm using various technologies, including an IPL-based super hair removal or in-motion hair removal, LinScan diode laser, which is a diode laser with a scanning mode. And also I have carbon dioxide laser, Q-switch lasers, erbium YAG laser, as well as the excimer laser with various other energy-based devices. Now, medical management of certain conditions is not an option in many situations in dermatology. Laser therapy, though it is challenging, but it is extremely gratifying in many dermatologic indications. That is what we are going to talk about. Proper patient selection, choosing the right device and the parameters is essential. Always prime the patient, particularly in Indian skin types. You have to make the patient educate regarding sunscreen use, topical skin lightening agents. They all go a long way in giving satisfactory results. Then counseling, consent, photography, they're all essential for getting good results, as well as to document your progress. Then long-term follow-up is mandatory for most laser treatments. Now, this is my outline. I'm going to talk about pigmented lesions, hair reduction, scar improvement, epidermal nevi, as well as vitiligo, etc. So let's talk about pigmented lesions. Epidermal, dermal, and mixed lesions are all amenable to laser therapy. Q-switch Nd:YAG laser is the treatment of choice for these conditions, and picosecond lasers and fractional lasers have now expanded our options, and combinations are now possible. IPL is mainly used for pigment, which is epidermal. Now, this is the laser that I use for Q-switch Nd:YAG technology. This is the Spectra by Lutronic. So this is the laser that I use now. And now, there has been an evolution on technology over the last decade with Q-switch lasers. Nowadays, most lasers have a large spot size, they have high energy, and they have multiple wavelengths apart from the 1064 and 532. And also you have the ability to use a quasi long pulse mode, which is the microsecond mode rather than the nanosecond mode. Then you have the ability to split pulses. You need to have a top head beam profile with high peak powers. Now, what are the approach to epidermal pigment? You need to use a shorter wavelength, such as 532, but 1064 can also be used. 660 nanometer can also be used for epidermal lesions. Then use of a large spot size, use of a spot size which matches the lesion is recommended. Interval between sessions is 1 to 2 months between sessions. And just 1 or 2 sessions are enough for epidermal pigment to give good results. And usually in darker skin types, you need to use lower fluences with minimal overlap. So let us look at some of the conditions that we have treated. Now, this is a patient who had nevus on the upper eyelid as well as on the temple area. I treated her with the Paloma QEAC5 with these parameters, and you can see that a remarkable clearance of the nevus on the eyelid. I had to use a laser corneal eye shield to protect the eyeball, and then the patient had a remarkable improvement. Now, this is a case of lentiginosis, which is very simple to see. And though you can use your Elman, you can use TCA, so many things can be used, but I don't think anything is as quick and as effective as the Q-switch laser. And here you can see with a 532 nanometer wavelength, almost a remarkable clearance of the pigment of the lentigens. Even here again, a centrofacial lentiginosis, you can see a remarkable clearance. A solar lentigo in an elderly woman can also be treated very nicely with the Q-switch laser. This is a case of segmental lentiginosis or a nevus pilus, which has a background cafe au lait macule with the lentigens on top. And you can see a combination of 532 and 1064 is what I used. And you can see a remarkable clearance of pigment. Again, another case, very difficult cases to treat. Apart from this, all you can recommend the patient is cosmetic camouflage. But in this case, you can see that the patient had a very nice lightening of her segmental lentiginosis. This is again a very tricky condition, which is cafe au lait macule on the upper lip. And seldom do you get a very good result. But if you use the right technique, right combinations, I used a combination of 532 and 1064 in the same session. And you can find that after 6 sessions, nearly magical clearance of the cafe au lait macule. And I'm following her up. Now, dermal melanosis are again very difficult to treat. These are heterogeneous group of pigmentary disorders with inflammation at the dermoepidermal junction with pigment incontinence as the main histology. They're refractory to medical management, and target chromophore here is the melanin, and these are the conditions that we treat. So let us look at lichen planus pigmentosus, which these days I'm very, very pleased to treat, and I'm getting some nice results. So this is the standard treatment that I follow. Control the inflammation, use short course steroids, topical immunomodulators, etc., followed by Q-switched Nd:YAG laser once a month for about 5 to 6 sessions. And these are the parameters that I use. So this is a case of LPP. You can find a remarkable improvement in the pigment on both the temple areas here. Again, you can see almost the patient had like a raccoon eyes kind of a picture, and then it cleared nicely. Again, another case of LPP with a very good clearance. This is on the other side. You can see the improvement on the neck as well. And this is another case of LPP. Another case of LPP, you can see a remarkable clearance of pigment on the perioral area here. And the patient was so pleased after the treatment. This is another case of LPP. You can see a good clearance of the pigment. This is on the other side of the face of the same patient. This is another case of LPP. You can see that ashy bluish gray pigmentation. And after a few sessions of Q-switched Nd:YAG, the patient was again very satisfied. Even on the neck, you can find a remarkable clearing of the pigment. This is on the other side of the same patient. Now let us look at Horis nevus. Horis nevus is acquired bilateral nevus of like macules, quite resistant to treatment. Typically, I use shorter intervals once in 4 weeks. And Q-switched Nd:YAG in a combination of 532 and 1064 gives better results in this situation. So this is a case of Horis nevus with the remarkable clearance of pigment on the cheeks. This is the right side of the same patient. You can see the good improvement. Nevus of again is a classic indication for Q-switched Nd:YAG laser, as we all know. And of course, I won't go into the details. You all know what nevus of is. These are the different patterns of nevus of including bilateral nevus of Tannino classification. You can see all the different varieties over here. Never forget to look into the tympanic membrane as well as in the mouth, because you can find pigment in the hard palate also in this patient of nevus of So this is my standard protocol of treatment. And I have treated more than 250 cases of nevus of with no recurrences, more than 90% clearance in most cases with minimal complications. Now, this is one of my first patients of nevus of You can see a remarkable improvement. Again, another case of nevus of one more case over here. So you can see that every single case, this is a really, really very heavily pigmented nevus of but after about 10 to 11 sessions, you can find a remarkable clearance. This is a case of bilateral nevus of again, excellent clearance. This is another nevus of So we have a lot of nevus of and then this is again another case of bilateral nevus of and this is, remember that this is in type 5 skin. So it's not easy to treat these kind of skin types. And then once in 2 to 3 months is what I treat the patient for about 6 to 8 sessions, and you can see a good improvement there. Now, remember that if you have a Q-switch laser, which has a very small spot size, then you will end up with the post-inflammatory depigmentation, almost a guttate hypomelanosis kind of a pigmentation. So I would recommend not to use 4 millimeter, 3 millimeter spot size for treatment of nevus of Now, melasma is another indication which is now being widely treated with lasers. Of course, it is never the first line therapy, not even the second line. It's always the third line therapy. And here you use the Q-switch laser in the form of what is called low fluence laser toning, where you use a very large spot size, low fluence, that is roughly about 1.2 to 1.3 joules of energy, and 1064 nanometer wavelength, almost like a paintbrush fashion, multipass technique, where the endpoint is not frosting, the endpoint is only a mild erythema with little bit of warmth of the skin. So you just touch the skin and you can feel the warmth. But you can combine laser toning with IPL. You can combine it with gold toning, which is the 585 nanometer low fluence Q-switch Nd:YAG laser treatment. So 585 is a vascular wavelength. We know that in melasma, vascularity is known to be one of the features. So here you use a combination. You can also use what is called dual toning, where you use a 1064 nanometer at nanosecond pulse duration, as well as in a quasi-long pulse, that is 300 microsecond pulse duration. So what is the mechanism of action? It is subcellular selective photothermolysis, where it leads to, the low fluence leads to dendrectomy of the melanocyte, so that the transfer of melanin from the melanocyte to the keratinocyte does not happen. So that is how it works. So this is the some of my patients of melasma. These are patients who are stubborn patients who have done everything possible, and then only when after adding some Q-switch Nd:YAG, the patients got some improvement. Otherwise, they had done every possible peel, every possible topical agent was used before treatment. Now let us look at some hair reduction. So hair reduction is popular even after 20 years. There has been an evolution in technology, but not a revolution. So you know that you have multiple wavelengths, you have different kinds of machines available for hair reduction. I use the Alexandrite laser, then I use the in-motion hair removal, and then now I use the diode laser. So this is the paradigm for use, especially if you're dealing with the dark skin type, use longer wavelength. If you want to treat finer hair, you use a shorter wavelength, as well as if you want effectiveness, you have to use a shorter wavelength. So now this is the classic endpoint of treatment of hirsutism. This is the perifollicular erythema and edema, which you can see on the chin of this patient. And then these are some of my patients with hirsutism. You can see a very good improvement in the unwanted hair. The patient had pseudofolliculitis because of constant plucking of the hair, and then that also improves remarkably after doing a laser hair removal. Very dark skin with the severe hirsutism. Again, after 3 sessions, there's a good reduction in hair. Again, this is the PIH that can occur in dark skin type, so you have to be very careful. Again, a case of severe hirsutism with PCOD, and you can see an improvement in the hair in that patient. So let us look at some scars. Fractional lasers are used for scars, burn scars, keloidal hypertrophic scars are all treated with that. So one of my patients had a hypertrophic scar on the cheek over here. I treated her with ablative fractional laser with topical triamcinolone application like a transdermal drug delivery. So you can see a very good clearance of the pigment and also the flattening of the scar. Also, I did a series of carbon peels in this patient. So you apply carbon solution, then you use a Q-switched Nd:YAG laser, and you can see the acne and PIH also improve significantly. So post-herpes zoster scarring can be treated with erbium YAG. Again, a case of pigmented atrophic burn scar, which we find so often nowadays. So with this, you can find a remarkable improvement in the pigment. This was treated with ablative fractional laser with application of topical triamcinolone acetonide. So let us look at epidermal nevi. Again, these are different patterns, world pattern, linear pattern. So many patterns of epidermal nevi are there. And then carbon dioxide laser is ideally suited for this. In this patient, I used a combination of Elman along with the CO2 laser, and you can find a remarkable improvement in the epidermal nevus. Again, another case of epidermal nevus treated with just a simple carbon dioxide laser, not a fractional laser, just an ablative CO2. And you can see that CO2 can do magical treatments, and then you can find a wonderful clearance. This is again another case of epidermal nevus. Another case of epidermal nevus. You can see with the CO2 laser, you can give the patient a complete new life where they don't get married because of this, and then you can see you can transform their lives with a simple CO2 laser. Again, another case of epidermal nevus. This patient came to me about 10 years ago, and she has been coming to me for follow-up, and you can find that her epidermal nevus is totally cleared. Even on the eyelid, she's almost 80% less. And now she came back pleased, saying that she just got married. So this is another case of epidermal nevus on the cheek, another on the jaw, epidermal nevus on the nose. You can find significant reduction with the CO2 laser. In this, I used a combination of Elman followed by a CO2. Now, let us look at excimer light, which is again a very, very important modality of dermatologic therapy. And its various indications can be treated with this: vitiligo, psoriasis, prurigo, LP hypertrophicus, as well as alopecia. So we all know that the excimer laser is very expensive, whereas the excimer light is a little more reasonable. And biologically, the effectiveness of the monochromatic light of excimer, as we all know, results primarily from the apoptosis of the lesional T lymphocytes. So the necessary dose for this effect is lower than the conventional narrowband UVB phototherapy. So let us look at some of the vitiligo. This is my protocol for treating vitiligo. And what I found is that just in a few sessions, the patients have a good result. This was a young girl, barely 6 years old, and I treated her with the excimer, 10 sessions. You can see a good improvement. Another case of segmental vitiligo on the right cheek. This is the result after 15 sessions, along with tacrolimus topically. Acral areas, though they're difficult to treat, with the excimer with high energies, you can find a significant improvement. Look at the thumb over here. So you can find a very good improvement over here. Even on the ring finger, you can find the patient had very good improvement in the, even mucosal vitiligo can be treated with excimer. So this was a patient who I treated with the excimer once a week with tacrolimus, and you can find improvement in the lips, improvement on the cheeks as well. Again, the same patient on the other side, she had all these diffuse, hypo to depigmented patches, and along with the depigmentation on the lips, you can find a good improvement. This was another case of focal vitiligo on the nose. After 10 sessions, you can see a near 100% clearance of the vitiligo. This is another case of facial vitiligo, which was treated. Now, alopecia, I know we have many modalities to treat alopecia areata. This was a case of alopecia totalis. Patient was totally, the parents were really frustrated. They were not getting any results with the various modalities, and giving an intralesional steroid on the entire scalp can be quite painful in a young person. So in this case, we tried excimer laser. And then with the excimer laser, I combined it with the topical minoxidil. And then the patient had, after about nearly 20 sessions, nearly complete regrowth of the hair. So to conclude, lasers have brought new hope and new optimism to our patients. Lasers are tools that, though effective, there are limitations. One is the cost, one is the time required. We need to work around them. Complications need to be kept in mind, especially while treating dark skin types. Always under promise and over deliver. Thank you so much for a patient listening. I hope it was useful.
Excellent presentation, Sanjeev.
Because of shortage of time, I tried to cover as much as possible quite quickly. So I hope I wasn't too fast.
You are very thoughtful, and it was very nice and very informative.
Thank you. Thank you so much. So I've stopped my screen share. I think you can move on with the session.
Dr. Kesram, can you
unmute yourself, Dr. Ram? We can't hear you.
Is it okay?
Yeah, now it's better.
So one of the well-known Dr. Sudhavani Damarla is here now, and she is an associate professor in the Department of BBL in Usmania Medical College, and a consultant and founder for Sri Skin and Dermatology Center in Hyderabad. And she did her MD dermatology from Gandhi Medical College, and she had a number of publications, around 19 for her credit. And she is one of the well-known dermatologists in the Twin Cities. Now, I present Dr. Sudhavani to you.
Thank you, sir. Thank you very much. Respected chairpersons, seniors, and dear colleagues, welcome to the panel discussion. Today, we are having eminent panelists with us who are well acquainted with the lasers, and I am grateful to moderate this session. So one of the panelists is Dr. Sanjeev Aurangabadkar. No need of any introduction. He is a pioneer in introducing lasers in Hyderabad, and not only in Hyderabad, I can say in India. And he is the managing editor of Journal of Cutaneous and Aesthetic Surgery and the reviewer of the Indian Journal of Dermatology. Also, he published many papers on lasers. And next, please. Our next panelist is Dr. Padmavati Surupaneni. She is a well-known consultant dermatologist, founder of Pregna Skin and Laser Clinic Hyderabad, and she has 20 years of very good experience in dermatology and cosmetology. And Dr. P. Usha, she's one more well-known dermatologist and cosmetologist, founder of Samanvi Skin Clinic, practicing in Hyderabad for the last 18 years. And she is also founder and CEO of Samanvi Institute of Dermatological Sciences. And she is a student of Gandhi Medical College. And our next panelist is Dr. Nimmi. Nimmi, she did her MBBS from SVS Medical College, Mehboob Nagar, and PG from KIMS Naketpalli. She trained from Dr. Anchala's Skin Institute and Research Center, Jubilee Hills. And she also worked with Dr. Anchala Padasardi for the last more than four years. She has presented many studies, case reports, and free papers. And she is a gold medal in mesotherapy study. She won gold medal. And one more panelist, Dr. Gurnadam, is now unable to join with us because of his father's ill health. So we all know that over the years, lasers has become an important treatment modality in dermatology. I'm sorry, I'm unable to share my screen. Yeah. Yes. Are you able to see?
Yeah, we can see it. You can just put it in the full screen mode.
Yes, yes. So over the years, lasers have become an important treatment modalities in various dermatological conditions, and they have revolutionized the treatment practices. But still, there are many new devices under development to give more effective, safe treatment in many dermatological indications. So during this COVID period, most of our dermatology consultations have considered to be non-emergency, and almost all dermatology laser procedures fall in the category of non-essential procedures. But still we are doing some procedures. Still we started doing all the procedures. So during this period, which lasers are you still avoiding? Or are you doing almost all the lasers? I'll start with Dr. Sanjeev.
Right now, Dr. Sudha, we are using almost all lasers. So maybe in the month of May, June, till that time, we were a little hesitant. But right now, we have been using all our devices that are available in our clinic, including fractional lasers, including Q-switch lasers, excimer, everything. All you need to do is take precautions. One, screen the patient properly and make sure that there are no contacts with COVID patients. And then the typical triage when they come in, check their temperature and everything, and then we can treat the patients. And I think in the future, it is going to become mandatory that we will do a RT-PCR or maybe a COVID antibody test and then take the patients for treatment.
Dr. Padma, I think hope you are also.
We also started everything, Sudha.
So almost all started all the procedures. So now we will move on to our next question. This is a patient. She tattooed all this kind of tattoo on her arm, and she came for the laser hair removal. And she doesn't want her pigment to fade. So this is the second session. Previously, she took one session outside, and here there is a loss of pigment. So she doesn't want to. She want to preserve her tattoo. So how do you manage this patient, or how do you do laser hair removal? Dr. Padma.
Okay. So because tattoo removal and then the hair removal, in both the chromophore is the same, the melanin.
Yes,
so in our practice, we try to avoid the laser tattoo areas. We try to cover those tattoo pigment with a plaster or something, and then do the laser on the surrounding areas. That is what we usually practice. I don't think the low level laser also will help. The other important thing you can do is the ELOS technology, the technology with the RF base, which is non-pigment based laser hair removal. Maybe that technology is one thing which can help in patients who want to do the hair on the laser also.
On the laser. Okay. Dr. Sanjeev, would you like to add anything?
First and foremost, the pulse duration used is completely different for tattoo removal versus a laser hair removal. When you're talking about laser hair removal, you're talking in milliseconds, whereas when you're dealing with tattoo removal, you're going to use nanoseconds. So a millisecond pulse duration laser, if you use adequate cooling and if you use the proper technique, that should not dilute the pigment much, number one. Number two, if the patient still is very particular, then what you can do is you can use a micropore tape, just take small strips and cover that area, or you can use a white marker pencil. And since these are more like line tattoos, you can just mark with the white marker pencil, and then you can treat. But ideally, marker pencil is there now, the white colored marker pencil, so it kind of reflects light back. So you're not going to affect that unless you're going to use contact cooling. Then it's a little difficult because it will rub it off. But suppose if you're using a machine with Zimmer air cooling, then that should not be a problem. But ideally speaking, the pulse duration is totally different. So you're not going to really dilute. You're not going to get much dilution of pigment.
She wants to undergo hair removal and she wants to preserve the laser.
Yeah. If you use a hair removal device, what is the typical pulse duration you're going to use?
No, but in the same
30 milliseconds, 100 milliseconds is what you're going to use. So it will not affect the pigment unless you're going to go very, very high fluences. That can cause some blistering. So blistering will cause indirect pigment dilution, not the rupture of the tattoo particles.
Anyone? Dr. Nimmi?
Yeah, actually, suppose if because here you have a competitive chromophore, wherein along with the dermal, the follicular melanin as well as the pigments and the tattoos are interacting. So here I think even the pulse duration, all that matters. When you have a proper wavelength and pulse duration, I think the lasers which can affect the deeper, that is the follicular area, we can use that. Probably if any experience with other than diode lasers.
Padma, would you like to tell anything? Final one.
Yeah, I think we covered everything. Only I usually do covering the tape because I've seen a few patients, the normal low clearance also, there will be a pigment dilution if we do different.
So what this is the thing. Lasers cannot tell the difference between this hair pigment and tattoo pigment. So 2 to 3 centimeters area we should leave, and then we should do the laser. Even that white tape or whatever we do, it may not. And electrolysis over that tattoo area, hair which contains, that gives the better results. That is what the suggestion. I did stamp mode for her, leaving 2 to 3 centimeter area in that. So coming to this patient, she is an 18-year-old who wants to get married, and she is having this congenital melanocytic nevus in the forehead. We know that surgery is the best option, but she doesn't want to undergo surgery because of the unibrow problem. So how do you manage this case with the lasers? Dr. Sanjeev?
The best option in this particular case is if the patient doesn't want surgery. Ideally, surgery is the number one option. But if the patient doesn't want that, then what you can do is you can use a carbon dioxide laser, completely ablate the area, and after that, combine it with Q-switch laser.
But carbon dioxide again leaves a pigmentation in our Indian skin.
Yeah, it does. But the thing is, if you use the proper priming and everything, sun protection, there will not be much of PIH.
Will not be much.
And you can easily treat that. So the ideal treatment is surgery. The next option is a carbon dioxide laser, ablated, followed by a Q-switch laser.
She is having hair and that melanocytic nevi. Do you combine the diode also in this case?
Diode also can be used, but the hair is so deep and so thick, the pigment itself is so dense that it is not going to cause much of hair removal with that unless you ablate with the CO2.
CO2. So that is the. So this is another patient who is having this type of hair, and her all hormonal profile, everything was normal, even no PCOS. So how do you manage? How do you approach this case, and how do you counsel, and how many sittings do you promise, Dr. Nimmi?
Yeah, ma'am. Usually, ma'am, like in this, if suppose all the parameters are normal and all that, in fact, first we have to take the detailed history and even the thorough clinical examination. Then again, the scoring, the FG scoring, that is the Ferriman-Galway scoring, which category it falls into. Suppose it's into a mild to moderate or moderate to severe hirsutism. Depending on that, and depending on, suppose if any other therapy she has used before or any other medications she has taken before. So depending on that, we can plan either starting with even the oral medications. We can even add some, directly we can add some OC pills or even any, the other hormonal therapies if required. With the laser, it gives good results. So usually in these situations, if no other underlying cause is there, or it's like an idiopathic hirsutism, first of all, again, we have to take written informed consent and the photographs taken in the area before and 3 months after the sessions and all that. And you can say up to, they can expect around 20 to 75% result in 1 to 6 months duration. And we can increase the fluence by 10% in every sittings. So usually we can prefer, depending on the skin type, we have to adjust the fluence and then plan. In case any
Padma?
medical approach is required or any, ma'am, like all the investigations are normal, like no other underlying, she doesn't have any. Okay, so in that case, we have to treat it like idiopathic hirsutism, wherein most of the times, again, we doubt even we can get the ultrasound done. So 90% of the times is because of the PCOS syndrome and all. So once that is ruled out, we can plan the sittings, and depending on the tone, the color of the skin also, we can approach, the fluence can be adjusted.
That
so
we
for
can,
this skin,
yes. Dr. Padma, would you like to add
little
any
fair,
points?
so we can plan.
I think she's right, but when we counsel, we have to counsel. In these patients, it's looking like not a hypertrichosis, it's a hirsutism. Even
Hirsutism,
if
right.
it's
a hirsutism. Yes.
Hormonal profile is normal, also this hair may be more sensitive to the normal circulating androgens. So counseling, I would tell like she may require more number of sessions, and then after a few sessions, I may have start her on spironolactone if the improvement is not. So this is my
Yes, yeah, we can add spironolactone or OCPs. OCPs also
Yes,
we
ma'am.
can add, and she requires more number of sittings.
Sittings. Yes,
Coming to this acne can lead to atrophic, hypertrophic, or keloidal scars. So how do you treat the different types of scars as shown in this picture? Dr. Usha?
The
Here there is
pictures.
erythema is there. Dr. Usha is...
Yeah, I'm just seeing the picture. Sudha, wait a moment. Mostly we are able to see atrophic scars only. I don't see any hypertrophic scar as it is.
Yes.
Okay, in this case, I would like to go for fractional CO2 laser to go with. Initially, I would like to go for fractional CO2, few sessions, but slight amount of erythematous scars are also there, for which I would like to go in between fractional CO2, I would like to go for IPL or QSESH for the erythematous scars.
So you would like to go with fractional CO2.
Fractional CO2.
Even for erythema?
BMAG also, Fraxel is also okay, but I don't have Fraxel with me. So I'm using only fractional CO2.
Dr. Sanjeev?
First, medically managed, because I still see some active acne in that patient, especially in the lower jaw area. So in that case, simply I'll put the patient on isotretinoin, use topical agents, prime the patient well, and then he will require some amount of subcision, especially on the, there are some rolling scars on the cheeks. So later on, once the erythema and the active acne subside, then I would add subcision along with the fractional CO2 or a microneedle radiofrequency. Even MNRF will do a great job here.
MNRF also, right.
And add some PRP as well.
PRP also, right. When
So it will be a combination approach, so not a single modality.
It is. So this is a case of melasma. I think Dr. Sanjeev covered everything, but we agree that melasma has a vascular component. So what is the role of vascular lasers in case of melasma?
See, copper bromide laser has been suggested for the vascular component, but nobody has a copper bromide laser in India. Even a thulium laser has been suggested for melasma, again, not very commonly available. So ideally, you can use a vascular laser like a pulse dye if you have, but otherwise, as I said, most of the Q-switch lasers have a 585 or 595 Q-switch handpiece, which has basically a converted wavelength. So from the 1064 532, it is converted to 585, 595 by adding a dye kit in between the beam. It goes through the dye kit and then it converts the wavelength. So that can be used, works very well for vascular component as well.
So
and of course, nowadays, to be honest, all of you, I think everybody will agree that with tranexamic acid, I think we are seeing a lot less need for interventions compared to what it was before tranexamic acid.
Anyone would like to add any points? Dr. Padma, Usha?
The same, like we can use an IPL also if you require, but in this case, in this type of skin, I don't think. Mostly the topicals and tranexamic acid, and if possible, NDAG, Q-switch NDAG.
But recent literature shows that oral tranexamic acid has role, but these vascular lasers are not that effective in case of melasma. That is what the recent publications. So we can give combination therapy. And in case in these melasma cases, you straight away start with conventional Q-switched laser or with laser toning. Which one do you prefer?
Always a low fluence Q switch Nd:YAG laser, not a conventional. So it is always low fluence, always low, because as I said, the concept is subcellular selective photothermolysis. You don't want selective photothermolysis here. So you want to destroy and damage the melanosomes, not the melanocytes.
Melanocytes, right. So tattooing, tattoos have become a trend nowadays. With that, tattoo removal also become the part and parcel of this. So this is the one patient with low fluence or low parameters. She developed this bulle. So what is the what could be the reason and how to manage these kind of patients? Dr. Sanjeev.
Yeah, so basically, can you show the picture again for the audience? Yeah, so if you notice the problem is the tattoo is fresh. It looks like a very recently placed tattoo where the pigment particles are much more superficial. And also the pigment particles are very compactly placed, dense in the papillary dermis. So in that situation, when the tattoo is fresh, when the pigment is very compacted in the epidermis, upper dermis, that is when, if you use a Q-switch laser, even if you use a slightly higher fluence than that is necessary, then you will end up with blistering, number one. Number two, what happens is fluence
This
is
1-year-old tattoo.
That's what 1 year old also is. It's fairly recent. Normally tattoos, the longer they are, the more the melanophages and macrophages come in that area and they try to clear it. So what you will have is you will have indistinct borders. A very sharply demarcated border clearly indicates it's a newer tattoo. So whatever it's a blurred margin, then it indicates that the melanophages are trying to clear the pigment. So one, the dense pigment which is compacted in the papillary dermis, and use of a higher fluence. Last point is stacking. If you stack too much, if you're going over and over on the same area again, you will end up with blisters.
So any role of pigments, the type of tattoo pigment, any metal
blistering?
Role for blistering?
I don't think so. It's monochromatic tattoo. It's a carbon-based pigment that you can see here. It's not a multicolored tattoo as far as I can see. And if you use titanium dioxide crystals, or if you use zinc oxide and all those things which reflect light back, so then that you don't even get much of blistering. So blistering is typical where you're having black colored ink which has absorbed a lot of light.
Yes, bulle can occur due to extensive cytolysis of epidermal. So the management is here, the clean the blisters and all, we know this. So topical steroids, topical antibiotics can be given. So another, this is a case of lichen planus pigmentosus. So when do you start lasers after stabilization, or how do you stabilize these lichen planus pigmentosus, Dr. Padma?
So lichen planus pigmentosus, as Dr. Sanjeev clearly said in his talk, first is to prevent like whatever the triggering factors, have to identify trigger and the trigger and then avoid it, and then give a topical steroid and tacrolimus to stay. If it is very severe, you can give, but this is a mild pigmentation, it's looking like a dye pigment actually. You can give a oral steroid also to stabilize, or Dapsone, and sometimes retinoids also work well if it is a severe case. And once it stabilizes, then only I'll start doing a laser to clear the whatever the residual pigment is there. You can start doing a low fluence Nd:YAG, Q-switch Nd:YAG laser. Multiple sessions it requires. You have to counsel the patient very initially that the pigment is dermal. It takes a long time to clear, and you may require multiple sessions to do it.
Yes. Dr. Padma clearly told that first we need to stabilize the lichen planus with oral steroids or isotretinoin or cyclosporin or Dapsone. Dapsone we are not using. So after the stabilization, we can start Q-switched Nd:YAG laser. So this is a case of difficult or very resistant areas to treat because of the non-hair bearing. So any improvement in case of this type of vitiligo with the excimer laser, what is your experience?
Excimer laser can be used in this area, but as you know, it's areola, so it's a little sensitive skin, just like the mucosa. So, you'll have to be very careful because blistering can occur very easily. So, you have to have guarded approach, start with the, MED and then slowly increase over a period of time. The best option in this situation is probably a tattooing or even a grafting, if it is a stable vitiligo.
Anyone? Padma? Dr. Usha? Nimmi?
Yes, ma'am. Yes, ma'am. Even just like how even the lip vitiligo will respond to excimer laser, of course, we can try with excimer laser. And as sir was mentioning, like even the other modalities will also help, like tattooing and all. So that will cover up that area.
So these are the difficult to treat areas. So here I did tattooing before and after. And this is another case of segmental vitiligo in a child, Dr. Nimmi. So when do you, what treatment do you advise?
As you know that this segmental vitiligo is very resistant to the conventional treatments and all that. So of course, some topical medications we can give. But yes, of course, like how even sir has discussed in the talk, we can go for this excimer laser. Here, actually the trick is that if you start in the early stages of any segmental vitiligo, the results are better. And what happens here is again the inactive melanocytes and all through migration, they reach the epidermal area and they try to repigment. That's when we start to see the actual perifollicular pigmentation in the segmental vitiligo when we start giving excimer laser. And usually what happens is we say 1 to 3 sittings per week they can come, or max like alternate days they can come. But of course they need a real like at least 20 to 30 sessions are required. And depending on the MED dosage and all that, every sitting it can be increased by 10% of the previous sitting what we have given. But whenever there is marked erythema, because we have seen so many patients of segmental vitiligo and all developing marked redness in that area once we increase the dosage and all. So that is a time we can maybe give little gap and maybe start with the same dose or maybe go back again. Maybe again 10% reduction of the dose we can do for them. But I have seen pretty good results in segmental vitiligo, especially the areas of the face, neck, we have seen good results. Body, yes, of course, the larger area and all, maybe we have to observe. And the ones with white hair, they're more difficult. So I think some suggestions from the panelists so that what we can do when there is even the white hair associated with segmental vitiligo.
Any panelist? Melanocyte transfer, any panelist would like to?
Dr. Sudha, madam? Madam, Dr. Naeem here. I'm sorry to interrupt in between.
Sir.
So regarding the segmental vitiligo in excimer laser, I also treated few patients, as Dr. Nimi keep pointing out, over the body, especially larger lesions, there is which we can actually achieve the repigmentation in such areas. Improve to some extent. After that, it will completely stop.
Yes.
Line after that. So probably we need to do some kind of we have to combine with certain other surgeries like punch grafting to put some island pigmentation, or even hair grafting nowadays, no, like
yes,
sorts of melanocytes, those kind of things, and then we can probably proceed. If we just depend on procedure alone, segmental vitiligo is very notorious.
Yes,
very difficult to
As with any vitiligo, Dr. Naeem, as you rightly said, there are certain UV sensitive areas like your face, like your upper body. These areas respond well, like any other vitiligo, to excimer light. So it responds faster. Some of the other areas like acral areas, legs, shins, hands, etc., they will be a little more difficult to treat. And yes, I think relying only on excimer laser, once you do about say 15 sessions and you don't see much of a result or you don't see any further improvement, it is better to stop. So ideally the cutoff will be 15 to 20 sessions, and then you evaluate the patient, then you either continue or withdraw based on the result, and then you can change over to, if it is a stable condition, then you can add surgical modalities.
Yes, exactly. Thank you.
Thank you. And so this is a beautiful tattoo with multiple colors. So how do you perform tattoo removal in these cases?
Typically, you will require multiple wavelengths, Dr. Sudha. So you will require your 1064, you will require 532 for the red pigment. Then because there's some yellows, some greens, etc., then you will require either a Q-switch alexandrite laser for that, or if you have multiple wavelengths like the 660 nanometer wavelength also, that also can be used. So, but typically speaking, it is going to be a little difficult. It will require multiple sessions, like the Kirby-Desai scale, which clearly indicates or gives an approximate idea of how many sessions are going to be needed. So you need to use the KD scale, calculate the value, and see exactly how many sessions the patient will require. But typically, the patient will require multiple wavelengths over a long period of time. The other thing that you can do is you can use either the R0 or R20 technique, where you can speed up the improvement.
Will you combine with any other laser in this case?
I don't think you need to combine. If you have a good Q-switch laser or a pico laser, then with multiple wavelengths, you can actually treat it quite nicely. And along with the, your R0, R20, it works well. Of course, if you want, you can combine with fractional laser. So which is again a new paradigm shift, where you're using a fractional laser and a Q-switch laser in the same sitting for the faster clearance of the pigment. That can be done. Can be done. But initially, I would not recommend, because it can cause some blistering and other problems. And especially if you're new to tattoo removal, I would not recommend to combine initially.
So there is one case report where they have done this kind of multiple color lasers with fractional erbium YAG laser followed by R22 passes. Within 3 sessions, there is a complete removal or complete tattoo removal was happened. But I think in our skin, that is very difficult.
You'll have to be a little careful, and especially if you're new to treatment, I would definitely ask you to be a little careful. And remember that it is multicolored tattoo, so you will have to use different wavelengths as well.
Different wavelengths.
And the idea of drilling holes before the Q-switch laser is to remove the steam buildup which occurs, the intracellular steam formation. You kind of extrude that, minimizes the risk of scarring as well as blistering in that situation, and also speeds up the clearance.
So blue and green. So coming to this, Dr. Usha, this is angiofibroma case. 2/3 of angiofibromas are sporadic. They doesn't have any other underlying systemic problems. So what is your experience in treating these kind of lesions with the CO2 laser?
First, I would like to debulk them with slightly with the radiofrequency emission. At the same time, I would like to do fractional CO2 on top of that.
On top of
I would like to debulk that, and then I will do fractional CO2, the same session. But you need at least 2-3 sessions to completely clear these things once in 15 days.
So any experience in treating keloids or seborrheic keratosis with CO2?
Seborrheic keratosis, usually we do with Alman radiofrequency only. We don't use this fractional CO2. Any debulking procedure can be done with fractional, not fractional, the plain CO2 we can do.
The plain CO2. Dr. Nimmi?
Yes, actually in some of the, I think, studies and all, they have combined 2-3 sittings at a time, like doing even the, the fractional CO2, and then again doing the ablative modes, and again application of topical creams in those areas. Like in the same sitting, they have combined. So we can go for like even the ablative CO2 lasers, along with again the fractional CO2 lasers, and with again the resurfacing lasers also can be used.
Yes.
CO2 topical rapamycin, they say to prevent the recurrence.
To stop the emergence of new lesions. CO2 laser is the most preferable laser. So this is after 6 sessions of CO2 laser. He is showing very good improvement. And this is any congenital melanocytic nevi or acquired melanocytic nevi are a great concern, cosmetic concern. So what is your experience, Dr. Padma? Do you use lasers in treating these or removing these congenital acquired melanocytic nevi?
These can be very easily removed with the CO2 laser, or you can use a Alman radiofrequency. That gives a good result actually.
Q-switch laser?
Q-switch, I don't think they'll help.
They will help, especially if it is a junctional nevus. Remember that if it is a compound nevus, it's better to use Elman. But if it is a junctional nevus, what you can do is you can use 1064 nanometer wavelength at 4 millimeter spot size, very high fluence, that is 9 joules, 8 or 9 joules of energy. And you do 2 or 3 stacks on the lesion, and it lightens up the nevus quite a bit. But since treatment of acquired melanocytic neva is controversial, the risk of conversion to malignancy, etc., in the long run is there. You have to take the patient's consent for that specifically, as well as counsel the patient that it can recur. But it does lighten up significantly if you use this technique.
Yes. Still laser usage. Padma, carry on.
And I'm just thanking Dr. Sanjeev for his input.
Welcome.
So normal, this is the target. Here is a cluster of nevus cells. So anyway, we have covered. No, still there is a controversy in treating these lesions with Q-switch laser. So any
laser for that
experience in
matter.
treating these
With any laser for that matter.
Yes. Right. Anyone? Dr. Padma, Dr. Nimmi, Usha.
Many
What
times,
is the role of lasers?
In which conditions?
Role of lasers in?
Target here is a cluster of neural cells and contrast. Okay.
Internet
we
connection.
can't hear you, Dr. Sudha. You're kind
Dr.
of frozen.
Sanjeev?
It's a little pause.
Yeah, I know. It's kind of hanging, I think.
I think my internet connection is unstable. I could not hear you. So this is a congenital hemangioma. What is the best treatment approach? Are you able to hear me?
We can
Yes,
hear you,
ma'am.
but the slide is showing steatocystoma.
Steatocystoma.
Yeah.
We don't see the hemangioma.
This is steatocystoma. Now? Now?
No, it's not moving forward, at least for me.
I think the slide, yes.
Now we can, yeah. Now we can see that.
Yeah. So here CO2 laser can be used and the contents are evacuated. So because of with this, there is a less risk of scar formation and recurrence.
Yes, ma'am, like for steatocystoma multiplex, yes.
Yeah. Even we can use RF also, but CO2. So coming to this congenital hemangioma, what is the best approach in treatment of these? When do you start lasers? Dr. Nimmi.
Lasers? Yeah, ma'am, actually we can, if the topical medications and all are not working, we can go for even this pulse dye lasers. Maybe because it's again a little in the safer zone and all, we can go for it. Since the chromophore is the oxyhemoglobin here, so we can go with this particular laser because as a small size, I think it should respond pretty well. If it's like a bigger sizes and all, I think the other lasers we have to plan, like maybe the NDR Alexandrite lasers can be planned.
Okay, anyone would like to add any points?
I think with the use of topical timolol and propranolol, I think the need for lasers has reduced in these situations.
Yes.
The only reason why we should use laser is if it is causing a functional issue in the child, or if it is blocking vision, or if it is causing some other, functional impairment. That is when a laser can be added. Typically, the treatment of choice is a pulse dye laser. In this
laser. So we need to start at the earliest to get the best results. Yeah, combination also, we can initially pulse dye laser followed by long pulse NDR laser also gives better results in case of
that is what deeper seated,
deep seated ideal. Yes, NDR is for deep seated. So coming to the post traumatic scars, how do you manage post-traumatic scar? What is the role of lasers in post-traumatic scars? So this girl, she had met with an accident, and after 3 weeks of she developed this hypertrophic scar and pigmentation. So what lasers can we do in these, and what is the role of lasers in post-traumatic scar management?
I think lasers have a good role to play. Lasers have a good role to play. You can use a non-ablative fractional lasers like the erbium glass laser, which works quite well in these situations. Of course, if the patient has erythematous scars, a pulse dye laser can also be combined with it. So you can use a combination of pulse dye along with the fractional non-ablative lasers.
No.
If the patient has hypertrophic scars, post-burn, post-traumatic scars, then you can use both a combination of Q-switched. If the patient has like a traumatic tattoo, then in that case, a Q-switched laser works very well. And if the patient has a hypertrophic scar, then a simple fractional CO2 laser can also do a great job.
Yes. So CO2 laser, when we can start these lasers?
You can start as early as 1 week, 2 weeks.
As early as possible. Within 2 to 3 weeks, if you start that laser, the scar management will be very better. So in erythematous scars, as Dr. Sanjeev said, PDL lasers can be used, and pigmentation, Q-switched Nd:YAG laser. So this is also we discussed. I think this is a port wine stain. She took pulsed dye laser treatment outside, and then she came for the further management. So which laser do you use?
So I think for port wine stain, it is the pulsed dye laser.
Pulsed dye laser. Yes, yes.
So
combination of long pulsed Nd:YAG laser.
And I mean, pulsed dye, I think, is the gold standard.
Yeah, pulsed dye is the gold standard. And this is a dermal pigmentation. So this case, how do you approach Q-switch laser? But nowadays, one more question. We are using minocycline most commonly in treating acne. Minocycline causes 3 types of pigmentations. So lasers can be, what is the role of lasers in treating that pigmentation?
Q-switch lasers work well for minocycline-induced pigmentation. You have to do at least 6 to 8 sessions once every month or 2 months, and then it does respond to Q-switch laser therapy.
But there are studies which is showing that Q-switch lasers are not that effective, whereas alexandrite lasers are effective in treating this.
I know, but Q-switch alexandrite, I don't think anybody has in the country.
No, we are not here.
Actually,
but
I
your
think,
experience with Q-switch is good in treating.
Only thing
it works, it lightens up.
Even the spot size here, actually, when we are using the small spot size, it's giving more of depigmentation. So I think the spot size matters a lot in, again, the results, what we get here. So we have so many times depigmentation falling if the spot size of that Q-switched Nd:YAG is small spot size. So there, I think we have to go for a little bigger spot size and then go for the Q-switched Nd:YAG.
Yeah, so this is the last. Thank you. So with the child with a beautiful smile, with the lasers, I think we can get more smiles from our patients. So this is the end of session. I thank all the panelists for their wonderful participation and giving the great information. And I learned so much from you all. Thank you. Thank you very much.
Thank you so much, ma'am.
Thank you so much. Thanks for a good moderation.
All panelists, thank you.
Thanks, everybody.
Thank you all.
Everyone of you well.
I would like to thank you, Dr. K.S. Ram sir and Radha Sham, and also Sanjeev Aurangabadkar sir and Sudhavani madam for moderating this session, and the panelists Padmavati madam, Dr. Usha ma'am, Dr. Nimi ma'am, and Dr. Sanjeev Aurangabadkar sir once again. Thank you, sir. Thank you for giving your valuable time and suggestions to the young generation and the young students. And I would like to thank Dr. Managna, who is backupping my presentations and sharing the slides. With this, we will conclude our session and we will go to the afternoon session directly without any lunch break. Sorry for the interruption, but obviously we are all, I think, within our homes only. There is not a big problem for the lunch break. So we will move on to the next session. Thanking you, sir.
Thank you.
I would like to Dr. Kranti to continue.
Yeah, good afternoon one and all. So moving on to our next session, we'll be discussing something on nutraceuticals. So before that, I'll be calling upon chairpersons Dr. Mukesh Raj sir and Dr. Usha Poturu. I'm just sharing my screen. Yeah, can you see my screen?
Yeah.
Yeah. So Dr. Mukesh Raj sir, yes, has finished his MBBS from Gandhi Medical College in 1981, and he has done his MD from Osmania Medical College. So he has been practicing since then as a consultant dermatologist. He served as a treasurer of APIADVL, member of ACSI, CDSI, and EADV. Received the Economic Times Inspiring Award recently in 2019. So this is about Dr. Mukesh Raj. Coming to our next chairperson, Dr. Usha Poturu. So, founder of Samanvi Skin Clinic, practicing in Hyderabad since last 18 years. She's a founder and CEO of Samanvi Institute of Dermatological Sciences. Trained under various prominent dermatologists in anti-aging techniques and lasers, conducted various hands-on workshops for budding dermatologists, established sits with the aspiration of sharing her knowledge and skills with her juniors. So, welcome, chairpersons.
Thank you so much. Thanks for the introduction.
So I'm just sharing.
Am I visible? Am I audible?
Yes, sir, you're audible.
So I thank the organizers who have given me an opportunity to chair the session. And I'll straight away go for the first speaker. Dr. Nirmala Purohit. Dr. Nirmala Purohit has done his MBBS in 1998 from GMC Nagpur and MD in 2005. Well, she worked as a consultant in Apollo Hospital. This is the Best PG Paper Award 2006. Presented papers in national and state conferences and gave radio talks to increase awareness about skin and hair diseases. She received the Best Doctor Award in 2019 by Suman Arts Theatre. Over to Dr. Nirmala.
So, sir, good afternoon. Shall I share my screen?
You can share the screen.
Yeah. Yeah, thank you, Dr. Mukesh, sir. Am I audible, madam?
Yeah, you're audible, Nirmala.
Yes.
You can go ahead.
Thank you, Dr. Mukesh, sir, for the nice introduction. And at the outset, I would like to thank IDVL team, Telangana IDVL team, for giving me this opportunity to present in this my topic in this August gathering. In this 1 hour, we all 4 speakers will be taking you to the world of nutraceuticals with special focus on the molecules which are important in our dermatology practice. What is nutraceutical? Nutraceutical is the term coined by Dr. Stephen D. Phillips by combining the terms nutraceutical. Nutra derived from nutrition and ceutical is a suffix for therapy. So basically, it is a therapy in the form of food. But however, the concept of food as a therapy is not new. Father of medicine, Hippocrates, has said, "Let food be your medicine and medicine be your food." So according to Dr. D. Phillips, nutraceutical is any substance that is a food or a part of food that provides medicinal or health benefits, including prevention and treatment of diseases. It is any non-toxic food component that has been scientifically proven to have health benefits. Recently, modern nutraceutical industries are exploring the medical benefits of healing power of plant-based materials, mainly because of its easy availability, affordability, safety, and most important, belief in traditional cures. So nutraceutical is nothing but biologically active molecules which are isolated or purified from the food, and they enhance human health and well-being. Broadly, nutraceuticals are classified as nutrients, phytochemicals or herbals, dietary supplements like probiotics, prebiotics, antioxidants. There are different ways to classify nutraceuticals. They are classified as food sources, like basis on their what are the natural sources, either plant origin or animal origin, classified depending upon their pharmacological actions, chemical nature of the constituents. They also include dietary supplements, functional foods like fortified foods. They also contain macronutrients, micronutrients, and most important, phytochemicals involving carotenoids, minerals, polyunsaturated fatty acids. So the knowledge of nutraceuticals will help us to answer frequently asked questions by our patients like, "Doctor, what should I include in my diet? What specific diet should I take?" whenever they come for our skin consultation. Recently, there is a surge in nutraceutical use in skin diseases, mainly because of a rise in the per capita income, increase in the geriatric population, more inclination of patients towards health, wellness, and prevention of signs of aging. It also increases it has also increased due to the increase in awareness of the beneficial effects of these products, and most important, the idea of going natural. So the commonly used nutraceuticals in skin diseases are vitamins like nicotinamide, vitamin C, vitamin D, vitamin A, vitamin-like substances like myo-inositol, N-acetylcysteine, oxidants, antioxidants like glutathione, superoxide dismutase, polypodium leucotoma, various minerals like zinc are also given nowadays in variety of skin diseases, probiotics, grapeseed extracts, polyunsaturated fatty acids, oral collagen, and most important, phytochemicals like pycnogenol. So the products which are highlighted, we'll be discussing in details. How does it work? Skin, being the largest organ of our body, suffers various alterations like photoaging, immune dysfunction, epidermal barrier breakdown, which all leading to inflammation as well as leading to various inflammatory skin diseases like psoriasis, atopic dermatitis. So nutraceuticals represents here as a promising strategy for preventing, delaying, or minimizing the signs of premature aging or aging. It also reduces the inflammation at molecular level, and in this way it helps to elevate certain skin disorders. This is a triad of healthy skin maintenance. So nutraceuticals work on mainly on the reduction of reactive oxygen species, which you all know is involved in photocarcinogenesis, photoaging. It also indirectly is involved in inflammation, immunosuppression, which leads to cascade of various pathophysiological mechanisms of our skin disorders. So what is the evidence? Yes, there are studies, a comprehensive review of human clinical studies on various nutraceuticals which are used for the skin care. It has shown that there is the supplementation of these products contain various products like containing phytochemicals, FUFA, vitamin C, vitamin E, and antioxidant. They definitely have evidence in reducing the signs of aging, protection against UV radiation. In conclusion of this study, it was proved that they are useful, but the quality and the rigorousness of the trials has to be improved in order to build a credible scientific evidence for the use of nutraceuticals in our skin disorders. Now coming to the individual molecule, myo-inositol. It is commonly found in various fruits, vegetables, in all fruits containing seeds. It is one of the 9 different types of inositol, mainly of the vitamin B group family, though it is called a pseudovitamin. How it works? It not only leads to positive changes in the metabolic parameters, but also causes reduction in elevated androgenetic values. At the cellular level, it acts as intracellular second messenger, especially improving the insulin sensitivity and increases the intracellular uptake of glucose. Hence, it improves insulin sensitivity, decreases insulin resistant levels, improves glucose utilization intracellularly, and also reduces free testosterone. So all because of this mechanism of action, it definitely improves or has a role in acne and hirsutism. So the main uses of myo-inositol is its use in acne and hirsutism, mainly in PCOS women. At high doses, it also acts as anxiolytic and antidepressant. So there are studies which proves the efficacy of myo-inositol in the treatment of cutaneous disorders in women with polycystic ovarian syndrome. It has been suggested that when myo-inositol was used for the PCOS, there was reduction in the hirsutism and acne. It reduced free testosterone level up to 48%, 62%, and there was 48% reduction of total testosterone level. Myo-inositol also causes reduction in hirsutism in 16 to 30% of patients at the end of 3 months. which increased to 21 to 53% at the end of 6 months. So this study concluded that at least 6 months of supplementation with myoinositol is necessary to see the effects in acne and hirsutism. The randomized meta-analysis analysis of randomized controlled trials of effects of myoinositol in women with PCOS highlighted the beneficial effect of this molecule in improving the metabolic profile of the woman with PCOS by reducing serum fasting insulin levels, hormone index, and also reducing total testosterone levels. Another study of inositol in women suffering from acne and PCOS showed that it is a useful adjuvant in patients of adult acne, especially female patients who are unable to take OC pills due to various reasons. It has to be given at least for 6 months and dosage 1 to 2 milligram daily, twice daily. Hence, to conclude, it is a useful adjuvant in acne management, especially with insulin resistance and acne in PCOS women. Side effects of myoinositol are very few. It is well-tolerated drug, safe in both obese and lean PCOS patients. It is safe in pregnancy, and very mild side effects are noted only at high doses. Coming to the next molecule, N-acetylcysteine, it is present in high cysteine food. As we all know, it is a mucolytic drug commonly used as antidote for acetaminophen toxicity. It is a thiol compound, and mainly it acts as a donor of cysteine and helps in the replenishment of glutathione, which is a potent antioxidant and will be discussed in detail by the next speaker. Mechanism of N-acetylcysteine has antioxidant action, it has anti-inflammatory action, it is anti-proliferative also. It helps in the maintenance of epidermal barrier. It also modulates certain neurotransmitters. So due to its variety of actions, it has various uses in dermatology, like it is used in drug reactions like TEN at high doses, 300 milligram per day orally. It can also be used in psychodermatosis like trichotillomania, though there is not much evidence in children. It is used in various disorders like photodermatosis, connective tissue disorders, but in all these skin problems, it is mainly used as an adjuvant therapy or a combination therapy. So to conclude, though the drug is cheap, generally safe with very few adverse effects, it is not used much commonly in dermatology, maybe because of we have very few case reports, very small case series and small trials. Hence, high quality of evidence is needed for its wider use. Now, to conclude, nutraceutical market is increasing because of consumer demand. Use of nutraceuticals is there in variety of skin diseases, but the strong scientific evidence for the individual products or the combination products is still scarce. Hence, there is increased demand of naturally based products which have negligible side effects. And yes, there are plenty of opportunities in the future, and scientific evidence must increase to improve the product credibility. Individual product studies are more required. Thank you.
Thank you, Dr. Nirmala. It was a nice presentation. You have dealt in detail with all the aspects of nutraceuticals. I'd ask the other speaker to come. Dr. Harita.
Good afternoon.
Sure, I can take.
1 second.
Can you hear?
Yeah.
Hello.
Somehow my video is not coming, sir, but I start my presentation. Ma'am, you should close your screen share, ma'am. Nirmala, ma'am.
Dear chairpersons, this is the intro of Dr. Harita.
She is Dr. Harita Komarwali, the consultant dermatologist at My Skin, Hair and Cosmetology Clinic in Hyderabad from last 10 years. She published articles in national and international journals and is a member of SIG Psoriasis 2019. She believes in being focused, taking ownership of my work, and working with integrity and passion. Over to Dr. Harita, please.
Thank you, sir. This is a continuation to the madam's topic where I'm going to speak about few nutraceuticals which have been using in our regular practice. Can you see my share?
Yeah, we are able to see the screen, please.
Yeah, thank you. So I'm going to speak about the polypodium, glutathione, pycnogenol, and vitamin E, which are more commonly used in our daily practice. Coming to polypodium, it is a fern extract, usually as known as oral sunscreen, mainly compound contents of chlorogenic acid, comaric acid, ferulic acid, and valenic acid. Of all these, valenic acid and ferulic acid has more potent antioxidant effect. So it has a mechanism of action, it has an antioxidant activity, it has a photoprotection activity, and prevents a carcinogenesis. It is shown in a picture. So whenever there is an UV radiation or solar burn skin reaction, it leads to a cyclooxygenous pathway that causes a cell proliferation, angiogenesis, and apoptosis. All these can be prevented by the polypodium given orally. And there is an, as itself, it can remove the oxidative products that helps in the antioxidant effect. And it also has an effect on the matrix proteinases, which inhibits the proteinase expression, and that helps in collagen breakdown. So all these are effects seen by taking oral polypodium. So the dosage is not well given in a proper way, but whatever the dose is used, it is always tolerated with less side effects. And most of the studies showed the dosage taken input is around 240 to 480 milligrams. And the dose can be increased or titrated according to the person's exposure towards the sun in a day. So the recommended duration of therapy can be continued as adjuvant to the topical sunscreen, along with all the sun protective measures, wearing a scarf, using a wide hat brim, and application of the sunscreen regularly. So there are many studies done by speakers on all the photodermatosis like solar urticaria, so PMLE, vitiligo, and other dermatosis also been done. Here are the few studies done in a 21 volunteers, healthy volunteers. They have given the polypodium along with the sorolin, and the other one is alone a sorolin. So it was seen that where the combination was given, there was a increased dose usage to produce the immediate pigmentation and minimal erythema dose. So that's showing and improving there is a photoprotective effect of this molecule. And there are many same in the pigmentation and deep skin damage done by the UV rays. So here is another study by Nestor where the group has given 240 milligrams of polypodium taken twice daily for 60 days. They have shown a good effect, but the duration of the study was very less and higher dose of the polypodium is required. That is the conclusion was done in this study. And in the melasma, the same effect was given where the group taking the polypodium along with the measures, there was a significant decrease in the MASI score. And there is on the same in the Hispanic group also where there is a decrease in the melanin index and MASI score. But here it is 240 milligrams was used for 3 times a day. There in the previous study, it was given once a day. So all these studies shows there was good improvement. And it is also been taken orally in several other dermatoses like vitiligo, atopic dermatitis, PMLE, solar urticaria, actinic keratosis. There was a study done in actinic keratosis among the 60 people where the group given with the polypodium, recurrence of the actinic keratosis was decreased. So there is a more effective and benefit of this compound. So how much ever we studied all the solar urticaria and other dermatoses, still there are no published studies to say directly it is overtake the topical sunscreen. And we have no studies also show how much amount of absorption is happening that is reaching the skin to give all these photoprotective effect. And there is no proper or precise recommendations for the dose and schedule has been not yet done. So seeing all this, we can just say that polypodium can be an alternative, but it is not only the only drug can be taken in all these photodermatosis. It can be adjuvantly used. So coming to the other three is a pycnogenol. It is a pine bark extract. Mainly it consists of procyanoids and bioflavonoids. It is mainly resource is mainly the pycnogenol by peanut skin, grape seeds extract, and hazelnut bark. All these have more rich in bioflavonoids. And it also have the same antioxidant effect, anti-inflammatory effect, where it acts on the metalloproteinase inhibitors, thus increasing the extracellular matrix. So this is a picture showing an antioxidative effect, anti-inflammation, and it decreases the effect of fatty acids, where the lipid peroxidation is inhibited. So there is a study done giving in acne also. So there will be a reduce in the inflammatory cells in the acne reduction, and thus helps in acne also. That is study seen. This is a different where the extracellular matrix proteinases increases that can be inhibited by the pycnogenol. So it is highly beneficial and prevention of wrinkles, fine lines, acne, rosacea, sunburns, and melanoma. And it also helps in the skin hydration by increasing the cellular matrix proteins. And there are studies done including dermatosis, psoriasis, skin allergies, and skin cancers also. It's in an oral administration study done in published in JARD article 2014, where a group of 29 patients given 100 milligram daily for 2 months, combined with other sun protective factors also for treating melasma. There was a significant reduce of the subjects in the pigmentation. But the main background is a short study and given for a short term.
Hello.
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 Shall I
Who is
continue?
that?
Yeah, you can continue. We are able to listen to you.
Okay, sir. Thank you. So
Harita, you can continue.
Yeah, ma'am. Long-term administration is given protection, so that we can see the further effects, how much it is maintained, any drug side effects that also be seen when we carry out in a larger group. Most of the studies are in a smaller group and small studies. This is published in experimental dermatology, where it is shown on the UV induced damage to the skin. So when they given as a 10 milligram pycnogenol per body kg weight, and there was a photoprotection effect was seen within first 4 weeks. And again, it is also in a short term period of the study. So these are the limitations for all these products, where there is no large study, double blind studies, and a longer term. So coming to glutathione, which many of the people are using in our day practice, it is mainly a tripeptide containing glutamate, cysteine, and glycine. It is in a sulfur hydride group, which is more important as it is an electron donor. That is why that is given as a short term of GSH, which is in a reduced form, which is more active. It is a picture showing where the almost most of the glutathiones given in a combination with other vitamin E, C, niacinamide. Here is a cysteine, where the N-acetylcysteine is important. It gives a release of cysteine that can be taken by the GSH for further reaction in the tyrosinase pathway. And NADP neoacinamide, which mainly plays role in the ATP and ADP formations, which is in a redox reaction, which more commonly seen. So the mechanism is mainly the inactivation of tyrosinase, and there is a diversion of the formation of melanin from eumelanin to pheomelanin. And it has an ROS radical scavenger action also. It's a picture showing the glutathione where it acts by the tyrosinase, diverting into the pheomelanin, which is in a lighter pigment. With that, mainly taken skin lightening agent. Main sources are mainly the avocado, watermelon, citrus fruits. It is also seen in broccoli, cabbage, and asparagus. Even green tea content can be given glutathione. So dosages recommendation is according to the body weight. It's 20 to 40 milligram per kg body weight. And the effects taken is not same in all the skin types. It depending on the skin type, the skin effective and lightening effects are taken in a respectively. Like 1 to 3 months is more commonly seen. When we taken it orally or buccal lozenges, the effect can be seen within 3 weeks in any of the forms. And once the desired color is obtained, we can keep a maintenance dose with 500 milligram per day. There are not much literature or published articles. So there is only 2 studies which can be evaluated and published. It's a randomized trial control done where there is a comparison of this article is seen with the topical, oral and oral. Mainly we are concentrating on oral formulation, where it is a group is given 500 milligram per day and with a placebo, and oral lozenges are also available nowadays, but mostly they are in the lower dosages available like 50 to 100. Here in the study they have used 500 milligram per day and kept in the mouth under the chin. All these have shown effect within a shorter period, and the mean index of the pigmentation score and melanin index was reduced. But all these studies are the shorter period and then a concise size. So that comes the limitations. And there are no studies seen in any of the intravenous formulations. Means these are published articles. And basically when we see its IV glutathione is not approved by the FDA, but when we given its IVA, that instant skin lightening, it is more form easily and very instant. Within shorter period, we can get that lightening effect. There is no single clinical trial study showing its efficacy. There was adverse effect reported by the Philippines, saying that it is exactly not only the glutathione molecule might be causing, there are other additional molecules which can cause the adverse effect, and the technique how we are giving the injections, the process of injection technique. There are other studies showing SJS and 10 thyroid dysfunction, kidney dysfunction, several abdominal pain. These are all by idea. Even when you are taking the glutathione in higher doses or for a longer period, there are other side effects have been seen. There are like lightening of hair color or hypopigmented patches, mainly on the sun exposed areas. There increased susceptibility to melanoma. All these adverse effects are also seen. So the need of R is to require for more randomized double controls and a larger size sample and well-defined primary and secondary outcomes in all the formulations. So coming to vitamins, there are many important in our day-to-day life. They are divided in 2 groups, fat soluble and water soluble. Here I'm telling about the vitamin E, which is known as a tocopherol, rich in spinach, whole grains, olive oil, sunflower. There are 8 types of vitamin E, but alpha tocopherol is more commonly seen in the tissues. Gamma tocopherol, which is mainly seen in the diet. It inhibits the production of the cyclogen prostaglandin E2 and nitric oxide, thus helps in epidermal protection, and it has a photoadductive formation and has an antioxidant property. And the recommended dosage is around 6 to 10 milligrams per day according to the body weight. And when it is taken in higher amounts can cause nausea, diarrhea, cramps and headache. There are many studies done in different conditions in the dermatological scenario. There are few indications where there's yellow nail syndrome, drab zone induced hemolysis and headaches, subcorneal pustular dermatosis, cutaneous amara, where the dosage was given from 400 to 1000 international units per day, depending upon the condition and the improvement of the patients. All have given a level of evidence for. Even in acne vulgaris, we have the importance of vitamin E, where it prevents the lipid peroxidation, thus preventing the inflammation due to this. And in melasma, where it interferes with the lipid peroxidation of melanocyte members, so that it's increasing the intracellular glutathione content and inhibiting the tyrosinase formation towards the pheomelanin. So that they have an importance in the acne vulgaris and melasma. And it is niacinamide B3, which is 2 forms, nicotinic acid and niacinamide. Nicotinic acid is not shown more effect because of the vasodilatory effect and the unpleasant side effect. It has many redox reactions. More than this, this is the main pathway which helps in the glutathione reduction also. It has an antioxidant property, anti-inflammatory, improves the barrier functions and fine wrinkles. This is further taken up by the subsequent speaker. Here I conclude that most of these what nutraceuticals we are telling, they are available in our food ingredients. So the duration, concentration, how much amount that should be taken. By taking all these nutraceuticals along with the regular exercise, stress reduction, meditation and stress relaxation, all will help you improving both health and wealth. So I conclude with this one. Thank you. So take more bright color fruits, vegetables to have a healthy skin and health. Thank you for the opportunity, ma'am.
Thank you, Dr. Harita. It was nice presentation. You have covered a controversial topic of glutathione also, and it was nice. Now I request the other speaker, Dr. Kranti, to come. Is it Dr. M. Himabindu is going to come? Dr. M. Himabindu
Yes,
is
good
on.
afternoon, sir.
Yeah, please. She's done her MBBS from Warangal and DDUL from Mahbubnagar. He has worked in government hospitals, Sangareddy Hospital and in Jubilee Hills for 7 years. She's received the best first poster omalizumab study of the chronic urticaria patients as in CUTICON 2017. I presented an e-poster on secularmab study on psoriasis patients in Dermacon 18, presented free paper on cutaneous lymphomas and treatment in CUTICON 2018, presented a topic on lasers and demonstrated plasma laser at ACADS 13. He presented a case of bullous mastocytosis in an infant at PetermanCon 2019. His experience in lasers, peels, dermatosurgeries like sebaceous cyst extractions, earlobe repair, nail evasion, and vitiligo surgeries. Aesthetic procedures and Botox are also done by him. Now, over to Dr. Himabindu. Please.
Good afternoon, everyone. So now I'm continuing the nutraceutical topic, and I'm going to discuss a few more molecules. Niacinamide, vitamin B3, vitamin C, polyunsaturated fatty acids, and collagen. Now coming to vitamin B3, nicotinamide, aka vitamin B3, niacinamide is a pyridine 3 carboxylic acid amide form of niacin. It is a water-soluble vitamin that is not stored in body. The main source is the diet in the form of nicotinamide, nicotinic acid, and tryptophan. Main source of niacin include meat, liver, green leafy vegetables, wheat, oat, palm kernel oil, legumes, yeast, mushroom, nuts, milk, fish, tea, and coffee. This is the structural molecule, nicotinic acid and niacinamide. So the effects of nicotinamide, it's mainly anti-inflammatory. Mechanism of action, it inhibits nuclear PARP1 enzyme and inhibits production of IL-12, TNF-alpha, interleukin-1, and controls the nuclear factor for kappa B-mediated transcription. It suppresses cytokine-mediated induction of nitric oxide synthase. It inhibits leukocyte chemotaxis and release of lysosomal enzymes. All these are anti-inflammatory effects. It has skin lightening effect, which it blocks the transfer of melanosomes from melanocytes into keratinocytes by inhibiting keratinocyte factors. It has antimicrobial effect. It inhibits nuclear PRP enzyme, preventing the integration of proviral DNA. It inhibits Propionibacterium acne and Mycobacterium tuberculosis by acting on SIL2 enzymes, NAD-dependent deacetylase. It has barrier protective function. It boosts up ceramide synthesis by mRNA expression of serine palmitoyl transferase. And also it stabilizes the mast cells by inhibiting CAMP phosphodiesterase. And it inhibits nitric oxide synthase and suppresses antigen-induced lymphocyte transformation. It has photoprotective effect. Nicotinamide is the precursor of NAD, therefore it prevents depletion of cellular energy. It has many dermatological uses. So coming to the required dietary allowance, niacin daily requirement in men is weighing 60 kg is around 16 milligram per day, and in women 18 milligram, 12 milligram per day. Nicotinamide is a safe and inexpensive compound with negligible side effects. It is well tolerated even in doses of 1 gram to 3 gram per day. There are no reports of teratogenicity with nicotinamide. Minor side effects include nausea, vomiting, headache, fatigue. It does not cause vasodilatory effects as in the case of niacin, and topical formulations produce skin irritation. It does not cause skin irritation. So it has many dermatological effects, like it is anti-acne, It is anti-inflammatory and serostatic, and various studies are done. Nicotinamide is helpful in atopic dermatitis because it increases free fatty acids 2 to 3-fold, and also it prevents the upregulation of aquaporin channels, thereby preventing the transepidermal water loss. And anti-aging effects of nicotinamide are through increased collagen production and decrease of dermal glycosaminoglycans. Nicotinamide main role in autoimmune skin disorders, if we see, it is hypothesized that due to the anti-inflammatory effect of nicotinamide. And it inhibits the cytokines such as interleukin-1 beta, interleukin-6, interleukin-8, and TNF. And most studied use is in bullous pemphigoid. There is one study which suggests that nicotinamide monotherapy of 1.5 gram per day is an effective treatment in localized bullous pemphigoid. Another study randomized the open label clinical trial compared nicotinamide 500 milligram thrice daily plus tetracycline 500 milligram 4 times a day to prednisolone in another group, in which 40 to 80 milligram per day is given in 18 patients with bullous pemphigoid. In the nicotinamide and tetracycline group, 5 out of 12 showed complete response compared to 1 out of 6 in prednisolone group. So it shows that nicotinamide can be used as a steroid-sparing agent, and it can be considered in some of the cases of bullous pemphigoid where steroids cannot be given. And in various case reports are there where successful use of nicotinamide and tetracycline are there in autoimmune blistering diseases like cicatricial pemphigoid, lichen planus pemphigoides, dermatitis herpetiformis, and immunoglobulin A bullous dermatosis. It has also anti-carcinogenic and photoprotective effect by the enzyme PARP, which is inhibited by nicotinamide, which is involved in cell senescence, aging, and cancer. So there is a clinical trial, phase 3 clinical trial done, the nicotinamide 500 mg twice daily led to the statistical significant reduction in number of cases of non-melanoma skin cancer and actinic keratosis. But it disappeared. The effect disappeared after 6 months of stopping nicotinamide. Nicotinamide is also known as the pellagra preventing factor or vitamin pellagra PP due to its role in treating pellagra, and it was first clinically used in 1937. So pellagra, as we know, is a triad of diarrhea, dermatitis, and dementia. It is due to cellular deficiency of niacin resulting from inadequate dietary supply of niacin and tryptophan, seen in chronic alcoholics and patients with GI symptoms and psychiatric disorders. And also other conditions like carcinoid tumor, heart nerve disease, and isoniazid therapy, mercaptopurine 5-fluorouracil. So cutaneous changes include erythema, scaling, and on the sun-exposed areas, which is known as Cazel's necklace. So nicotinamide is given as 100 to 300 milligram daily in 3 to 4 doses until improvement in acute symptoms, and then slowly tapered to 50 milligram BD or TDS. Nicotinamide is an anti-psoriatic agent. Its potential role is because of anti-inflammatory effect. It inhibits the expression of ICAM1 and MHC2 and production of interleukin-12, TNF-alpha, and interleukin-1. So nicotinamide in combination with methotrexate has proved to be superior to methotrexate alone. It can be also combined with the topical calcipotriene for its beneficial effects. Now coming to vitamin C. Vitamin C is a water-soluble vitamin. 70% of vitamin C is lost while cooking process. Most animals and plants can synthesize ascorbic acid from glucose, but man, higher primates, guinea pigs, bats cannot synthesize ascorbic acid. Structural molecule of vitamin C. Then vitamin C is a 5-hydrocarbon ring similar to that of glucose. It has an attached hydrogen ion, and LAA becomes weak sugar acid. L-ascorbic acid is chemically active, and D-ascorbic acid is inactive, and it is the isomeric molecule, and they are interchangeable. Adding metal ion to the vitamin C forms a mineral ascorbate, physiologically active and chemically stable. And L-ascorbic acid is unstable in nature, especially when it is exposed to light. The functions of vitamin C, if we see, mainly it is antioxidant. It reduces oxidative stress reduction. It regenerates vitamin E, and helpful effects are seen in nervous system. And then it has effect on the immune system. It boosts up the immunity, and also collagen synthesis. So collagen synthesis, it helps in the synthesis of collagen, and iron absorption. Vitamin C is known to absorb non-heme iron. and has a protective effect on cardiovascular system. It is the, if we see the antioxidants, these are the primary internal antioxidants, compete the defense system. The vitamin C comes under secondary dietary antioxidants and play a buffering role, and they get rapidly saturated. So in this group comes flavonoid, vitamin A, C, minerals, proteins, carotenoids, vitamin E, etc. Function of vitamin C, it promotes collagen in the skin. It promotes collagen synthesis. It has antioxidant properties. It is photoprotective. Both it protects from ultraviolet A and B, and it is anti-inflammatory. It lightens hyperpigmentation. It reduces post-laser resurfacing erythema. It improves acne and acne scarring. It protects the skin from oxidative stress by sequentially donating electrons to neutralize the free radicals. Oxidized form are relatively non-reactive. It can be converted back to vitamin C by enzyme dehydroascorbic acid reductase in the presence of glutathione. Exposure to UV rays reduces the availability of vitamin C in the skin. Dietary sources of vitamin C, we know that Indian gooseberry is having higher amounts of vitamin C, and then comes orange and lemon, and the other fruits and broccoli and large pepper, guava, kiwi fruits, etc., papaya, strawberries, tomatoes, peas, parsley, mango. These are all the good sources of vitamin. So required dietary elements of vitamin C, if we see, that is, if we take adults, it is 75 to 60, 90 milligrams to 75 milligrams. And in pregnancy, we require additional requirement, and smokers, we require 35 milligram extra, more than the daily compared to the non-smokers. Oral vitamin C supplements are given in a tablet form. Usually they are from 500 milligram to 1000 milligram. They include sodium ascorbate, calcium ascorbate, addition of bioflavonoids, addition of ester-like compounds, and toxic doses of vitamin C lead to cellular apoptosis under laboratory conditions. That is 100 to 200 times the daily recommended dose if they take. So vitamin C is highly safety. Maximum limit usually we give is 2000 milligrams. So during this corona time, most of them, to boost up their immunity, we are taking vitamin C supplements daily. And so now coming to the polyunsaturated fatty acids. So fatty acids are divided into saturated and unsaturated fatty acids. Unsaturated fatty acids have double bond. Monounsaturated fatty acids means they have one double bond. Polyunsaturated means they have more than one double bond. If the double bond is present from the third carbon of the omega end of the fatty acid chain, it becomes omega-3 series, and likewise 6 and 9. So in omega-3 we have ALA, EPA, DHA. ALA is alpha-linolenic acid. Omega-6 series we have in linoleic acid, GLA, DLA, arachidonic acid, omega-9 oleic acid. So here we see that the double bond is from the near the 6th carbon from the omega end. So it forms the omega-6 fatty acid, linoleic. Arachidonic acid similarly. The ALA and DHA are the omega-3 fatty acids. So we are of more interest, showing more interest in omega-3 fatty acids because of its protective effects and good health benefits seen in various conditions. So we have two essential amino acids, that is linoleic and linoleic acid. Linoleic acid, because they cannot be synthesized in the body, they must be obtained from food. Body can synthesize most of the fats from the diet, but linolenic and linoleic acid cannot be synthesized, so they form the essential fatty acids. So when we take ALA and linoleic acid in the diet, so the essential fatty acid metabolism, they get converted into various long chain fatty acids with the help of desachuratase. So linolenic acid becomes eicosapentaenoic, docosapentaenoic, and docosahexaenoic acid, likewise with the help of desachuratase, that is 6,5,4. So essential fatty acid pathway, if we see in omega series, we have linoleic acid, GLA, arachidonic acid. These form pro-inflammatory products. Omega-3 family, they form anti-inflammatory products. Alpha-linoleic acid, eicosapentaenoic acid, docosahexaenoic acid, they form anti-inflammatory products. So omega-3 group have inflammation resolving lipid mediators like resolvins, protectins, marasins, and omega-6 have leukotrienes, prostaglandins, and thromboxane. So the sources of omega-3 fatty acids are canola. ALA is derived from canola, soya beans, walnuts, and flax seeds. EPA, oily fish such as cod liver, herring, marcal, salmon, and sardines. DHA, oily fishes such as cod liver, herring, marcal, salmon, sardine, and also from the algae produced from the algal fermentation. Sources of omega-6, if we see, linoleic acid, soya bean oil, corn oil, safflower oil, sunflower oil, peanut, cotton seed. So we see that essential fatty acids, most of them are derived from the vegetable source. And arachidonic acids, if we see meat, egg, dairy products. More consumption of this will lead to reduced health benefits or more adverse effects on the health. So a diet should ideally consist of 2 or 4 times of omega-6 fatty acids than omega-3.
No, only 5 minutes left, doctor.
It should be 1:1 or okay. In American diet, usually have 30 times more, contributing to rise of inflammatory disorders. So we should cut down omega-6, go for omega-3. Functions, it is major component of plasma membrane and all other membranes of organelles. It maintains the membrane fluidity, produces prostaglandins and leukotrienes, and esterification and excretion of cholesterol, lowering cholesterol. Health benefits. Deficiency symptoms are seen like dry, itchy skin, brittle hair and nail, constipation, etc. Recommended dietary allowance is 1.6 gram per day or 1.6 gram per day in female teenagers and adults. So excess intake of cod liver oil may lead to excess of vitamin A and D, we should keep in mind. And flax seeds, especially derived from plant origin, are safer alternative. And coumarin derivatives, blood thinning agents, blood thinning agents. In such cases, we should be careful because already these thin the blood, so they may lead to further anticoagulant effects. Long-chain polyunsaturated fatty acids derivatives is minimal in skin due to absence of these enzymes, and it becomes more or less if the diet is more of trans fat, free glucose-rich diet. Alcohol intake, corticosteroids, hypoinsulinemia, hypothyroidism, aging, smoking, vitamin B6 and zinc deficiency. So fatty acids in skin disorder, it prevents photoaging, cutaneous carcinogenesis, dermatitis, cutaneous wounds, helps in healing of wounds, hyperpigmentation. Main we have used so in psoriasis, omega-3 fatty acids of major role. Metabolic, it also helps in metabolic syndrome, psoriatic arthritis. Photoprotective effects of polyunsaturated fatty acids. They decrease the nuclear factor for kappa B and activator signaling in the skin, and further down signaling is being reduced. Fish oil, interestingly, increases the expression of antioxidant enzymes like superoxide dismutase and glutathione S transferase. Various studies in which polyunsaturated fatty acids are of beneficial effect is cutaneous photoaging, reduces all the inflammatory mediators, prevents carcinogenesis, wound healing. In psoriasis, it reduces the inflammatory omega-6 polyunsaturated fatty acids, omega-3 fatty acids, reduce interleukin-1, tissue responsiveness to cytokines. So dietary intake of 170 grams of oily fish is advisable, and combined omega-3 and 6 fatty acid supplementation rationale should be considered. Polyunsaturated fatty acid supplementation may lead to improvement of psoriasis management and prevent comorbidities. Even mild improvement or in psoriasis, severity mediated by PUFA can decrease the dosage of currently available therapies and reduce risk of their side effects. In atopic dermatitis, it has numerous beneficial effects. It maintains the barrier function, stratum corneum maturation, differentiation, lamellar body formation, locks and pro-inflammatory eicosanoid inhibition, cytokine suppression, inhibition of mast cell degranulation, and modulation of other immune cells. So recommendations in infant formulas also, polyunsaturated fatty acids are recommended. Then supplementation of high-risk group
Time
like
is up, Dr. K.
Try to finish
collagen
fast.
and just in younger CPC collagen and in the aging skin collagen decreases. Collagen is the most abundant protein in the body, accounting for about 1/3 of the protein composition. It is a major building block of bone, skin, muscles, tendons, and ligaments. It is also found in other parts like vessels, blood vessels, cornea, and teeth. It is a glue that holds the things together, and it is the name is derived from Greek word kolla, which means glue. It is made from hydroxyprotein, amino acids like hydroxyproline, proline, and glycine. There are 30 types of collagen. Type 1 is more present. It is present in 90% of the body collagen constitutes. It is present in skin, bone, tendons, fibrous cartilage, connective tissue, and teeth. Body makes pro-collagen by combining two amino acid glycine and proline. This process utilizes vitamin C. All the
Dr. Himabindu, you have exceeded your time, please. Please try to finish off as early as possible.
Only one slide is there, sir. Not many studies are there with oral intake of collagen 3, but in few, what they are, like 8 studies where collagen hydrolysate 2.5 gram per day to 10 gram per day for 8 to 24 weeks for the treatment of pressure ulcers, cirrhosis, skin aging, and cellulite. 2 studies use collagen tripeptide, and there is noticeable improvement in skin elasticity and hydration. Lastly, one study using collagen dipeptide suggested anti-aging efficacy is proportionate to collagen dipeptide. So, further studies are needed to elucidate medical uses in other skin barrier diseases like atopic dermatitis and to determine optimal dosing regimens. So, oral collagen is known to increase skin elasticity, hydration, and dermal collagen density. Collagen creams are unlikely to work because they are the more larger molecules and they do not penetrate into the skin. So we should not consider them as in our practice. And any benefit is probably due to the moisturizing effect. Thank you.
Thank you, Dr. Himabindu, for the nice presentation. Now I ask Dr. P. Usha to take the further proceedings. Dr. P. Usha, please introduce Dr. Himabindu.
It was nice present. Hello, sir. Nice to see you after so many days, sir. It's a nice presentation by all of the speakers. It's a most uncovered part till now, nutraceuticals. Nowadays, they are going for even IV nutraceuticals became a very popular thing in Hollywood. They are giving IV nutraceuticals, simply glutathione. Of course, apart from glutathione, they are giving all other nutraceuticals also IV by Meyer's cocktail and all. So here I have a question.
Doctor, we have another doctor's presentation, Dr. P. Himabindu, on the nutraceuticals.
I didn't know that. Okay, I'm so sorry. Okay, I would like to invite Dr. P. Himabindu, who is a consultant dermatologist, cosmetologist, medical director at SBR Diagnostics and Polyclinic, Amberpet, Hyderabad. She is a civil assistant surgeon at ESI Hospital. Dr. Himabindu, please take over.
Yes, ma'am. Thank you, ma'am. Good afternoon, one and all. Am I audible, ma'am?
Yeah, you are audible.
Yeah, very much.
Good afternoon, one and all. Today, my topic of discussion is nutraceuticals, and where I'm going to discuss about superoxide dismutase, zinc, grapeseed extract, and probiotics. Coming to superoxide dismutase. One second. Coming to superoxide dismutase, it is the ubiquitous antioxidant enzyme naturally present in aerobic organisms, including mammals and plants. Superoxide dismutase, it exists in different isomeric forms. Which include superoxide dismutase 1, which contains copper and zinc, found in nuclei, cytoplasm, and lysosomes and peroxisomes, whereas superoxide dismutase 2, which contains manganese, that is found in mitochondrial matrix, and superoxide dismutase 3 or extracellular superoxide dismutase that contain copper and zinc secreted in extracellular space. So different isoforms of superoxide dismutase, they have similar functions but present differences in protein structure, metal cofactor requirements, and cellular compartmentalization. It's the first line of antioxidant defense mechanism, also known as primary antioxidant. As an enzyme, it exhibits very high catalytic rate of reaction and it is constantly renewing itself. Yes. Superoxide dismutase. Good sources of superoxide dismutase include medicinal mushrooms, green peas, nutritional yeast, wheat grass, raw liver, heart and wheat germ. Coming to the mechanism of action, it has got antioxidant properties. Superoxide dismutase, it converts extremely reactive superoxide anion into hydrogen peroxide and oxygen. By dismuting superoxide anion, superoxide dismutase prevents liberation of free iron ions and thus formation of harmful reactive oxygen species like hydroxyl ion. At the same time, superoxide dismutase, it also protects vascular signalization from nitric oxide by preventing its reaction with superoxide anion and formation of peroxynitrate, which is a harmful reactive nitrogen species. Coming to its anti-inflammatory properties. Superoxide dismutase, anti-inflammatory properties of superoxide dismutase are due to suppression of hypoxia-inducible factor 1-alpha, which in turn suppresses nuclear factor kappa light chain pathway, signaling pathway. This in turn suppresses the nuclear factor dependent enzymes like pro-inflammatory enzymes, cyclooxygenase and inos, and also other pro-inflammatory and pro-angiogenic mediators. So other mechanisms of action include hyaluronic acid fragments, which directly can activate leukocytes and in turn production of pro-inflammatory cytokines. And hyaluronic acid fragments, they can also directly activate NADPH oxidase and in turn reactive oxygen species. Superoxide dismutase, by directly suppressing hyaluronic acid fragments, it has got its anti-inflammatory properties. Coming to anti-fibrotic properties, transforming growth factor beta is the key element responsible for initiating, development, and also maintaining myofibroblast stimulation. Superoxide dismutase, by inhibiting transforming growth factor beta, it induces phenotypic reversion of myofibroblasts into normal fibroblasts. Coming to the uses, acne vulgaris. Superoxide dismutase could act at different levels of acne vulgaris. In grade 2 acne, being an anti-inflammatory agent, it can be used in grade 2 acne. And being an antifibrotic agent, grade 3 and grade 4 acne, it can prevent scarring. And coming to psoriasis, inflammatory cell activation and dysregulated cytokine production appear to play a critical role in the pathogenesis of psoriasis. So being an anti-inflammatory, again, this is helpful in psoriasis and atopic dermatitis even. Cellulite is a connective tissue disorder affecting more than 90 to 95% of women. This results from chronic inflammation secondary to hormonal activity, provoking continuous collagen destruction. Fibrosis is one of the main mechanisms involved in cellulite. So being an antifibrotic agent, it is useful in cellulite. And coming to vitiligo, it helps to support beneficial effect of narrowband UVB. Superoxide dismutase allows repigmentation process to be maintained even after a long period following phototherapy. Coming to pruritus, it has got antipruritic effect through downregulation of numerous pruritic factors like nerve growth factor and substance P. Though it has no direct effect on this, but it can attenuate its effects by downregulating various pro-inflammatory cytokines. By its effect on vascular endothelial growth factor, it has its effect on wound healing, And photoaging and melasma, it has got primary protective role against UVB-induced injury on human keratinocytes. Coming to the next topic, zinc. Zinc is a nutritionally fundamental element and an essential trace mineral. It is the second most prevalent trace element in human body, first being iron. Meat, shellfish, and wheat germ are rich dietary sources. Phytates and some medications, they inhibit its absorption. Zinc absorption mostly occurs in jejunum and duodenum. Coming to the dosage, total amount of zinc in adults is about 1.4 to 2.3 grams. 85% of it is seen in muscles and bones, 11% in skin and liver, and 1% in other tissues. Recommended dietary allowances include 11 milligrams per day for males, 8 milligrams per day for females. Because it is absorbed in duodenum, from the duodenum it takes around 3 hours to pass into bloodstream, and in the bloodstream 84% of zinc is bound to albumin. Zinc has got its effects like protects against vitamin E depletion, stabilizes membrane structure, restricts free radical production, a component of extracellular superoxide dismutase enzyme, and maintains metallothionein concentration. It plays an important role in cell-mediated immunity. All these mechanisms. It is an antioxidant. The antioxidant mechanism of zinc is because it is an inhibitor of NADPH oxidase. NADPH oxidase is an enzyme that catalyzes production of superoxide anion from oxygen by using NADPH as an electron donor. And also it is a cofactor for superoxide dismutase, cytosolic and extracellular superoxide dismutase. So in that way, it acts as reactive oxygen species scavenger. And it also induces generation of metallothionein. Metallothionein, it is a ubiquitous cysteine-rich protein with low molecular weight. It can bind up to 7 zinc ions, which acts as intracellular zinc buffer. Metallothionein is an excellent scavenger of hydroxyl ions. And one more effect being by virtue of similarities, zinc can exchange with iron ions and copper, which are redox active transition metals, and in that way that it can attenuate oxidative injury. Coming to its anti-inflammatory properties, zinc can increase expression of peroxisome proliferator activator protein, and thus contributing to downregulation of inflammatory cytokines. It can also inhibit nuclear factor kappa light chain pathway, and in turn inhibits nuclear factor induced expression of growth factors, cytokines, enzymes, and thus reduces inflammation. Uses: acrodermatitis enteropathica. Acrodermatitis enteropathica is a rare disorder associated with zinc deficiency. It presents with a classical triad of periacral and periorificial dermatitis, diarrhea, and alopecia. It's of two types, primary and secondary. Primary is due to inherited zinc transporter defect, and acquired is due to reduced intake, increased demand, and malabsorption. Coming to its treatment of primary acrodermatitis enteropathica, it begins with high dose supplementation using oral elemental zinc at 3 mg per kg per day. Whereas out of acquired deficiency, it begins with 0.5 to 1 mg per kg per day of elemental zinc. Other uses include chronic telogen effluvium, wherein oral zinc has been found to be effective, and hidradenitis suppurativa, which is an chronic suppurative dermatosis involving apocrine gland-bearing areas, and folliculitis decalvans, which is a neutrophilic inflammatory disease of scalp characterized by painful, recurrent, purulent follicular exudation resulting in cicatricial alopecia. Being an anti-inflammatory agent, it has been found to be effective in both these conditions. And necrolytic migratory erythema, which is a rare condition which wherein high serum levels of glucagon have been observed and is seen in glucagonoma, wherein decreased zinc levels have been observed. Hence, oral zinc has been found to be effective in this condition. Coming to uremic pruritus, which is common in hemodialysis patients, where there is increased urinary loss of zinc. Hence, oral zinc has been found to be effective. Oral zinc has also been found to be effective in recurrent aphthosis and Behçet's, acne vulgaris, where oral and topical zinc has been found to be effective. And viral infections like molluscum contagiosum, viral warts, and herpes, wherein oral and topical zinc preparations are being useful, and wherein viral warts, intralesional zinc has also been given. Coming to melasma, aging, and skin cancer, based on its antioxidant and anti-inflammatory properties, these are also useful. In seborrheic dermatitis and pityriasis versicolor, topical zinc preparations like zinc pyrithione has been found to be effective. Next topic, grapeseed extract. Grapeseed and skin are good sources of phytochemicals such as gallic acid, catechin, and epicatechin, and are suitable raw materials for the production of antioxidative dietary supplements. Peroxy radical scavenging activities of phenolics present in grape seeds or skin in decreasing order were resveratrol, followed by catechin, followed by epicatechin, and gallocatechin, followed by gallic acid. Dosage include procyanidin found in grapeseed extract is available in tablets or capsules form 40 to 80 mg per day. Extract procyanidin you can take up to 150 to 300 mg per day orally. Mechanism of action. Grapeseed extract is rich in polyphenolic compounds, particularly catechin and epicatechin. Strong antioxidant activity of these compounds makes grapeseed extract to be value added in anti-aging formulations. Proanthocyanidins present in grape seeds inhibits UVB-induced lipid peroxidation, protein oxidation, and DNA damage, and hence has a role in prevention of photocarcinogenesis. Uses, it is used as an antioxidant, anti-carcinogenic, and free radical scavenger. Last topic, probiotics and prebiotics. Probiotic is a preparation of a product containing viable defined microorganisms in sufficient numbers which alter microflora by implantation or colonization in a compartment of the host and by that exert beneficial health effects in the host. Coming to prebiotics, these are the substances that come from types of carbohydrates, mostly fiber, that humans can't digest, but the beneficial bacteria in our gut can. Coming to the mechanism of action, the potential mechanism by which probiotics exert their action may include production of pathogen inhibitory substances, inhibition of pathogen attachment, inhibition of the action of microbial toxins, stimulation of immunoglobulin A, and trophic effects on intestinal mucosa. Dosage. Daily intake of oral probiotic preparations is commonly recommended, but some trials have used twice weekly dosing also. Preparation strength is usually measured as million per billion colony forming units per capsule. These are the foods rich in probiotics and prebiotics. Probiotics include coconut, yogurt, natto, and prebiotics include asparagus, garlic, bananas, and other green leafy vegetables. Uses. Atopic dermatitis, wherein probiotics have been found to decrease allergic mechanism in atopic dermatitis. It can also be used in acne vulgaris, bacterial vaginosis, vulvovaginal candidiasis, psoriasis vulgaris, inflammatory bowel disease, rosacea, wound healing and aging, oral mucositis, and seborrheic dermatitis. This is a paper. It has been concluded in that like skin is the site of multiple oxidative reactions neutralized by exogenous or endogenous enzymatic and non-enzymatic systems in a complex but efficient equilibrium. Any change in this balance may induce or aggravate dermatosis. Each antioxidant molecule has action at certain sites, and therefore combination of these molecules in smaller doses seems to be more efficient. In addition, combinations allow administering concentrations closer to physiological ones, which reduces toxicological risks and even imbalance of antioxidant systems. Currently, there has been an increased interest globally to identify antioxidant compounds from plant sources which are pharmacologically potent and have low or no side effects. Plants produce large amounts of antioxidants to prevent oxidative stress. They represent a potential source of new compounds with antioxidant activity. Increasing knowledge in antioxidant phytoconstituents and including them in daily usage in diet can give sufficient support to human body. Thank you.
Thank you so much, Dr. Ima Bindu. It was a nice presentation. Over to Dr. Pusha.
Thank you all the speakers for your wonderful presentation. It was the most untouched topic. You covered very nicely. Thank you. Are we having any question answer session, sir, or we are going to conclude?
No, we have to conclude. There's no question.
So that ends the session of nutraceuticals. Thank you, Dr. Mukesh Raj sir and Dr. Usha madam for chairing the session. So we'll be moving on to our next session on short oral paper presentations. Thank you, sir.
Thank you, organizers,
Thank
for
you.
getting the
Thank you so much.
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you so much.
Thank you so much.
Bye.
So on our new session on short oral paper presentations. So here are our chairpersons. Dr. Aruna Samat, MBBS and MD DVL, MD from Usmania Medical College. She has done her assistant professor of dermatology at from Usmania Medical College for 20 years. Associate Professor of Dermatology at Mehboob Medical College, presently Senior Consultant at Central Railway Hospital, Lalaguda. And our next chairperson will be Dr. Sudhavani Madam. So, Associate Professor, Department of DVL, Usmania Medical College, Consultant and Founder, Shri Skin and Cosmetology Center, Hyderabad. MD, she has done her graduation from Gandhi Medical College, Hyderabad. She has 19 publications on her name. Active member, active involved in various research work done and ongoing in the Department of Dermatology. Presented original research papers in state, national, and international conferences. Published paper on confluent reticuloid papillomastosis in British Journal of Dermatology and various publications in various national and international journals. So this is a session on. So I would like the chairpersons to address the judges.
Hello.
Hello.
I'm Dr. Aruna.
Hi, madam.
Hi.
Yes, madam. You can introduce judges, Dr. P.L. Chandravati, madam, and Dr. Sai Krishna, sir.
I'm introducing Dr.
Yes,
P.L.
ma'am.
Chandravati, Professor and HOD, Department of Dermatology, Care Institute of Medical Sciences, and Care Hospital, Hyderabad. She was my colleague at Usmania, and she is one of the learned persons. And she trained many DNB students. And okay, thank you.
And Dr. Sai Krishna, sir.
Dr. Kotla Sai Krishna is a consultant dermatologist and cosmetic surgeon, Yashoda Hospital, Secunderabad. She runs Sri Sai Skin Clinics at Chaitanyapuri, Hyderabad, and MBBS from Gandhi Medical College, and he also done his MD dermatology from Gandhi Medical College. He held various prestigious administrative posts and has various publications in peer-reviewed journals, and worked as a principal investigator for several phase 3 and phase 4 trials on psoriasis, acne, cosmetic studies. So I'm handing over to Dr. Aruna, madam.
So this paper on
two prestigious judges are there for this session. Welcome you, ma'am, and welcome Dr. Sai Krishna.
Yes, thank you. Thank you for the introduction. Nice introduction, Aruna and Sudha. So what is the time period?
Each presentation will have 3 minutes, madam.
3 minutes. Then are you going to take care of the 3 minutes business?
Yes, yes, ma'am. I'm going to time it.
Okay.
I am the timekeeper.
Yeah. Look after that.
Yes.
Okay, go ahead.
First speaker will be Dr. Hiba Shakir. Over to you. Dr. Hiba Shakir.
Hello.
Yeah. Over to you.
Yes, I'm sharing my screen. Good afternoon, everyone. Good afternoon, ma'am and sir. Today's topic for my short oral presentation is verrucous psoriasis, which is a distinctive clinico-pathological type of psoriasis. Now my introduction. Psoriasis is an inflammatory disorder which is characterized by peculiar skin and joint manifestations. The most common clinical presentation is erythematous plaque with thick silvery white scale. Psoriasis with verrucous verrucous appearance is very rare, and it might be confused with other lesions including warts, verrucous carcinoma, and verrucous epidermal nevi. So I'm starting the case report. The case report is a 50-year-old male patient with a history of hypertension, diabetes, renal failure, and mitral insufficiency was referred to our department. And he presented with multiple verrucous growths over his bilateral feet, which were gradually progressing since 5 years. And on history, he reported that the initial lesions started as thick silvery white scaly plaques with verrucous papules, which eventually flared up in size and number, associated with intermittent mild pruritus and were malodorous in summers. He had difficulty in movement of feet and was unable to walk. A primary care physician had advised him topical fluticasone 0.05% and salicylic acid 6% preparation, which showed no significant improvement in the lesions, after which the patient did not sought for any management.
To exclude the infectious differentials, HPV immunostaining and past special staining for fungi was done, which came out to be negative. On cutaneous examination, the physical examination revealed erythematous greasy scaly patches with aggregation of multiple small to medium-sized verrucous, flesh-colored to yellowish-white papulonodular plaques over bilateral dorsum of feet involving the digits and lateral borders, and multiple flesh-colored exophytic growths over the ankles anteriorly and Achilles tendon posteriorly. Histopathological examination, it revealed that there was psoriasiform epidermal hyperplasia with acanthosis, hyperkeratosis, parakeratosis, papillomatosis, regular elongated club-shaped retiridges, and reduced granular layer. Well-formed neutrophilic collections were noted in parakeratotic layer. No coilocytic changes were seen. These features were suggestive of psoriasis with verrucous morphology. Talking about the discussion, while the exact etiology of verrucous psoriasis is presently unknown, there are a handful of theories as to the cause. Based on comorbidities present in their patients, other authors have postulated diabetes and chronic autoimmune hepatitis, chronic hepatitis C, treated with interferon as conditions contributing to the pathogenesis of verrucous psoriasis. In this case, patients' long-standing diabetes mellitus and chronic renal failure could have been an addendum to the pathogenesis. Verrucous psoriasis is characterized by regular psoriasiform acanthosis with
Doctor, your 3 minutes up.
Okay, I'll just conclude it. Although it is considered to be a variant from psoriasis, little is known about its adequate treatment because of poor response. So concluding it, it's a recognition of this uncommon psoriasis variant with overlapping clinical and pathological features is with the verruca vulgaris is necessary to avoid delayed diagnosis and to guide proper management of these patients. Thank you.
Thank you, Dr. Hiba. Next speaker is Dr. Sirigi Reddy, Sunaina Reddy. Dr. Sunaina?
Yes, ma'am.
Yeah, please share your screen. Start, ma'am.
So, good afternoon, everyone. I'll be talking now about an unusual presentation of de novo histoid leprosy transpired to erythema nodosum leprosum on treatment with multibacillary multi-drug therapy. Coming to introduction, histoid leprosy, a relatively uncommon presentation of multibacillary leprosy, is characterized by typical clinical histopathological and bacteriological features. Incidence in India has been reported to vary from 2.79 to 3.60% among total leprosy patients. According to available literature, histoid leprosy patients usually do not develop ENL reaction. However, some patients develop during the course of anti-leprosy treatment or dapsone monotherapy. Coming to case report, a 45-year-old male patient presented with complaints of red raised painful evanescent skin lesions over upper limbs associated with high-grade intermittent fever since 5 days. He was diagnosed with histoid leprosy 5 months back and was started on multibacillary multi-drug therapy. Patient initially noticed skin lesions over the extensor aspect of both forearms, later over the arms. He later on developed fever a day after and swelling of both feet. There was no history of pain, abdomen, recurrent infections, or any usage of new drugs. Coming to cutaneous examination, there were multiple erythematous tender papules and nodules measuring approximately 2 into 2 centimeters to 4 into 4 centimeters were seen predominantly over extensor aspect of both upper limbs. Few dome-shaped, non-tender, discrete, smooth nodules were seen over right arm. Dactylitis and bilateral pitting pedal edema were noted. Both ulnar nerves and radial cutaneous nerves were thickened and tender. Hair, nails, and mucous membranes were normal. Investigations like hemogram, blood glucose, liver, and kidney function tests were within the normal limits. Histopathological examination showed foamy macrophages and neutrophilic infiltration suggestive of erythema nodosum leprosum. Coming to discussion, erythema nodosum leprosum is a rare phenomenon observed in histoid leprosy. Also known as type 2 lepra reaction is an immune complex syndrome causing inflammation of the skin, nerves, and other organs, causing arthritis, dactylitis, eye inflammation, osteitis, orchitis, lymphadenitis, and nephritis. Occurs mostly in lepromatous leprosy and sometimes in borderline leprosy patients. They may occur before, during, or after the treatment. So, risk factors for type 2 lepra reaction include lepromatous leprosy with skin infiltration, anti-leprosy drugs with clofazimine, bacterial index more than 4 plus, intercurrent infections like streptococcal, viral, intestinal parasites, filariasis, malaria, physical and mental stress. So erythema nodosa leprosum is treated mainly with corticosteroids, often required for extended periods of time, which may lead to serious adverse effects. Conclusion, erythema nodosa leprosum is generally seen with the above mentioned risk factors and it is rarely associated with histoid leprosy.
Doctor, please wrap it up.
Yeah, hence this case is being reported for its rarity. Thank you.
I request all speakers to stick to time because if you don't, they will reflect negatively on your scoring. Please keep that in mind.
Third paper is by Dr. Tarangini. Please, Tarangini, please present the paper. Dr. Tarangini. Hello.
Is Dr. Tarangini available? Is she logged in? Do we have Dr. Tarangini?
Then go to Suraj. Otherwise, go to Dr. Suraj.
Dr. Suraj, are you up?
Yes, ma'am.
Yeah.
Should I start sharing my screen?
Yeah, please do start sharing your screen.
Okay, ma'am. Is my slide visible?
Yes. No, slide is not just
Not yet.
showing. It started screen sharing.
Is it visible?
Yes.
Yeah. Good evening, everyone. Myself, Dr. Suraj Mali, second year PG from Osmania Medical College. Today, my topic for short oral presentation is on azathioprine as a culprit in causing squamous cell carcinoma. Introduction. Squamous cell carcinoma is the second most common skin cancer worldwide. Risk factors include UV radiation, genetic factors, physical and chemical carcinogens, immunosuppression, drugs, infection, chronic injury, and inflammation. Azathioprine is one of the immunosuppressive drugs attributed to cause lymphoproliferative malignancies and non-melanoma cancer of skin by photosensitization and immunosuppressive carcinogenesis. Here we report a case of squamous cell carcinoma in SLE patient. 54-year-old female patient came with complaint of painful lower lip swelling with bleeding since 3 months and multiple scaly lesions present on trunk and upper limb since 15 days, associated with fever, joint pains, oral ulcers, and photosensitivity. She is a known case of SLE, diagnosed outside with ANA titers 1:180, being treated with 4 mg methylprednisolone BD and azathioprine 50 mg BD since 9 years. On examination, there was swelling of lower lips with erythematous erosive plaque of size 4 by 3 centimeters, covered with hemorrhagic crust and bleeding at some points, and multiple ill to well-defined crusted plaques and erosions of varying sizes on upper chest, upper and lower back, and extensor respect of upper limbs. Investigations revealed anemia, leukocytopenia, and other investigations with normal. Histopathology report, biopsy performed from the lower lip revealed keratin pearl formation with features of well-differentiated squamous cell carcinoma. And biopsy from the lesions on trunk revealed histopathological changes of subacute cutaneous lupus erythematosus. Conclusion, here we report a case of azathioprine-induced squamous cell carcinoma in SLE patient to create an awareness among dermatologists prescribing azathioprine for longer duration, and also to stress upon the importance of patient counseling, photoprotection, usage of sunscreen, and routine follow-up for physical examination to detect early changes of malignancy. Thank you.
The next presenter is Dr. Anusha.
Yes,
Dr. Anusha.
Yes, ma'am. Can I start screen sharing, ma'am?
Yes, doctor.
Yeah, start.
Good afternoon, everyone. The topic of my presentation is spontaneous self-regression in a rare diagnosis, an interesting case report of localized lichen myxedematosus. Case report: a 19-year-old male presented with multiple itchy raised lesions over the neck, back, and buttocks for 3 months. Initially started as small raised skin lesions, skin-colored lesions over the back of the neck, and later progressed to involve the back and the buttock region. His medical and family history was unremarkable. No systemic complaints. On examination, multiple discrete, firm, waxy, flesh-colored, 2 to 6 millimeter sized, closely spaced papules and few papules coalescing to form plaques were found on the occipital region, neck, back, and the buttocks. There was no thickening or skin induration. Systemic examination was within normal limits. Neither hepatosplenomegaly nor lymphadenopathy was observed. Clinically, differential diagnosis of papular mucinosis,
Mute.
lichen amyloidosis, eruptive
Disturbance.
investigation. Thyroid function
Some
tests
disturbance, please.
were normal.
What is the disturbance at the background?
Serum protein
All
electrophoresis.
others, please mute.
Serology for HIV and hepatitis C virus were negative. A 4 millimeter punch biopsy was performed from the upper back. On it, the epidermis showed mild acanthosis with focally flattened reticuli, overlying an area of dermal mucin. Collagen bundles were seen admixed with dermal mucin, but there was no fibroblastic proliferation. On Alshin-2 staining, it confirmed increased deposition of dermal mucin. Thus, the final diagnosis was consistent with this weak papular subtype of lichen myxedematosus. Due to the benign course, a wait and watch approach was adopted, and significant regression of the lesion was observed, and spontaneous dissolution of all the lesions within discussion. Papular mucinosis or lichen myxedematosus is a unique chronic idiopathic disease which is characterized by lichenoid papules, blocks, nodules due to dermal mucin deposition and there are two subsets, that is the generalized papular and sclerodermoid form, and the other is the localized papular form. Diagnostic criteria for localized papular form include papular or nodular or plaque eruption, mucin accumulation with variable fibroblastic proliferation, absence of monoclonal gammopathy, and thyroid disease. The localized form is not associated with sclerosis, paraproteinemia, systemic involvement, or thyroid disease, in contrast to scleromyxedema. Here, skin is the only site of involvement and the lesions show slow progression. Conclusion: although this disease is very rare, it must be considered in the differentials of patients with skin-colored papular lesions. Localized lichen myxedematosus is a benign condition that may rarely show spontaneous regression as seen in our case. Thank you.
Next is Dr. Lakshmi.
Yes,
Dr.
ma'am.
Lakshmi. Yes.
Yes, ma'am. I'm sharing my screen. Good afternoon. My topic for short oral presentation is bullseye pemphigoid, a rare presentation. Introduction. Bullseye pemphigoid, bullous pemphigoid is an autoimmune subepidermal blistering disorder, most commonly found in elderly. The clinical features include pruritic urticarial plaques followed by appearance of tense bullae filled with clear fluid. Erythema multiforme like bullous pemphigoid is a rare variant with clinical findings of both bullous pemphigoid and erythema multiforme, and the diagnosis is based on immunopathology. Our case report is a 70-year-old male with mild itchy and painful erythematous targetoid plaques with dusky centers forming areas of concurrent erythema on face, neck, trunk, and extremities since 15 days, and a single erosion on hard palate which developed 7 days later. Few plaques showed central crusting and few tense clear fluid filled blisters were noted on dorsum of hands and feet. This was a patient with plaques and central crusting and plaques with dusky centers forming targetoid plaques. The involvement was generalized and there was an erosion on the hard palate, and clear fluid filled blisters were noted on dorsum of hands and feet. Neck and ear was also involved. Then on skin biopsy from the plaque, it showed basal cell vacuolation, dermal edema, lymphocytic and eosinophilic infiltrate, but there was no evidence of blisters. It was pointing towards the diagnosis of erythema multiforme, and an excision biopsy from the blister showed subepidermal blister containing fibrin and eosinophils and dermal lymphocytic and eosinophilic infiltrate, pointing towards bullous pemphigoid. Direct immunofluorescence from the perilesional skin showed linear deposits of C3 along the dermo-epidermal junction, pointing towards the diagnosis of bullous pemphigoid. And the patient was started on oral prednisolone 30 mg once daily and is currently under follow-up. He has been improving clinically. Conclusion:
The clinical diagnosis of bullous pemphigoid can be challenging in the setting of erythema multiforme like lesions, and this case has been reported because only 8 such cases have been published in literature. Skin biopsy and direct immunofluorescence are mandatory in such cases. Thank you.
Very good. Next presenter, Dr. Girish Kumar. Dr. Girish?
Ma'am, I'm sharing my screen.
Please.
Is the screen audio visible, ma'am?
No. Dr. Girish, keep your microphone closer.
Yes, ma'am. Ma'am, is it visible, ma'am?
Yes.
1 second. Okay. Good afternoon, everyone. My topic today is not so sweet, gum button disease with molluscid and herpetiform pleomorphic pustular eruptions by me, Dr. Girish Kumar, MC, final year postgraduate. As we all know, gum button disease, also known as sweet syndrome, is a prototypical neutrophilic dermatosis characterized by acute onset of fever, leukocytosis, edematous plaques, and nodules with dermal neutrophilia. It is associated with a wide variety of disorders, including infections, autoimmune diseases, malignancies, drugs, pregnancy, etc. Here we report a case of histiocyted sweet syndrome, which may have been precipitated by filgrastim. Case report was a 46-year-old female patient, a known case of carcinoma cervix, who presented with sudden onset of multiple painful pus-filled lesions for both forearms and back of 2 days duration. It was associated with intermittent fever. There was a history of administration of filgrastim for 3 days, 5 days prior to the onset of rash for the treatment of neutropenia. Cutaneous examination revealed multiple grouped pseudopustules with few coalescing to form annular plaques on erythematous base, which were tender and were distributed over bilateral forearms and back. Some of the lesions showed central umbilication. Multiple dusky erythematous papules and plaques with overlying tiny pustules presented over bilateral hands, legs, and feet, and also over palms and soles. Mucosae were normal. The angstmere revealed lot of neutrophils, and pus culture was negative. Histopathology revealed dermal edema, neutrophilic debris with abscess formation and scattered histiocytes, which is revealed in annexure 1. Lab investigation included leukocytosis, neutrophilia, and traced ESR. Drug-induced SS was considered here according to Walker and Cohen criteria after ruling out herpes zoster and Kaposi's varicella eruption. The patient was started on oral prednisolone, and there was clearance of 60% of lesion within 3 days, and with resolution of fever. The complete resolution was noted in 7 days, and there was no recurrence in the last 1 month follow-up period. Discussion: gum button disease, also known as sweet syndrome, can have a wide variety of clinical presentations. Clinical variants include histiocyted, subcutaneous, neutrophilic dermatitis of dorsal hands, and etc. The etiological types include classical malignancy associated and drug-induced. Filgrastim, which is granulocyte colony stimulating factor, is known to cause neutrophilic dermatosis and cutaneous vasculitis. In our case, drug-induced SS was diagnosed according to Walker and Cohen criteria, and it has a rare variant of molluscid pustular lesions and herpetic infection. Additionally, histiocyte infiltration in the dermis supported the diagnosis of histiocyted herpes. These are the pictures, pre and post images. The figure 1B is showing central umbilication over few lesions, and figure 2 is showing healing of lesions after 6 days of therapy. This is the HP picture showing dermal edema, neutrophilic debris with abscess formation and scattered histiocytes. The diagnostic criteria of drug-induced sweet syndrome. These are my references. Thank you.
Next is Dr. Pranit. Hello, Dr. Pranit, next.
Okay. I'm unable. Hello?
Yeah. Please share it.
Yeah. Is my screen visible?
Yes.
Yeah. Hello. Good evening, everyone. I'm Dr. Pranit. I'm a second year DNB student from Railways. Today, I'm going to present a case of squamous cell carcinoma arising out of a tropic ulcer, which is secondary to Hansen's disease. So, patient is a 75-year-old female resident of Hyderabad, presents to dermatology OPD with a verrucous growth over the plantar aspect of the right foot. Patient is a known case of Hansen's disease, diagnosed 40 years ago, for which patient was apparently treated with Jackson monotherapy. Patient developed an ulcer 4 years back, for which she was periodically treated with oral antibiotics by a local doctor. From last 4 months, patient noticed an ulceroproliferative growth, which according to the patient attendance is increasing in size. Patient denies having a history of diabetes, hypertension, tuberculosis, or thyroid abnormality. Here we can see the picture of the ulcer and proliferative growth. So examination and investigation findings: a 6 into 5 centimeter ulceroproliferative vegetative growth on the plantar aspect of right forefoot. Toes of the right foot were clawed, atrophied, shortened, and deformed. Right posterior tibial nerve and common peroneal nerve were thickened without any tenderness. Sensation to temperature, touch, and pain were markedly impaired in both lower extremities below the knee. No regional lymphadenopathy was appreciated on palpation. Skin biopsy was suggestive of a squamous cell carcinoma associated with full thickness dysplasia, nuclear hyperchromasia, and loss of polarity seen along with the keratin pulse. Slit skin smear was found to be negative, and culture of the specimen was done and it was negative for fungal elements and acid-fast bacilli. And PET-CT was ordered and it showed metabolically active, large, irregular, ulcerative, heterogeneously enhancing soft tissue mass lesions involving plantar aspect of the right foot and metabolically active and enlarged right popliteal and inguinal lymph nodes. Patient underwent Lisfranc amputation and frozen section suggested squamous cell carcinoma with margins free of malignancy. Here we can appreciate the keratin pulse in the histopathological exam, and we can also see the focus of malignancy in the PET scan in the pictures. So the discussion and aim is tropic ulcers in leprosy are common, but neoplastic transformations are relatively rare. It probably occurs in long-standing neglected cases. The best management of tropic ulcer is nursing care of the disease and the early detection of the neoplastic changes and prompt treatment. The reduced cell-mediated immunity in the leprosy increases the risk for malignant changes. Cellular mutations are responsible for neoplastic transformations with infections. Malignant changes in non-healing tropic ulcer for Hansen's disease may not be common, but can be missed if not vigilant. A high degree of clinical suspicion and early specialist referral is recommended. Role of MDT now at this point of time, considering patient has previously taken only dapsone monotherapy and that too many years ago, is probably a matter of debate. Thank you. Thank you very much.
Thank you. Next presenter, Dr. G. Anand Divya. Dr. Divya.
Yes, ma'am. Is my screen visible, ma'am?
Yes. Start.
Good evening to one and all. My topic of presentation is infantile systemic hyalinosis, an inner exploration of an exceptional disease. Sorry, I have an issue with the screen. Stop sharing and share again.
Shall we go to the next presenter?
Ma'am, it's on, ma'am. Can I start now, ma'am? Can I have the timing from now?
Yes, start.
Thank you. My topic of presentation is infantile systemic hyalinosis, an inner exploration.
There is no screen not visible. No screen is seen. Go ahead.
Is it visible, ma'am?
Yes.
Thank you. A 1 year, 4-month-old baby boy born at full term to second-degree consanguineous parents was brought with complaints of skin lesions over scalp, face, trunk, and perianal regions. This one I can't see. Excessive cry, deformity of all 4 limbs, recurrent upper respiratory tract infections, and diarrhea since birth. There is history of physical developmental delay and negative family history. On examination, child was small for his age and irritable. He had facial dysmorphism with low set ears and dolichocephaly. Skin appeared tense and shiny, mainly over bony prominences, with erythematous papules coalescing to form plaques over chin, occipital scalp, nape of the neck, earlobes, and back of the trunk. Skin colored to pinkish nodules measuring 1 into 1 centimeter to largest 6 into 5 centimeters were present over both elbows, knuckles, tips of the nose, mid-back and perianal region. Gingival hypertrophy and hyperpigmentation over knuckles were present. Tender flexion deformities were present over all the small and large joints. A clinical impression of infantile systemic hyalinosis was suspected. Routine blood investigations, serum amino acid levels, neurosonography, ultrasound abdomen pelvis, tests for lysosomal storage disease and immunodeficiencies were all negative. Radiological evidence of generalized osteopenia with right distal humerus fracture on the X-ray was noted. On skin biopsy from the nape of the neck, it showed coarse collagen in papillary dermis with increased number of plump fibroblasts and reduced number of appendages surrounded by thickened and hyalinized collagen. Molecular gene analysis was done. Sequencing of human anthrax toxin-like receptor gene revealed the child was homozygous for frameshift mutations and missense mutations in exon 13, confirming the diagnosis of ISH. ISH is a rare, progressive, and fatal autosomal recessive disorder with mutations in von Willebrand type 2A-like domain of capillary morphogenesis gene, also known as human anthrax toxin receptor gene on chromosome 4q. Mutations in this gene lead to excessive proliferation of spindle cells, abnormal collagen synthesis with extensive deposition of amorphous eosinophilic hyaline material in connective tissue of skin, cardiac, skeletal muscle, GIT, and endocrine glands. They present at birth or first few months of life with reduced spontaneous movements due to progressive joint contractures and pain. The main dermatological manifestations are progressive skin thickening, papilla skin lesions, gingival hypertrophy, perianal nodules, and hyperpigmented patches over bony prominences. It is one of the DD for infantile stiff skin syndromes, Winchester syndrome, juvenile hyaline fibromatosis, and arthrogryposis
Doctor, time's up.
congenita. Yes, ma'am, I'm concluding. In our case, diagnosis was made with the help of typical skin manifestations and confirmed by HPE and molecular gene analysis. Currently, there is no treatment for ISH, and it is important to counsel the parents regarding the need for prenatal diagnosis by chorionic villus sampling. Thank you.
Next is Dr. Pavitra.
Yes,
Are you
ma'am.
ready?
Yes, ma'am.
Yes. Start.
Is my screen visible, ma'am?
Yes, yes.
My case is traumatic panniculitis of right thigh in a 3-year-old boy, ma'am. Introduction. Traumatic panniculitis refers to damage of subcutaneous tissue induced by physical, chemical, and agents. The clinical picture of traumatic panniculitis is non-specific. This is a case of 3-year-old boy who presented with swelling of right anterior aspect of right thigh of 4 months duration, which developed following an injury due to hit by cord. The parents noticed hemorrhagic swelling initially, which gradually increased in size within a span of 4 months to attain the present size. Incision and drainage was performed on it by local practitioner. Following the procedure, the lesion increased in size. Examination revealed a warm, tender, boggy, mobile swelling of size 17 into 21 centimeters on anteromedial aspect of thigh. The skin over the swelling is pigmented and not pinchable. Initially, clinical diagnosis of abscess, panniculitis, subcutaneous mycosis, malignancy like rhabdomyosarcoma were thought of. The first picture shows the initial picture at presentation. Then routine investigations were all normal. Then a CT scan of the right thigh was performed, which revealed an ill-defined area of fat attenuation separated by septae in the subcutaneous tissue. The underlying muscles and bone were normal. These features were consistent with traumatic panniculitis. A 6 mm biopsy was performed, which shows excessive fat necrosis of fat lobules, a thick eosinophilic peripheral fibrotic pseudocapsule with hyaline appearance encircling the nodule and separating it from the surrounding tissues. From the CT and biopsy report, along with the clinical examination, this case was confirmed as traumatic paniculatus that requires only symptomatic treatment. Then the boy responded dramatically with the syrup ibuprofen plus paracetamol and syrup amoxicillin plus clavulanic acid. Traumatic paniculatus refers to changes in the subcutaneous fat related to the physical or chemical agents. The causes of physical injuries are trauma, cold, and electricity. In general, the intensity of traumatic injury is not necessarily related to the development or the intensity of the cutaneous lesions. History of trauma helps in the diagnosis, although often the antecedent injury is minor or even unnoticed. Traumatic paniculatus is usually a self-limiting disorder and requires only symptomatic treatment. This report shows an interesting case of traumatic paniculatus, which is a self-limiting condition, which the boy responded very well to the conventional treatment. Some patients may require surgical treatment of local complications like erythema, indurated fibrous masses, or losses or nodules. Thank you.
Next speaker, Dr. Nikat Shaheen Syed.
Am I audible, ma'am?
Yes.
Good afternoon, everyone. I'm Dr. Nikat. My topic of presentation is diagnostic dilemma of connective tissue diseases. Herein, I'm presenting two cases of autoimmune connective tissue diseases which posed a dilemma as the serology was negative. Case 1, a 28-year-old female presented to our OPD with chief complaints of tightening of skin of both the hands and face since 2 years and painful bluish discoloration of fingers on exposure to cold since 2 years. On examination, shiny taut skin was seen on the face and on both the hands, extending proximal to the metacarpophalangeal joints. Motile pigmentation was seen on the posterior aspect of the neck, upper back. Investigations showed raised ESR, but the serology was negative. Based on the ACR criteria for systemic sclerosis, that is presence of skin thickening proximal to the MCP joints and Raynaud's phenomenon with a score of 9 or more, this case was diagnosed as seronegative limited systemic sclerosis. Case 2, a 9-year-old female presented to the OPD with chief complaints of itchy raised lesions over joints of fingers, difficulty in standing from sitting position, climbing stairs, buttoning her shirt since 6 months, swelling around the lower eyelid since 3 months. On examination, calcineosis cutis was seen proximal to the edema was seen and Gotran's papules on the interphalangeal joints. Investigations shows markedly raised muscle enzymes, that is LDH and creatinine kinase were raised, but the serology was negative. Electromyography was suggestive of muscle disease and MRI of right thigh showed edematous changes along myofascial planes and increased signal intensity of all muscle groups diffusely on T1 images, suggesting inflammation. Based on the Bohan and Peter criteria, this case was diagnosed as classic juvenile dermatomyositis. Discussion: autoantibodies are of significant value in the diagnosis, management, and prognosis of autoimmune connective tissue diseases. Understanding its limitation is critical to clinical decision making. They're positive in about 90% cases of systemic sclerosis, 70% Sjogren's syndrome, and 40 to 65% in dermatomyositis. Relationship between presence of autoantibodies and diagnosis is enigmatic sometimes. Antibody tests are intended for diagnostic confirmation, but the absence do not exclude a specific connective tissue disorder. Hence, in the diagnosis of connective tissue diseases, both clinical and serological arms have to be considered. Thank you.
Next, Dr. Namrata.
Am I audible?
Dr.
Shall I
Namrata.
share my screen, ma'am?
Yeah, Namrata.
Yeah, get your yeah.
Correct. Ma'am, shall I present?
Yeah.
Good afternoon, all. I'm Dr. Namrata BN, third year PG. Today, my topic of presentation is the enigma of generalized vesicular eruptions in COVID. Introduction: COVID-19 infection has rapidly spread throughout the world, becoming a pandemic with various cutaneous manifestations like urticaria, morbilliform rash, papulovesicular exanthem, chilblain lesions, livedo-reticularius, and purpuric lesions being reported. Vesicular eruptions are increasingly described in association with COVID, and so is the increased prevalence of herpes zoster. Here we report a patient of COVID who presented with features mimicking disseminated herpes zoster. Case report: a 38-year-old female patient presented with multiple fluid-filled lesions all over the body of 20 days duration, which began initially on the chest and then spread to the entire trunk, face, and extremities, associated with high-grade fever. There was no history of cough or sore throat. History of adequately treated pulmonary TB was present 2 months ago. Cutaneous examination revealed group vesicles on erythematous background over the right trunk involving T3, T4 dermatome, and multiple discrete vesicles with few showing central crusting and few hemorrhagic present diffusely all over the body. A clinical diagnosis of disseminated herpes zoster was made. Zangsmear showed multinucleated giant cells. Injection acyclovir was started, to which there was partial response, followed by reappearance of lesions on stopping treatment. Varicella serology was negative. HIV and HSV serology were non-reactive. In view of the high-grade fever, lymphopenia, and the partial response to treatment, the patient was advised HRCT and COVID RT-PCR. HRCT showed bilateral ground glass opacity of Corat score 5 and positive RT-PCR. Patient eventually developed respiratory complications and succumbed to the disease. These are the clinical pictures where we can see group vesicles on erythematous background on T3, T4 dermatome and discrete vesicles on the trunk, on the upper limbs, on the lower limbs, the multinucleated giant cells, and the crusted lesions following injection acyclovir. Discussion: in a study by Galvin et al., vesicular eruptions constituted 9% of the cutaneous manifestations in COVID, characterized by small monomorphic vesicles, unlike the pleomorphic vesicles in chickenpox, affecting the trunk and limbs, and may have hemorrhagic content with a tendency to become larger or diffuse. They also suggested to categorize these patients further, as there's increased association with herpes virus. As we know, cell-mediated immunity is influenced by T cells. Herpes zoster is reactivated when the host cell-mediated immunity decreases, as seen in patients with immunodeficiency. However, COVID-19 also decreases cell-mediated immunity by decreasing the lymphocyte count, that is the CD3, CD4, and the CD8 T cells. Therefore, COVID-19 could increase the risk of herpes zoster by decreasing the cell-mediated immunity and the impaired antiviral response. Conclusion: in our case, the diagnosis of disseminated herpes zoster could not be explained with certainty as the patient was immunocompetent and varicella serology was negative. Hence, the possibility of vesicular eruption in COVID was considered. During the current pandemic, it is prudent to rule out COVID infection in patients with disseminated vesicular eruptions or clinical features suggestive of herpes zoster.
Doctor, you're exceeding time.
My references, thank you.
Next presenter, Dr. Shruti Ganesh.
Yes, ma'am. Is my screen visible, ma'am?
Yes.
Good evening, one and all. The topic of my presentation today is seasonal trends in sexually transmitted infections, analyzing the past to prepare for the future. Introduction. Seasonality is a systematic periodic occurrence of events over the course of a year. Observers worldwide have documented marked seasonal fluctuations in the incidence of many infectious diseases. Sexually transmitted infections, including HIV, present major health.
Keep your microphone nearer, ma.
Yes, ma'am. Sexually transmitted infections, including HIV, present major health and socioeconomic problems in the developing world, leading to considerable morbidity and stigma. To develop efficient strategies for disease prevention and control, there is a need to evaluate the determinants of their seasonal trends. Aims and objectives of the study were to analyze the epidemiology and seasonal trends of syndromic STIs over a period of 6 years and to describe the probable factors underlying these variations. Materials and methods: retrospective analysis of data collected from clinical records of patients attending the STI clinic of a tertiary care hospital over a period of 6 years from January 2014 to December 2019 was performed. Detailed history and clinical features were recorded. STIs were categorized in 7 syndromes as depicted by NACO in the syndromic management. The syndromes were vaginal and cervical discharge, genital ulcer disease, herpetic and non-herpetic, genital warts, urethral discharge, scrotal swelling, and inguinal bubo. The seasons of the year were categorized as summer, monsoon, and winter, and the data was analyzed by the ANOVA test. The results of the study were as follows. 11,399 patients were studied, out of which 55% were females, 67% patients were aged between 25 to 44 years. There was an overall increase in the number of cases over 6 years. The most common syndrome was vaginal and cervical discharge, accounting for 57%. 20% of the cases were seropositive for HIV. Vaginal discharge, non-herpetic genital ulcer, urethral discharge, and inguinal bubo showed rising trends relatively in winter, but it was not significant statistically. The p-value was more than 0.05 and the f-value was less than the critical f-value. These are the graphs showing the number of patients and the distribution of various syndromes, the age group distribution of age groups, HIV seropositivity, and the seasonal trends in genital ulcer disease, non-herpetic, and urethral discharge. Discussion. Increase in cases of STIs indicates change in the sexual behaviors of people over time, including early age at first sexual intercourse, promiscuity, unprotected sex, and substance abuse. Seasonal trends with relative peaks in winter in our study point to increase in sexual activity and unsafe sex practices involving casual partners more during the winter season. This may probably be due to cold weather conditions which increase the libido and the sexual desire. Conclusion. Seasonally related sociocultural events appear to have an influence on the incidence of various sexually transmitted infections. They can help to schedule and optimize various prevention and control strategies, including information, education, and communication programs. Thank you.
Next, Dr. Fareen, are you ready? Dr. Fareen?
Yes, ma'am. Yes, ma'am. I'm ready.
Yeah, please.
Ma'am, can I share my screen?
Yeah, please.
Hello? Hello?
Yeah, yeah,
Yes.
we can see.
Yes, good evening, everyone. I'm Dr. Fareen Kehkashan Ahmed, second year PG. Today I'm going to present a rare case of localized cutaneous mastocytoma subsiding on topical steroids and topical localized cutaneous mastocytoma is a very rare manifestation of cutaneous mastocytosis, presenting as a solitary red, pink, or yellowish nodule, and on rubbing they blister and can precipitate attacks of flushing. So, a 6-month-old male child was brought to the dermatology OPD with complaints of a red raised lesion on the chest since 2 months of age, which becomes deep red on crying and developed vesicles and blisters on the surface often. On examination, a single erythematous plaque of size 1 inch by 1.5 inch was present on the sternal region. Few vesicles were present on the periphery. It was non-tendon palpation and became red on rubbing. Diarrhea sign was positive. There was no hepatosplenomegaly. A provisional diagnosis of localized cutaneous mastocytoma was made based on clinical examination, and skin biopsy confirmed the diagnosis. Routine investigations like complete blood count, differential blood count, and liver function tests were normal. The infant was treated with topical fluticasone propionate 0.05% in the morning, atrazine 2.5 mg once daily, and the parents were advised to prevent physical triggers, especially rubbing and heat to the infant, avoid NSAIDs, insect bites, and allergens like latex to the infant. Now coming to the discussion, mastocytosis is a clonal disease of yeast growth and accumulation of mast cells in skin, bone marrow, liver, spleen, and lymph nodes. Mastocytoma is a type of cutaneous mastocytosis. Mastocytoma is caused due to mutations in c-KIT and D816 substitutions are common. It usually occurs in infants with age less than 6 months as red, pink, or yellowish nodules or plaques in infancy or early childhood, measuring up to 3 to 4 centimeters in diameter. The surface of the skin is smooth or has a purely orange appearance. They tend to blister when rubbed, especially in the napkin area of infants, and occasional attacks of flushing are induced by rubbing the solitary mastocytoma. Histopathology reveals diffuse completion of muscle perivascular aggregates, few eosinophils can be seen. Observation.
Dr. Fareen, you have exceeded time. Dr. Fareen?
No, Dr. Naushin Sheikh.
Ma'am, Naushin, ma'am.
No.
Can I start, ma'am?
Start.
Good evening, all. My topic of presentation is mistaken nominally, misdiagnosed clinically, familial benign pemphigus. It's not pemphigus. A 45-year-old male presented to our OPD with 20-year history of flexural blistering eruptions, started at the age of 25 years with vesicles and erosions in axilla, neck, groin, and perianal region. Lesions were pruritic with burning sensation and were foul smelling. Recurrent on and off episodes since 20 years with exacerbations in summer was present. Refractory to topical, systemic antifungals and antibiotic. History of similar complaints in his father was present. On examination, hyperpigmented macerated plaques with multiple fissures, peripheral vesicles and crusts were seen on neck folds, axillary, inguinal and perianal regions. No involvement of mucous membranes and nails. A 4 mm punch biopsy demonstrated incomplete intraepidermal acantholysis, showing a dilapidated brick wall appearance characteristic of Hailey-Hailey disease. Pemphigus is a general term used for a group of autoimmune intraepidermal blistering disorders. Whereas familial benign pemphigus is not an autoimmune disorder, it's a rare autosomal dominant intraepidermal blistering disorder with ATP2C1 gene mutations resulting in acantholysis in stratum spinosum due to abnormal intracellular calcium signaling. Usually, this is presents with recurrent fragile vesicles and erosions in intertriginous areas. Disease is usually seen in second to fourth decade, and family history is present in two-thirds of cases. Pruritic, painful, marrow-dress lesions are present. Nikolsky sign may be positive. Hailey-Hailey disease commonizes into inflammatory dermatosis and may exacerbate after triggers such as contact dermatitis and scabies infestation. Superinfection with Candida albicans, herpes virus, and Staphylococcus aureus are frequent complications. It can be easily misdiagnosed as it resembles dermatosis involving the intertriginous areas like tinea cruris, intertrigo, psoriasis, acanthosis nigricans, Terrier's disease, pemphigus vestans, and eczema. In order to prevent misdiagnosis, we have to look for family history, exacerbating factors like friction, heat, or sweating. Post-inflammatory hyperpigmentation is common. Longitudinal white bands in nails is uncommon, but when present is hallmark of the disease. Eczema or infections are the most common misdiagnoses. Hypertrophic flexural Hailey-Hailey disease resembles Darier's disease. At these times, histopathology comes to aid. In Darier's disease, we see more dyskeratosis than acantholysis, and in Hailey-Hailey disease, it is vice versa. Eroded or vesiculobullous Hailey-Hailey disease may simulate toxic epidermal necrolysis or pemphigus vulgaris. Genital Hailey-Hailey disease may simulate viral warts or bulbal intraepithelial neoplasia. Treatment includes first-line treatment, general measures like minimizing friction and topical steroids and topical antimicrobials. Second-line treatment includes ultra-potent topical steroids, topical or oral antimicrobials. Third-line treatment includes topical tacrolimus, calcipotriol, 5-fluorouracil. Oral cyclosporine, retinoids, and methotrexate can be tried but are of unproven efficacy. Thank you.
Today's last paper is Dr. Sweta. Dr. Sweta.
Yes, ma'am.
Madam, Dr. Farini is asking for one more time we should give or no? Because of some problem with her computer, she is asking once again she want to present. Dr. Farin.
Ma'am, is mine visible?
No,
not. I think we should give because maybe some trouble. Yeah, just 3 minutes. I think
after this, please prepare, Farin.
Yes, ma'am. Sure, ma'am. Thank you, ma'am. I'm ready, ma'am.
Go ahead. Share your screen, please.
Ma'am, is my screen visible?
Should I do from the starting or just...
Again, internet issues, Dr. Farleen. We are unable to hear you.
Oh, actually, no. You people announced
Ma'am,
Shweta.
can you hear me now?
Yes,
Shweta.
yes, madam.
If she has internet trouble and all that, why can't Shweta present in the meantime?
Ma'am, can you hear me?
Yeah, we can hear you, but
yes, ma'am.
share your screen and start.
Ma'am, it's saying that I'm sharing my screen.
Yes, it is visible.
Yes,
but,
go ahead. Go on slideshow.
Ma'am, should I go from the starting or the discussion part, ma'am?
Now who is presenting?
Yeah.
No.
Yes, ma'am. I'm Dr. Fareen.
Dr. Fareen, if your connection is good, please start from the beginning and take your 3 minutes and be done with it, please.
Okay, sure, ma'am. Yes, ma'am. Good afternoon, everyone. Today I'm going to present a rare case of localized cutaneous mastocytoma subsiding on topical steroids and topical tacrolimus. Localized cutaneous mastocytoma is a very rare manifestation of cutaneous mastocytosis, presenting as a solitary red, pink, or yellowish nodules or plaques in infancy or early childhood, measuring up to 3 to 4 centimeter in diameter. So, a 6-month-old male child was brought to the dermatology OPD with complaints of a red raised lesion on the chest since 2 months of age, which became deep red on crying and developed vesicles and blisters on the surface often. On examination, a single erythematous plaque of size 1 inch by 1.5 inch was present in the sternal region. Few vesicles were present on its periphery. It was non-tender on palpation and became deep red on rubbing. And a diarrhea sign was positive. There was no hepatosplenomegaly. A provisional diagnosis of localized cutaneous mastocytoma was made based on clinical examination, which was confirmed on biopsy. So the biopsy revealed presence of aggregates of mast cells in deep dermis with rounded nuclei around blood vessels. Routine investigations like CBC, differential count, liver tests, liver function tests were normal. The infant was treated with topical fluticasone propionate 0.05% in the morning and tacrolimus 0.03% in the evening, oral cetirizine 2.5 mg once daily, and the parents were advised to prevent physical triggers like rubbing and heat to the infant, to avoid NSAIDs, insect bites, and allergens like latex to the infant. Mastocytosis is a clonal disease of hematopoietic stem cells characterized by local or diffused increased growth and accumulation of mast cells in skin, bone marrow, liver, spleen, and lymph nodes. Mastocytoma is a type of cutaneous mastocytosis. Pediatric mastocytoma is caused from mutations in CK-D816 substitutions are common. It usually occurs in infants with age less than and they tend to blister. Flushing and induced histopathology reveals diffuse infiltration of mast cells in deep dermis, perivascular aggregates. Few eosinophils can be seen. Observation is enough to clinch diagnosis in young children with solitary mastocytoma with a positive diarrhea sign in whom systemic disease is rare, and the biopsy can confirm the diagnosis. Complete and differential blood count, liver function test, and tryptase levels can also be carried out. Hepatosplenomegaly should be looked for. Differentials include juvenile xanthogranuloma. Treatment options include counseling parents about avoiding triggers like heat, rubbing, exertion, insect bite, NSAIDs. Potent corticosteroids and occlusion can be given for 8 to 12 weeks. Topical calcineurin inhibitors, topical 4% sodium chromoglycerate cream, H1 receptor antagonists
Sorry,
like
we are not able to hear you.
Ma'am, treatment options include counseling parents about avoiding triggers like heat, rubbing, exertion, NSAIDs. Topical corticosteroids and occlusion can be given for 8 to 12 weeks. Topical calcineurin inhibitors, topical 4% sodium chromoglycerate cream, H1 receptor antagonists like diphenhydramine, hydroxyzine, loratadine, cetirizine, desloratadine can be given, and these prevent pruritus and flushing. Prognosis is good with most cases resolving by puberty. Patients have to be followed up for up to 6 months and 1 year, and investigations are to be repeated. Localized cutaneous mastocytoma is a rare disorder and cause of prompt diagnosis, investigations, treatment, and follow-up to prevent discomfort to the infant and to monitor development of systemic mastocytosis and to prevent anaphylaxis. Presenting a case of localized cutaneous mastocytosis. Thank you so much, ma'am. Thank you for a second chance.
Dr. Sweta, next. Hello.
Yes, ma'am.
Dr. Sweta.
Yes, ma'am. Ma'am, I'm unable to share my screen because Fareen's screen is still active, ma'am.
Fareen, please stop sharing. Hello, Dr. Fareen. Now you
think
start.
now-
Sweta, you start.
I stopped screen sharing.
Yeah. Yes, ma'am.
Dr. Sweta,
Yes, ma'am.
now also, are you not unable to share your screen?
Ma'am, is it coming now?
Yes.
Yeah, ma'am. My case is about remission of vitiligo with treatment of schizophrenia.
Your
As we all
screen is not visible.
Screen, yeah, share the screen.
Dr. Shweta, first open the presentation and then press share screen, okay?
Okay. Ma'am, is it coming?
Yes.
Yeah. So my case is about remission of vitiligo with treatment of schizophrenia. Introduction, as we all know, the skin and nervous system are embryologically derived from the neural plate of ectoderm. This shows the interconnection between the skin and the nervous system. Psychodermatology addresses the interaction between the mind and skin. Today here we present a case report about a 17-year-old girl who was suffering from vitiligo since 3 years, and she has stopped her treatment for vitiligo as she developed other symptoms like food refusal, refusing to go to college, not talking to her family members or outsiders. She became over suspicious. She disturbed sleep, for which she was referred to a psychiatrist. Then she was diagnosed as a schizophrenia with a catatonic type, and she was put on some atypical antipsychotics like olanzapine 10 mg and trihexyphenidyl 2 mg and lorazepam 2 mg, and the dosage of the drugs has been gradually increased. Within 1 month of the treatment, there were improvement in the psychotic symptoms, and in 1 year, the social and occupational functioning of the patient along with the skin lesions improved markedly. So the pathophysiology of this is, as we all know, vitiligo is an autoimmune and psychocutaneous condition characterized by generalized and localized depigmentation of skin and mucous membrane, and stress plays an important role in pathophysiology of vitiligo. Then there is a model that explains, like the neuroimmunocutaneous endocrine model explains the mind and body relationship. Stress can exacerbate vitiligo by changing immune function, increasing the production of opioid peptides, increasing the catecholamine release, and affecting other hormonal pathways. The HPA axis is central to the stress. It responds to stress by upregulation of the corticotropin releasing hormones, cortisol, prolactin, activation of sympathetic nervous system, and release of neuropeptides and neuromediators. Skin mast cells are also an important target of these key stress hormones mediators, and their activation leads to immune dysregulation and various skin disorders. Here is the pathway. And these are some of the before and after photos. Before treatment, 6 months post-treatment, and 1 year post-treatment. So in conclusion, I would like to say that vitiligo is not just a cosmetic disfigurement. It is associated with a variety of psychopathological problems that can affect not only the patient and their families, but the society together. We need to broaden our conception of psychocutaneous medicine, as psychodermatology has evolved as a new and emerging subspecialty of both dermatology and psychiatry. Increased understanding of these issues timely referral, and value of the shared care of these complex patients with a psychiatrist is highly recommended, leading to a more holistic approach and better prognosis in such cases. Thank you.
I think all the presentations are over. Thank you all for the excellent presentation.
So the presentations
Also,
are
we'll
done. Thank
thank
you.
judges.
Yeah, thank you. Thank you. All the presenters actually presented very well, but there are only 3 prizes for it. Everyone has presented very well. So we'll let you know who won the prizes.
Thank you, Varuna madam.
Thank you.
Thank you,
Thank
Varuna
you.
madam.
Thank you. Thank you, Aruna and Sudha.
Thank
So
you.
Sai Krishna.
Thank you, ma'am.
Thank you, ma'am.
Sai Krishna is there?
Think
Sai
is not
Krishna.
there.
No, ma'am,
I
he
think
hasn't
He is
joined.
not here.
Is that? Okay. Or silent is.
No,
Okay.
ma'am, you are the sole judge.
Oh, okay. Sai Krishna is not. Oh.
Yeah, ma'am.
It's okay. So I will send the things,
Yes, ma'am.
this thing,
Please let
names.
Rajalakshmi ma'am know
Yeah,
and
to
we can do that.
Rajalakshmi. Okay.
Okay, ma'am.
Okay.
Thank you, ma'am.
Okay. Right.
Thank
Bye.
you, ma'am.
Thank you.
Thank you. Thank you very much.